complication and improving the surgical skill. Or using the hyperspectral image, in which we overlay the image above the abdominal wall, using a combination of camera with a spectroscope, and to use a quantitative image of tissue oxygenation in this peak, in which we identify the transaction line better than the other tools. Or using the artificial intelligence during the surgery, identifying the common bile duct, the cystic duct, and the vein of the semen 4 to try to minimize the risk of complication during the surgery. And postoperatively is another tool to use it, in which we can analyze the pixel changing and the texture of the pixel, and we can predict the liver dysfunction after hepatectomy. Or another example is to use the artificial intelligence in cirrhotic patients to measure the venous gradient, avoiding another invasive procedure to identify the venous gradient in this type of patient. Or using the radiomic to predict the early recurrence after hepatectomy due to hepatocarcinoma. And the third arm that we can use to reduce the complexity and the postoperative complication is the ICG contribution. We can use it for perfusion to identify the anatomy of the biliary duct for oncology surgery or in liver surgery, as we are going to see after. For perfusion, we can check the hepatojejunal and hepatico-jejunal anastomosis, reducing the anastomic leak in this type of patient, as we can see in the literature, that we could prevent postoperative bile leak using the ICG during the surgery in patient with a pancreatic duodenectomy. Or another complication is a delayed gastric empty, in which one of the main reasons is the gastric ischemia, in which the ECG play an important role, because we can identify the ischemia of the gastric stump to reduce the delayed gastric empty after the pancreatic duodenectomy. Or to identify during the surgery the biliary anatomy, we use the ICG to identify where is located the common bile duct to avoid any injuries during the surgery. The advantages that shown in the literature is easy way to identify the common bile duct, is cheap, and the common bile duct injury could be prevented, and it's not time consuming. This paper in which the fluorescence cholangiography and the intraoperative cholangiography are compared, you see that the fluorescence cholangiography reduce the cost of the procedure, and is faster and less expensive than conventional intraoperative cholangiography. Or in patients with cholecystitis, if you compare with the white light, in the conventional white light, we can identify better the common bile duct and the common hepatic duct using the ICG, comparing with the white light, or in patients with a severe adhesion, again, the ICG could help us to identify more precisely the common bile duct in this type of patient. In oncologic surgery, there are a lot of papers published in the literature who show this is a good way to identify the neoplasm inside the pancreas, that it is difficult to identify. This is a paper in which there are 100% of correlation between the merging and the ECG injection. That's why this is a meta-analysis in which using the ICG for detecting the pancreatic tumors, in which the conclusion of this meta-analysis show that it's a good way to identify the tumor, but it's needed to define the optimal ICG administration strategy. Or in this patient too, it's important to identify, to check the posterior involvement of the pancreas cancer. Using an ECG, we can increase the R0 resection when the pancreas cancer is involved in the retroperitoneum. Or for lymphadenectomy, the lymph node involvement is one of the most important prognostic factors, with multiple routes of lymphatic dissemination. Different meta-analyses show that the standard versus extended lymphadenectomy, the best solution is the standard, because in an extended lymphadenectomy, we collect more lymph nodes, but the extended will have more complication and more perioperative transfusion than conventional without increasing the survival of the patient. So the conclusion is that there is no evidence of benefits of extended lymphadenectomy in the cancer of the pancreas. That's why there are multiple routes of the lymphatic dissemination. So the idea is to identify the specific lymphatic dissemination for each pancreatic adenocarcinoma. I mean the cellular lymphadenectomy using the lymphatic navigation with ICG, reducing the morbidity, and with similar survival rate. It is an example in which we have injected the ICG in the pancreas head in a patient with pancreas cancer. You see how this spread the ICG in order to know what is the dissemination of the lymphatic tissue in this patient. We have done inter-aortocaval lymphadenectomy because the ICG show that there is a lot of fluorescence inside this lymph node, that it is positive after the pathologic report. And in this lymphadenectomy of the celiac trunk, you see how the ICG guide us to remove this type of lymph node, that it is positive when the pathologic report has done. That's why we use the ICG in order to identify the best dissemination of the lymphatic nodes in the pancreas cancer. What about liver surgery? Liver surgery is another tool to be used, the ICG, to identify the colorectal mets in order to reduce the hepatic parenchymal preservation, or to identify the margin between one and another segment using a ECG, or for bile leak after hepatectomy. It's perfectly well used to identify the bile leak after the hepatectomy. And for the conclusion, the new artificial intelligence algorithm, image processing tools, and ICG application could help us to the HPP surgeon to reduce the mistakes in postoperative diagnosis, improving the accuracy, guiding him during the surgery to find the correct dissection plane, increasing the structure identification, and reducing the postoperative complication. Thank you. Next speaker is Andrea Bala from Italy. He's going to talk about from Seville, and how to improve the outcome in minimal invasive colorectal surgery, the role of robotics.
Thank you, Mr. Chairman. Thank you for the invitation to this Congress, and good morning to all. So, how to improve outcomes in minimal invasive colorectal surgery, focus on the role of robotics. So, in the last century, we had several evolution of the treatment, the surgical treatment of the rectal and colon cancer, since the introduction of abdominal perineal excision, throughout the anastomosis creation, the introduction of the transanal surgery, and the concept of the total mesorectal excision, which improves the oncologic results. Following with the introduction of double staple technique, the introduction of the preoperative radiotherapy to improve oncological results. The first randomized control trial in which is reported as the laparoscopic approach improves the postoperative results in comparison to the open approach with the same oncological results. the alternative approach, such as, for example, the radiotherapy as therapy alone for the treatment of rectal cancer. And in this century, the last evolution are the introduction of the robotic approach, the introduction of the complete mesocolon excision for the right hemicolectomy, the introduction of ICG fluorescence, and of the artificial intelligence. So regarding the robotic approach, now we have a lot of data regarding short and long-term outcomes. This is a recent meta-analysis published in this year, in which are included only randomized control trial with 13 articles. We can see how we don't have statistically significant differences between the laparoscopic and the robotic approach. Robotic approach has longer operative time in comparison to the laparoscopic one with the statistically significantly differences, but has better results in terms of conversion to open surgery in comparison to the laparoscopic approach. This is another meta-analysis in which were included patients who underwent extended total mesorectal excision and lateral lymph node dissection, so more complex procedure. We don't have statistically significant differences among the major postoperatively occurrence after surgery, anastomotic leakage, bleeding, or lymph complication, or, for example, ileus or wound complication. We have longer operative time also in this study, but we have better results in comparison to the laparoscopic approach in terms of urinary complication, recurrence, and admission days. Finally, we don't have statistically significantly differences in terms of oncological results evaluating disease-free survival, local recurrence, or overall survival. Again, another study which evaluated the specimen of the surgery, in which it was evaluated the circumferential section margin. We can see that we don't have statistically significantly differences between the two groups, but if we analyzed only the randomized control trial published in literature, robotic surgery has better results in comparison to the laparoscopic one. After surgery, the evaluation of the functional outcome is crucial in the rectal surgery, especially, but also in colon surgery. So this meta-analysis reports as in a follow-up ranging from 6 to 35 months, the low anterior sexual syndrome score is better, statistically significantly better in the robotic group in comparison to the laparoscopic one, and this is the same for the Wexner score. And in special conditions, such as, for example, obese patients, robotic surgery proved to have better results in terms of hospital stay and blood loss, but also in this case with a longer operative time in comparison to the laparoscopic approach. Another special case could be the elderly patients. In this meta-analysis, it was included patients with more than 65 years, but it depends on the study, patients with more than 70 on 18 of the 80 years. The results are not statistically significantly different between the two groups in terms of the operative time and the hospital stay, but and post-operative complication, considering Clavien-Dindo classification from 1 to 4. And another aspect is the use of robotic approach in patients affected by inflammatory bowel disease. In this case, it seems that robotic approach has better post-operative results in terms of total complications, and also in this case, a longer operative time in comparison to the laparoscopic approach. This is not the focus of the presentation, but I think that the brief mention about the ICG fluorescence is necessary. I think that it's clearly demonstrated after about 10-15 years of the application of the ICG fluorescence that this is reduced the anastomotic leakage rate in colorectal surgery. This is a meta-analysis with about 6,000 of patients and 20 articles included. We can see that patients who underwent surgery with the ICG fluorescence angiography intraoperatively have a lower rate of anastomotic leakage rate with the statistically significant differences in comparison to the control group. The same results for about the evaluation, the severity of the anastomotic leakage with the statistically significantly differences between the two groups. And this data is confirmed if we evaluate only the rectal resection, again with the statistically significantly differences between the two groups. This is another interesting meta-analysis with about 11,000 of patients included, in which are evaluated all colorectal resection, and again, we have a statistically significant different lower rate on ostomatic leakage in favor of the ICG group. Finally, the artificial intelligence is a very interesting tools because we have several applications of the artificial intelligence. We can use in colorectal surgery AI in the preoperative management of patients. So for example, for the application of preoperative risk assessment, we can use the artificial intelligence intraoperatively for the anatomical structure detection, for example, or postoperatively for the length of stay prediction, and more and more. And we can use artificial intelligence also for the research gap evaluation and more, or for example, for the pathology assessment. And finally, for the outcomes, such as, for example, the prediction of or survival or mortality. But we don't have, still now, strong results of clinical application of artificial intelligence. So we now, the development of the AI and its application in clinical practice is still lacking, and we don't have data to discuss extensively about the application of AI clinically. So, in conclusion, in the last century, colorectal surgical strategies have improved significantly with the consequent improvements in the results. Robotic approach proved to have a very encouraging results in terms of short and long-term outcomes, including oncological and functional results. But in the analysis and in the meta-analysis that I've shown, we can see that in the sub-analysis, in subgroup analysis, the number of patients, it's very little. So, a warning about this statement. The operative times in the robotic approach continues to be a limitation of the robotic approach, and may be cost and learning curve. ICG fluorescence reduce the anastomotic leakage rate and its related complication, and artificial intelligence could support surgeons in every aspect of the patient management. However, strong data are still lacking in literature to draw definite conclusion. Maybe the future of the innovation is the merging of this technology, or maybe new tools in the future. Many thanks.
Next speaker. Dr. Salvador Morales Conde from Seville, Spain. The title of his talk is Towards Zero Mistake in Upper GI Surgery, New Tools for Intraoperative Guidance.
Okay, thank you very much for the ISMIT and the organization for the opportunity, and also the Spanish Association of Surgery, who collaborate with this in this session today. Well, I'm gonna talk about towards zero errors and how to navigate with innovation in upper GI surgery. So, which are the tools that we have today to navigate towards zero errors? I think that if we analyze those tools, it has to be said that there are three main revolutions in surgery today that we're facing. One is artificial intelligence, the other one is robotic surgery, and also everything related to augmented reality and image-guided surgery. And I think that the combination of the three of them are the ones who are going to make us strong, make us better surgeons to navigate and to be able to solve all the problems during upper GI surgery. Well, if we analyze image-guided surgery and everything related to vision, visualization system, I think that today we're moving into new way of visualizing the surgical field. 3D surgery, three-dimensional surgery at the beginning of the era, when they started like 20 years ago, it wasn't very welcomed by surgeons because you can get a little bit dizzy. It was complex to see. Surgeons do the interaction in the OR, and they were not used to that. But today, I think that the new tools of 3D and the new laparoscopic unit is a change. And you can see today that there is data telling you that 3D improved the depth field, improve the suturing skill, the dexterity, the speed, the accuracy, and it's been shown that really flat the learning curve, have a better performance for the surgeons and also diminish the workload of surgeons. So this is what we have today, and it seems like 3D, the new 3D system of the laparoscopic unit really is helpful, and you can see in upper GI, and in these cases of anastomosis in esophageal cancer, it really shows you that 3D system really reduce blood loss, and also you can get higher number of lymph nodes during the surgery. So there is data telling you that it seems that these complex procedures as esophageal cancer really is a must that you can have in the OR. Also parallel to that, there are some of the good companies of images that decide not to go and bet for the 3D, and they're working on 4K, because 4K give you the possibility of have more light, more color spectrum, and also at the same higher resolution during the surgery. So they think that if you have a good big screen of 4K, you can have as good results as if you have 3D. But today, now they join together the effort, and we have excellent 3D 4K system for this type of procedure that really is helpful during the surgery. But today also, better than having a 3D or a 4K or whatever, now one of the concepts is immersion. Immersion means getting into the surgical field. And of course, the one who moved into that concept has to be, there is a word behind, that is Da Vinci. Da Vinci, the robotic system, really make you go into the surgical field, but this immersion in the console that you think that you are inside the body of the patient, and you really facilitate your movement. And you can see that there is also some meta-analysis showing that if you do this immersion, immersive project during your surgery, you can have also better results in terms of blood loss, lower pneumonia, reduce the morbidity, and also you have higher rate of R0 resection. So it seems that this immersion also is something extra that you can have, not only because of the robot, because of the ability, all the skills that give you the robot, but also because you get immersed in the surgical field, so you have a better visualization. The problem of all these 3D systems, you can see here a team wearing glasses or the immersion, is that you can see that you break one of the team, the interaction between the team. And this is one of the things that worries me, because the problem is that wearing glasses and all this immersion, you lose the connection, the eye connection with the team, and sometimes that could be difficult. Who knows how it's going to be the future? Now I think that there is two movements. One is the immersion, the other one, the immersion, and the extra one that is the metaverse, so you can have the glasses and get into the body of the patient, but also there is new tools in which you can work in 4K 3D without glasses. So this is something extra that is coming, and we will see the impact. And now there is one paper in upper GI in esophageal cancer in which it's been tried this glass-free 3D system, and also it's been shown that with this technology you have higher safety, you have more lymph node, and more operating efficiency. So we are in this process today that we have three roads that we have to take. We don't know which one is going to be better, but of course it's going to be exciting for the future to see which one will be the one for the future. Well, regarding the technology that really lead us to have zero error, the other one is fluorescence with ICG. You have to consider that fluorescence with ICG is something extra. It's not just lighting up the vessel to see if you can have a good anastomosis or not. It's something that is augmented reality, because there is a reality, there are vessels there with blood inside that is augmented by the use of ICG. And I call it biological augmented reality because it's based in fluorescence, but also based in the characteristic of the tissue. So we are moving from this poor quality ICG system, black and white, to superimpose images in which you can work as a standard with your laparoscopic unit and have the superimpose those images. So today we learned from our friends in Korea the way that you inject ICG the day before surgery in the 3 cardinal points of a tumor, 12 to 24 hours before surgery, and then the next day we go into the OR, and we are able to navigate through, for example, in this case, over the hepatic artery. We're able to see where the lymph nodes are, and we are going to be more efficiency because we are able to see if we're leaving behind any lymph nodes. So you can see here that behind the hepatic artery, we were leaving 1 lymph node in that area. And also you can see how we clean the common hepatic artery, and you can see how we are leaving 1 little spot, 1 lymph node on the left that we have to remove with the specimen. So this really make you navigate during the surgery and be more efficiency because you are able to remove all the lymph node during the surgery. The question is, what is the clinical significance of these tools? And you can see that there is randomized clinical trial and even meta-analysis that show you that at least you have more lymph node by using this technology of ICG in upper GI. And we know that if you get more lymph node, you will have better outcomes in terms of oncological outcomes. So it's something to be considered that is very interesting to have this technology. And I feel very comfortable when I really have this technology in my OR. And when, for any reason, I cannot inject it the day before, I feel like a little bit unsafe during the surgery, to be honest. So this is something very interesting. And also, the most interesting thing is that also you can identify an aberrant lymph node area in which there are lymph nodes outside of the standard D2 lymphadenectomy. The first paper in that sense was this from Gianluca Baiocchi from Italy, and he showed that he found lymph node positive outside of the standard D2 territories. And also, in the register of the EARCAT, there is a multi-center register. Surprisingly, there is an important data in which 50% of the patients that were uploading the system, they have a lymph node that get green outside of the territory of the D2. And also, some of them, they have positive lymph node. So it seems that it makes sense. And I will tell you another example of how this technology is going to be used. We published this paper in which there is always doubts if you have to remove the spleen or not to do a lymphadenectomy of the splenic ileum. So you can see here in this case that we published in Cirugía Española, you can see how it is green in the area of the splenic ileum, but instead of doing an splenectomy to take them, what we are able to do is to clean all the green spot in the ileum and be able to do a lymphadenectomy of the territory 10 during a lymphadenectomy in a gastric cancer. And also, we can see, like in this video, the needle node, that is one of the most important discussions in the literature in esophageal cancer, if you have to remove the paratracheal lymph node. And you can see, like in this case, that this paratracheal lymph node really light up. At the end of the day, this lymph node was negative. But I'm sure that this lymph node that is at least 1 to 1.5 centimeter is going to confuse the oncologists when they read a CT scan after the surgery because they see a big lymph node paratracheal. It was negative, but it really gives you an idea to follow up the patient in the proper way. So it is useful to identify this lymph node that light up during the surgery. Well, but now we are in a new era of ICG, and we have the colon segmentation. We use it in several ways. This is a lead orogastric tube that we use to measure in the gastric bypass. So you can see that this technology, when you go to the ICG mode in the laparoscopic unit, you are able to see this bougie and being able to do a proper pouch during a gastric bypass. This comes to me because there was one case in which the bougie came in, bended, and I transect the bougie, and this is a nightmare for the surgeon. So with this technology, I'm able to identify properly and do a good pouch. And also, during a sleeve gastrectomy, I can guarantee you that when I have this bougie in, light up, I'm able to get close to the bougie, and I'm sure that I do a better surgery because I don't leave the fundus behind, avoiding the regained weight by the patient. In this colon segmentation, we have also used it during the lymphadenectomy that I just mentioned. You can see the area of influence of the tumor in the greater curvature of the body of the stomach, and you can see how all the lymph nodes light up in the small curvature. So you can see here in the territory 7. So with this technology, you are able to identify the lymph node, for example, in territory 4. You're able to see them to make and guide you during the lymphadenectomy in this area, and also you can do a nice lymphadenectomy over the artery. And really, it's not easy sometimes, even that you see here where the artery is, it's not different sometimes to identify pancreas, fatty tissue, and lymph node, and the vessels. So this technology tells you, hey, the lymph node is there, and make your life so much easier. And beside that, I can tell you that with this colon segmentation, you had a better visualization. Look at this case. I finished lymphadenectomy, ready to do the anastomosis, and I saw that lymph node lighting up in the mesocolon, almost in the mesocolon, because it was very low. So I removed this lymph node, and this case, it was positive. Like the other one that I showed you, paratracheal, was negative, but this was a positive lymph node. So that gives you an idea that how helpful is this technology. And also, another question that we raised in our group was if it really have an impact, not only in standard patient, but also in patient after neoadjuvant therapy, because we thought that neoadjuvant therapy might block the lymph node, the lymph channel, and avoid the spread of the ICG to do the proper lymphadenectomy. But in this paper, we demonstrate that it was useful with and without neoadjuvant therapy during lymphadenectomy in upper GI. 3D models are also very useful because give you the location of the tumor, which is very, very, very important in upper GI. And the reason is because it is easier to see in the book what is a Siever 1, 2, or 3 to do a esophagectomy, a total gastrectomy, or whatever, and where to do the lymphadenectomy. But that in real life is not that easy. So if you have these 3 virtual models, it will be much easier to know exactly what is the tumor and decide preoperative what type of surgery you are going to do. Another thing that we have to deal in upper GI is the benign tumor and the infiltration and the right location to do the type of surgery. You can see in this large leiomyoma of the gastroesophageal junction, and you can decide if you are able to reach the dissection of this tumor through the hiatus, or if you have to go to the thoracic cavity. So it gives you an idea exactly of what to do. Also, you can have an information about infiltration of vascular structure. The CT scan told us that in this case, all the splenic ileum was infiltrated by this tumor. But when we do the 3D reconstruction and we rotate, we were able to see that there was no infiltration of the vein and the artery. Also, which is very important, to see all the different vascular variation that you could do during the lymphadenectomy in a gastric cancer, which is very important for this surgery. And at the end of the day, the most important thing is to give you an idea for a surgical strategy. You can see this leiomyoma in a flat CT scan, but when you do a reconstruction, you are able to understand better what you are going to do in the surgery. And at the end of the day, this surgery, thanks to your previous preoperative planning, you're able to say, hey, this is going to be easier than what I thought when I observed the CT scan. And this surgery become a 20-minute surgery that you just excise the leiomyoma in this case. And for example, the case that I showed you before, it was just at the end of the day, there was just a transection and a typical transection gastrectomy in this case and become an easy surgery. The other one is robotic. Robotic surgery is a very interesting tool for D2 lymphadenectomy. It's a complex procedure. You need to clean arteries of the area. So robotic surgery allows you to reach the angle that are behind the artery, the territory 8A or the territory 10, because it's very complex to reach this area because you're working in that direction and you have to reach behind them. And the way to reach behind them, I think robotic surgery gives you an extra tool to do a good dissection during D2 lymphadenectomy. And in this sense, you can see the superiority in terms of blood loss, lymph node, and pulmonary complication. And also, one of the most complex anastomosis that you can do is an esophageal anastomosis during esophageal cancer. And you can see in this case how the ability and the skills that give you the robot, the Da Vinci robot, is very important to do this anastomosis. And really, there is another value of using this tool in this complex procedure. Things are coming, and in the future, we will be able to even go farther with the new tools like the SP, and there is some mediastinoscopy that could be done with this technology. Very interesting for esophageal cancer, and also who knows the future because we're facing a new revolution with the new robot today. The other thing is like robotic is linked to image guide surgery, and you can see how we are using also the ICG and the ICG during robotic lymphadenectomy. So you can use your pedal and move back to black and white or overlay or whatever and be able to see all the lymph node and do a proper surgery in our cases. So I think the combination of this visualization system, the immersion, the ICG, and the robot is a good combination for malignant upper GI procedures. Well, the other thing is that this combination of ICG and robotic is useful because there are some papers showing you that the mean total number of lymph nodes is much higher when you use this technology together, and it gives you an idea that if we add technology, we have better results. Well, the last one is artificial intelligence. And artificial intelligence, and I said, is very important. This video that seems just a cholecystectomy it could be part of many, many videos that it will give you a lot of information coming together and being able to have some extra an idea that it will serve the surgeon the possibility to identify how to operate and being able to see the anatomical structure and show that to the surgeon. The final decision will be surgeon's decision, but at least you will have a better idea of what you have in front of you. There is another tool that also will guide you to know exactly how to use ICG for perfusion. I will give you an example. This is a gastric conduit before to do an anastomosis in the thoracic cavity after a gastric and esophageal cancer resection. As you can see here, the anatomical vascular supply of the gastric conduit is totally different because depending on an arcade that doesn't reach the tip of the gastric conduit. So you really don't know which is the safer territory to do the anastomosis. I put some spot there. So the question is, we need information, and I'm pretty sure that for gastric conduits for esophageal cancer, you need this type of artificial intelligence to tell me exactly what is the safe area in which I want to do the anastomosis. Also, one of the nightmares of esophageal surgeon is to identify the laryngeal nerve during the dissection. During the dissection, there is tools that it will guide you to identify the anatomy and identify where the recurrent nerves are. So you see that artificial intelligence, it will change surgery. And also, we are working in the project Eureka, in which we're able to identify using artificial intelligence the connective tissue to identify the surgical plane, to identify the pancreas, and also to identify the nerve of the area. So we are very excited about our experience doing this using this technology. We did a couple cases, and we are waiting for the ethical committee to start moving this project from Japan to Europe and start doing some cases with this technology. So you see that this artificial intelligence is guiding me during the surgery to look for this proper dissection plane. So what we have in our mind as a surgeon is 0 errors. And as an innovator or surgeon who like innovation, we have in mind these tools: artificial intelligence, robotic, and augmented reality and image-guided surgery. But I'm pretty sure that today and the future, I think that AI, artificial intelligence, will be the one that will move forward robotic and will move forward image-guided surgery to do more safe and efficient surgery. Thank you very much.
Salva, let's move to the last speaker, José Antonio Pereira from Barcelona, Spain. He's going to talk about an interesting topic, influence of the artificial intelligence and other instruments in preoperative decision-making in abdominal wall repair.
Oops. Okay. Thank you very much for the invitation to this Congress. It's a pleasure to share a panel with all these good friends. When Juan Bellido called me to participate, I said, obviously, yes, but without thinking, because I didn't know what was the name of the topic. And later, when he told me about the topic, I thought, oh, because I'm a surgeon and I'm not an expert in artificial intelligence, and abdominal wall surgery maybe is the last subspecialty of surgery that received the innovations in surgery. This is my disclosures, my conflicts of interest. I'm from Galicia, and Galician, you don't know if a Galician is going up or down the stairs, but especially because we are very skeptical. We didn't believe in anything if we don't have seen or we have the blood in our hands. And the second one is the fact that I am a boomer. I'm used to use some old tools to work. So as a boomer, I made first a search on PubMed about artificial intelligence in abdominal wall surgery and only found 15 results. The most of them were from the last 3 years and were reviews or opinion papers, anything scientific. For example, this review concluded that there is a significant literature gap on AI in hernia surgery, and implies that more research is needed in the field. Also, most of the research is focused only in inguinal hernia, so we don't have any evidence about ventral hernia. That is one of the most difficult operations to perform. And this is an opinion paper published at and also, the same as the first, only concludes that AI is a promise in the field of hernia surgery and make a table with the potential benefits and associated risks. So after that, I feel a bit sad, a bit worried, because I don't have anything more to say for you. So at this moment, I thought, why don't ask ChatGPT about the questions that I have about this topic? So I made 4 questions to ChatGPT, being very skeptical, thinking very similar to Ted Chiang in this paper published at the New Yorker. And the questions were, how can AI aid to take decisions in abdominal wall surgery? Can we trust in AI decisions? What AI tools do we have available at this moment, obviously? Can AI be used to replace clinical judgment? And this is the results. In the first question about the probably aid of AI to take decisions in abdominal wall surgery, ChatGPT answered that it may be useful to enhancing diagnostic through imaging analysis and patient risk assessment, optimizing surgical planning by providing predictive analytics, 3D models, and measure recommendations, may be useful also to supporting intraoperative decisions with real-time guidance, monitoring, and risk mitigation, and improving postoperative care by predicting complications and personalizing recovery. The second question was if we can trust in AI decisions in abdominal wall surgery. And ChatGPT answered that artificial intelligence has become a powerful tool in abdominal wall surgery. I'm very skeptical about this. But it cannot replace clinical judgment. Instead, AI serves as an adjunct to enhance decision-making, offering benefits in several areas without overshadowing the expertise of surgeons. And I look for an example. And this is an example of an analysis of a radiological image by artificial intelligence made in X, previously Twitter, and shows an error in the diagnosis. The AI fails, saying that there is a pneumoperitoneum in the image of bowel obstruction. The third question was, what AI tools do we have available? And ChatGPT classified in 3 types: preoperative, for deep learning for imaging analysis, computer-aided diagnosis, for example, EDOC or Zebra Medical Vision, 3D imaging and modeling, for example, Synapse 3D, and for predictive surgical planning, as SurgiQuals or SurgiPlan. For intraoperative decision, ChatGPT answered that we have AI-enhanced laparoscopy, as, for example, SurgiBot, real-time intraoperative guidance with augmented reality, for example, AI-based predictive model for recurrence. This is a tool named hernia recurrence. I made a proof, and I was not very happy with that. Surgical simulations platforms as also VR or touch surgery. And for postoperative, we have wearable devices for postoperative monitoring, performance analytics and feedbacks. A very interesting tool. I think this is one of the most useful tools for the surgeons because this is a repetitive task in our job. Natural language processing for surgical documentations. And finally, telemedicine and decision support as either health, body health, etc. The fourth question was, can AI be used to replace clinical judgment? Again, ChatGPT answered that AI is a powerful tool in abdominal wall surgery, improving efficiency, precision, and decision-making support. However, clinical judgments remains essential due to the complexity, unpredictability, and personalized nature of surgical care. So the AI complements the surgeon expertise, but the human element, intuition, and experience are irreplaceable and making final decisions, clinical decisions. So I make this table of pros and cons of AI in abdominal wall surgery. AI maybe could be helpful for difficult diagnosis. Also, could be useful for improving accuracy in imaging diagnosis, for preoperative evaluation of the technique, risk, and prognosis. Could be also very useful to deciding the mesh type, the shape, the size, and the position of the prosthesis, to take standardized decisions, and finally, may be useful also to increase the supervision. But on the other hand, I think that AI could decrease of ethical personalized decision-making and disclaimer. It's very easy to blame others for your decision. It was a decision of the AI. This is a risk in using AI for the decision in surgery. Also cause over-control of the medical decision. You can have a big brother supervising that you are using the AI decision instead of you. Could imply lack of human intuition and expertise. So it also could be not helpful handling unpredictable situations. May induce a loss of basic skills. That is do it for the artificial intelligence. And finally, a mistake in AI could affect millions of patients. In conclusion, science is not fallible if it uses strictly, but this rarely happens if human inefficiency is introduced into the process. If artificial intelligence is created by humans, without enough evidence, AI could be as fallible as humans. Furthermore, as William Osler pointed out, medicine is a science of uncertainty and art of probability, and illness is often exceptional and does not follow established rules. So you have to improvise during a procedure. So you are free to take your own decisions and use the best for helping to decide. I'm thinking like Fernando Sabater, more than artificial intelligence, I'm worried about natural stupidity. It's a much more serious threat. Thank you very much.
Thank you, José Antonio. Let's start with the discussion. We have some minutes to ask some questions to the speaker. Any question for the floor? You have any question to somebody of us? I have some questions for the speaker. First of all, to Andrea Bala. Andrea, congratulations for your talk. It's wonderful, amazing. You have reviewed all the evidence regarding the colorectal surgery in robotic and in laparoscopic approach. But now you have reviewed all this evidence. The robotic should replace in the future the minimal invasive surgery or not? There are two places in which we have to use it, robotic and laparoscopic approach in colorectal surgery.
Thanks for the question. I think that at now, robotic surgery approach should not replace a laparoscopic approach due to the evidence based on the literature. So few studies, few patients, and few evidence. But I think that as all innovation, in the future, maybe the progress of the research and the investigation about the robotic approach could improve definitely the results. But now I think that laparoscopic approach is the best option in most of cases. Maybe the best approach could be the best results with the robotic approach could be in case of invasive tumor in which is needed an extensive resection. But in the standard case, I don't think so in this moment.
And what about the oncologic result in terms of lymph node resected, robotic versus laparoscopic approaches? They're different between both approaches?
I
in
think
terms
that
of
in
oncology?
this case, robotic approach could have a gain in a surgery, to surgeon. The article published referred to extended total mesorectal excision on lymph nodes showed very encouraging results. So I think that in this case, it could be very useful, the use of the robotic approach. Yeah.
And what about the ICG? You are able to use ICG in all of your cases in colorectal surgery? You recommend us to use it routinely during the daily practice using the ICG in all of colorectal surgery?
Well, it's clear that
because the evidence show that this is very important to use it because
Yes.
to reduce the postoperative leakage.
Yes.
What's your idea?
My idea is that we know that the value of the ICG is more in the rectal cancer, in the rectal resection, in the left colon resection, and a few value in the right colon. But I think that it's a very cheap technology, that now this technology is available in almost all operative room, and very fast technology, so I think that it's mandatory to use it. Even if it's useful only in a number of patients, but we don't know how are these patients, so I think that we have to use it.
We have to use it in every
Yes.
hospital
In my
in
opinion,
our
yes.
country.
Yeah.
Thank you.
To you.
Salva, congratulations to you with your talk. One of my question is if you think about the image in surgery, what do you think about the advantages of using 3D or 4K in patients with gastric cancer? I mean, if you have to choose between 4K and 3D, what kind of image you prefer to use it in this patient?
Today, I'm using 4K. This is what I'm using. And the reason is because the combination of 3D with ICG is not perfect today. And I feel comfortable 4K, and I want to have a good ICG to do the lymphadenectomy.
But your idea is to use both, right?
Yeah.
Depending on the patient?
Depending on the patient, no.
Depending of the tumor they have to...
Oncological procedure, for me, today is ICG. It's ICG to do the lymphadenectomy. And there is no way back. I mean, I do today 100% of my cases with ICG. And the combination of ICG lymphadenectomy and the 3D is not feasible because you have to switch to different units. So you need, it's not comfortable to do it. And that's the reason why I use in 4K, because I want to have the ICG. So 3D today is not an option because the technology doesn't allow me to use it. That's the reason. So in the future, if I'm able to do a good 4K, 3D, ICG, and if you take me off the glasses, that will be the way I say it. But I need the ICG to do it. So it's my first priority.
Okay. And another question is using an ICG in lymphatic navigation in gastric cancer. What's the role of lymphadenectomy outside of the conventional lymphadenectomy using the ICG? You see that it's important to use it to remove those lymph nodes outside of the conventional lymphadenectomy that could be positive after the pathological report? Because it's difficult to...
Well, one of the things is like, are we doing a good D2 lymphadenectomy? That's the question. Because most of the people say, I'm doing a D2 lymphadenectomy, but they're not doing it. And I've been having that conversation with some residents. So the question is, if we go to the ideal world in which you really do a D2 lymphadenectomy, and I have a lymph node out of the territory lighting up, I go for it. In my experience, I've done it several times, but only one case became positive, the lymph node. Who knows if I saved the life of that patient? And in fact, I operated that patient in April, and I saw it on Tuesday, and she's perfect with a new CT scan with no recurrence. So it's worth it if I get one patient out of whatever. But the other problem is, that is what I'm saying, I see some lymph node that I left behind, and you can consider that it's outside, but it's not outside. It's that you didn't do the proper lymphadenectomy. Because sometimes, for example, when you do the territory 11, that is the splenic artery, there are so many curves, and you can have lymph node high behind the pancreas, And this is still D2 territory, but the thing is like behind the
It's
pancreas.
D2 lymphadenectomy, not
Yeah.
extra.
It's not
outside of
external, so you have to well define what it is. And this is one of the things. So for that reason, what I think, beside that you get some lymph node out of the D2 territory, the question is that the lymphadenectomy with ICG make you a better surgeon because you do a better surgery and a better D2 lymphadenectomy. What I'm surprised that I still, I believe the literature, but one of the things, if you go to the register of the IRCAD, you see that there is almost 50% of the cases that the people upload to the register, they have lymph node out of the D2 territory. And that's the reason of the introduction that I gave to your initial answer, that I have my doubt if they're doing a proper...
They don't do a proper lymphadenectomy, we think.
Yeah.
Good. Thank you. And José Antonio, it's a question for you. That's the question? Yes, please.
So you are endoscopist, right? And well, I have good relationship with the gastroenterologist of the hospital that I work. And the only condition that I have to do a D2 lymphadenectomy guided is not to do it on Mondays. Because even that I get along with them, they're not going to come on Sunday to inject the ICG. So since this is the main rule. So beside that, I'm used to work in 2 centers. And if I talk to them and I organize with time 2 weeks ahead, and I get along with them, and they inject it the day before without any problem. And there is an extra value. When you go to the OR the day after, and you have in mind what you see in the gastroscopy the day before, again, you are a better surgeon because you know exactly what you are expecting to have during the surgery. So I think it's a very good tool to be ready for the surgery next day. It's like your preoperative planning that I show, but in your head you have that. So there is no issue related to that. And also, the other thing is like to be with gastroenterologists because you're used to do tattoo for the colonic cancer, and you tattoo, and you don't care if it's much or less. Here has to be the proper quantity, and you have to stop them and say, enough, enough. Because if you go too far and you inject too much ICG, at the next day you don't see anything. So it's very important to guide the gastroenterology to be with them. There is some voice in the world who should do that, if it should be the proper surgeon to do it the day before. I don't need to do that. I love my gastroenterologists, and I'm still going to work with them to do the ICG injection the day before.
Okay, thank you. Thank you, everybody. We don't have much time, and we close this session. And thank you to the organizing committee for inviting us to this meeting, and thank you. Thank you all.
main sponsor, and at the same time he just decided to give us as his membership fee $10,000 a year. So I would appreciate if you all would do the same. Anyway, so John Abel is a fantastic person and personality. He's what we want to have in this lecture, a medical technology entrepreneur, pioneer, who really changed things. He was working with clinicians together. He bended the catheters, the very early catheters they were using, and he also published a very nice book, A Balloon in the Bottle, because he compared the work of interventional radiology to building a ship in the bottle with long instruments, and very successful. Boston Scientific, you may know, they were suffering a bit, but then they came back to the market, and they always had, compared to Johnson & Johnson and other companies, despite their size, highly innovative products. This also made them suffer a bit compared to others, not the Me Too product. Yeah, we are very happy to have a very distinguished speaker, whom Heinz Lemke would introduce, and I hand over to Heinz. Thank you.
Okay, thank you, Andreas. Well, it's my great pleasure to introduce to you today Carlos Amato, who will give a presentation about the operating room of the future, in particular, specifically the central command suite and the evaluation of this and application of this in clinical environments. I should say a few words about Carlos. Carlos has been associated with the CARS Congress for quite a while, and this lecture here today actually is a cooperative attempt between ISMIT and CARS to do something jointly. CARS has also been the host of a few lectures given by ISMIT during the CARS Congress. The origin of the content which Carlos will talk about partially comes from a think tank the International Foundation of CARS has been organizing for quite a number of years now, and Carlos has been a member of this. The topic of the think tank was model-guided medicine applied to the operating room, but also to diagnostics in radiology and also into other aspects of surgery. This think tank is somehow differently organized than usually think tanks are. We have got 10 members in the think tanks. 2 come from surgery, 2 from radiology, 2 from engineering, 2 from computer science, 1 from architecture, and this is Carlos, and 1 person is there with common sense. And that is, by coincidence, a lady who has been working with CARS already for some 40 years. So in these think tanks, we are trying to figure out in a very interdisciplinary, open discussion how model-guided medicine and artificial intelligence will impact the clinical decision-making. And I think we can look forward to an interesting talk now by Carlos, who will, to some extent, also sum up what we at CARS try to engage in, that is interdisciplinary cooperation. Carlos.
Let's find the presentation here. Here we go. Great. So thank you very much, Andreas and Heinz, for the introduction. It is an honor to be here in company of such great minds and a lot of people that I greatly admire and I have followed for many years. And thank you also to the conference organizers for inviting me to present some ideas that we've been working on for quite some time about the hospital of the future. Thank you, Juan, Alberto, Margallo, Francisco, and the rest of the committee. And when I was invited to this conference, I kind of wondered, why would they have an architect here? And I think Juan, in one of his emails, said this presentation is an example of interdisciplinary collaboration between technical and clinical worlds towards the enhancement of healthcare. And that really resonated with me because everything that we have been exposed to the last few days and everything that's been discussed needs a space, needs a stage to happen. And I gladly accepted the invitation. So I was given an hour, which is quite a lot of time. I'm going to keep this to 45 minutes and hopefully have some questions and answers. But as Heinz said, this started a couple of years ago. The incubator for this idea, for this talk, originated as part of an ongoing study on the hospital of the future, which includes the operating room of the future. And on this slide, you see some of the primary objectives of the talk. So this is what I'm going to be discussing with you. First one is, as Heinz mentioned, what will the impact of artificial intelligence and model-guided medicine have in the operating room of the future? Now, I get to design these operating rooms. I'm an architect. I'm not a computer scientist. I'm not a doctor. But for the last 37 years, I have spent a lot of time in operating rooms and in hospitals watching what the clinical teams do, how they do it, what they need, and so forth. And they need space, and it's constantly changing. So my particular interest here was to focus on AI and model-guided medicine. What is it about that is going to change the architecture? The second point is all of you that work in surgery remember the old control desk, right? When the surgery suite has more than one operating room, you usually have a control desk. And that has been transforming itself over time to the point where now we recognize that you need, and for the lack of a better term, we titled it Central Command Suite, as a critical component of the surgical platform design. Third is we recognize that what you do is so complex that a space to bring interdisciplinary teams together to collaborate is essential. This cannot all be done digitally and remotely. You need places to collaborate in person. The other thing that we're exploring, and I'll get into it in the latter part of the presentation, is we are trying to figure out how to make the building a part of the care team. So how intelligent can a building be, an operating room, or any part of the building? How can ambient intelligence be incorporated so it becomes part of the care team? And then finally, we recognize the Central Command Suite must take care of or connect with patients that are no longer in the hospital, they're at home, but they're still your patients and they're in remote locations, so a critical component. So we started discussing this in Germany. Everything that we talked about immediately in my mind becomes an image. And the image on the center at the top was one of the first concepts, and that's not AI generated, that is a real 3D model that we built of how we imagine one of the places in the Central Command Suite to bring teams together. So last night, I'm actually still jet lagged because there's a 9-hour difference with California. So I was asking myself in the middle of the night, why am I here today? Why are we here today? And then I said, well, that kind of applies to everyone. It's not just me. The title of the conference has the word innovation, right? So innovation is inspiration. The fact
that we're all spending time together talking about stuff, right? I was at the castle yesterday talking to a surgeon that is passionate about tennis, and we're talking about plants and all kinds of things. That's a wonderful thing. So that fuels inspiration, innovation, and collaboration, and frankly, enjoyment, right? This is something that I keep reminding myself why these conferences are so important. But getting specific about the central command suite and surgery, Dr. Dirk Willem, who is on the first slide as a co-author of this work, one day said, there's an analogy between what's happening in surgery, especially when you scale it up into a large platform, and the Pentagon. And the analogy is that you need a center of intelligence to coordinate everything, model-guided medicine, artificial intelligence, anything that has to do with pre-planning surgical cases, interpretation of radiology images, and so forth. So there needs to be a central place. But at the same time, we also need to decentralize component of those intelligent elements. And those could be, for lack of a better analogy, those are bases that we have around the world. So that was a kind of a powerful analogy, and I want you to keep that in mind as you think about surgery in the context of the hospital of the future. So this is a slide that he put together where we look at data coming in on the left side and the creation of models, and then those models are processed, but at the end of the day, you need to execute the model. Execute as in, I'm going to perform surgery on a patient, and I need to supervise that case, and by the way, I have 70 ORs, and the same thing might be happening on 2 or 3 ORs. So how is all that going to get coordinated, right? So he proposed thinking about that because along that patient pathway, so all the steps that you go through when you take care of that patient, from the moment the patient feels they need something to when the surgical decision-making kicks in, you need staff to guide the surgical process, et cetera, et cetera. So all that begins to generate a great deal of data that goes into diagnosing the case of the patient. So some of our clients refer to it as the diagnostics odyssey. And Dr. Kandarpa, who's here today, he mentioned twice already in 2 days the diagnostic cockpit. So we got to figure out what's wrong with this patient, right? So that's the initial phase. But along that journey, there is a constant exchange of information. And frankly, a traditional hospital was never designed to handle and manage and organize all that. So the specific example here is obviously surgery. And, you know, we looked at what are the components here from the procedure itself to the folks that are getting the patient ready in the pre-op area to the PACU area after the procedure and so forth. Do we have the right surgical team in place, right? Who's available? How are the ORs prepared before the case and so forth? So there is an incredible push to see how AI can help set things up, and there was an interesting video yesterday by one of the presenters that shows what happens before and after the case. So how is AI going to organize all that? So we came up with general requirements and key functions that could occur in the central command suite. Now, this is a partial list. This list could have 50 different components, but it highlights some of the most critical functions. Obviously, pre-procedure planning, right? And again, you have to remember what the traditional typical hospital has. There's a control desk, that have gone from a marker board or a chalkboard with things written there, so-and-so is in OR number 12, and this is the name of the patient, and this is what we're going to do, to very sophisticated digital displays with all kinds of information. So a lot of people gather to talk about what's going to happen, but the space is usually inadequate. When I go to these places, it's not designed for that. So pre-procedure planning, procedure simulation, and patient modeling. Now, there's a big debate as to where that needs to take place. There are two, I was telling Heinz earlier today that there's two groups of people. Some people think this should be centralized. Some people think it should be decentralized. That's why you'll see that the solution that we came up with for the central command suite is very modular. So it says, these are the things you have to think about. And I'm not going to read through all this. But if you design it in a modular way, and somebody says, okay, the robotics engineer and automation for the robots that are cleaning the ORs, I don't really need that to be immediately adjacent or inside the surgical suite. It could be someplace else. Okay, so that module is designed and dealt with accordingly. But there's a whole list of things here that they're nowhere to be found in a traditional hospital, and we keep building the same thing over and over again. So that's why this, the material of this presentation became so powerful and caught the attention of some big projects that we're currently working on right now, and I'll show a case study a little bit later. We all know what happens in today's OR, what the communication challenges are. Traditional hospitals were designed on a department-by-department basis. The Department of Radiology, the Department of Surgery, the Department of Pharmacy. And this is a silo connected to a silo, and sometimes disconnected completely because you're on a different floor in a different building. One-way communication, workforces that don't communicate with each other, a lot of problems handing the patient over from one group to another group. So what happens when the patient goes from the PACU to ICU and so on. So each of these events could be improved with the creation of a space where we all get together and talk about how to make it more efficient and streamline it. So as part of there was a paper written about this, and we spent quite a bit of time trying to connect the central command suite with the patient journey, because at the end of the day, we're doing this to deliver the best possible service to that patient that has shown up for surgery, right? So we place the patient in the center. That doesn't mean that the patient is the center of everything, right? And Heinz reminds me often that as a computer scientist, we're not thinking about the patient. We're thinking about how can we write the best model to take care of the patient. But in this case, we're building a hospital to deal with the patient's journey. So I place the patient in the center to organize the conversation and to say, okay, some activities, what you see at the bottom of the chart, will occur in the hospital, but then there is a whole bunch of other stuff that occurs outside the hospital, and the central command suite is what is going to hold it all together. So there is a physical component, and then there is a virtual component. So, for example, the patient is going to be prepared to get the surgery. So there might be a personalized AI assistant that gets everything ready before the patient arrives at the hospital. But when the patient is in the hospital, during the stay, during the surgery, the recovery and the diagnosis and examination after the surgery, et cetera, through discharge, the items that are written here in red, all that happens in one location. From there on, you have to stay connected to the patient. You're going to monitor that patient at home. That patient is going to be rehabilitated either at home or somewhere else. But the idea is that you're always connected to the patients, right? You're done with the surgery, but it's still your patient, like it or not. So in the design of the Central Command Suite, we took that to heart, and we recognized that there's physical and digital components to the conversation. These are some of the principal planning considerations. It can be centralized or decentralized, as in virtual or digital. I mentioned that. Physical location, this could be local or it could be remote. If it's virtual, the question then is, who's going to manage it, right? So, yeah, we're going to use your information, but who are you and why are you sending me this? So who's organizing that? How is it connected to the different parts of the patient journey? And then eventually we have to write a program, right, to determine the size of the Central Command Suite. And we place the Command Suite as part of an ecosystem. We call it a suite ecosystem. So it could be very small if you have a rural hospital with, say, 4 ORs or 6 ORs, probably not a big deal. It could be medium or it could be very, very large, right? I'm working on a project right now and they have 156 ORs. That's big, right? That's a nightmare, right? And 42 MRIs. So the amount of information is just crazy. Here we listed the functions, and what's perhaps even more intriguing is the location, because you have all these different locations, on-site, remote. Oh, and by the way, I'm in a different state, and so forth. And then the organization of the strategy for all the information. So before we design anything, what we do is we try to understand the flow. What is it that we are designing, and how do we place it in the context of the patient journey? So this is a simplified version of 3 things. On the top line, you have the patient journey steps, starting at home. I think there's something wrong with me. I need to go to the hospital. I've never been to the hospital, so that process started. Data, right? So where is it happening? What technology do you need? What space do you need? You're not in the hospital, so what is it exactly that's happening at home? Then as you move forward, you move to the right of the chart, the environment changes. So the interaction and the location, what's on the bottom line, changes. So you might be asked to go to a medical office building, right? And then to the hospital and so forth. But what's important is that at the bottom, there is something here that is controlling all the intelligent constantly all the time. This chart, which actually was Dirk's idea, Dr. Williams' idea, is kind of an interesting way to look at that problem. Because if you think of the patient in the center, right, and you have all these streams, we call them swim lanes or streams of activities. One is staff management, you got patient modeling activities, you have spatial resources. Where am I going to do the surgery? Is that OR available? Does it have the right equipment and so forth? So when you run the patient through that, if you move the patient across that, if you see at the top of the screen, the intensity of information changes constantly, and it peaks when the patient is in surgery. That is kind of an interesting way of looking as an architect and with our engineering team to look at the problem. Because depending on where you are, the physician is in the car driving to the hospital, needs to know something about the surgery. They're going into a 6-hour surgery and they need something. So what technology, where is that phone going to ring? Who are they going to talk to? Does the person who is taking the call have the right information to deal with that? And the surgeon is in the car. Now they get to the hospital, so that constantly changes. So the architecture, the technology is constantly changing. It's like a moving target. I talked about why are we thinking about a central command suite? Well, if you have one OR or two ORs, not a big deal, you don't need it. But if I'm going to build 70 ORs in a new building, that's a nightmare, right? So who is managing all this and from where? So I'm sort of justifying what I'm about to show you. And this it's another way to illustrate the problem. So it'll be centralized somewhere, but you're controlling all these different departments and functions, imaging, emergency surgery, and so forth. So the second part of this is, how do we resolve this? So a toy that I loved when I was a kid, my father, who used to travel to Europe 3 times a year, brings a Lego back from I think he bought it in Hamburg. And I was fascinated with this, and I still have it, and I still play with it. And it's wonderful because it's architecture on steroids, right? Everything we do when we're planning a new hospital, it needs to be modular, it needs to be flexible, and so forth. It's really this concept. That's why this toy is still so popular. Lego system means that all elements fit together and can be used in multiple ways and can be built together. So we said, all right, we get that. That's how we plan. But let's apply it directly to a concept for a central command suite. And what you see here is the original idea. This was done during the think tank with Mario Sipko. He did the original sketch. So credit to him for sitting down and sketching this. And then from that, I worked on the computer model on the left-hand side. And what I was hearing was, we need a central space. We need a central area. But then everything around it it's going to be a variation of sizes, shapes. It could be 80 square feet, or it could be 200 square feet. We don't know. So this center is surrounded by different types of planning units. Each of those units has its own functionality, but it follows the Lego rule, which is the rule of modularity and flexibility, and you can interchange them. This animation shows how, as an architect, I think about constructing that model. So you start with a grid, right? You're going to have columns, and you have to decide what the spacing is, and then you start adding these components. And what makes it even more interesting or challenging is that it could be one floor or it could be multiple floors, like you see here. So the temptation as an architect is always to have a final solution for a problem. But when you're working for 30 different health systems, they all have very different needs. So that's why it's a system, it's not a solution, it's an idea. And that's where I connect this with what Heinz said at the beginning, which is the interdisciplinary nature of these conferences. Because he's given me an idea that then I can pass along to all kinds of different people to take advantage of that. And that's a wonderful thing. So in this particular case, this is a little bit more of detail added to each of those components. So I could have one of those functional modules could be a patient triage unit, either virtual care or in person. And that could be a group of nurses working with patients that are remote in rural areas or wherever they are, video conferences and so forth. In another module, you could have a surgery planning unit that is mostly data-based, and they're working on interpreting images and creating a hologram. Another one could be 3D printing. That keeps coming up. Every single project is like 3D printing, we need 3D printing. So we need the models, we need the printing, and so forth, and so on. So So what we did is we started organizing all this, and we started testing. We said, okay, let's look at what a staff management area could be. Now, again, these are artistic representations of spaces. It could be bigger, it could be smaller, it could have more people, less people, and so on. But it goes to show, remember the Lego board, right? And you're adding all these pieces, the parts are different colors. Each of the color has a function. So you can have a decision-making unit, a whole bunch of people in a room that is open. There's daylight coming into the space. It feels modern. It feels minimalistic. And there is this sort of collegial environment that is designed to make people interact. You could have a patient modeling area, right? You're building a digital twin. You have your planning teams looking at the procedure in detail and so forth. What is that going to look like? And so on. Data analytics. This could be a little bit more of a kind of a technical, a technical room as we know it today, mostly computers and people looking at screens. There is a big push now for sustainability. You talked a lot about this. Sustainability needs to be controlled also, right? Where are the instruments going, why, et cetera. So this is something that we're going to study in quite more detail in the future. Staff, big deal. Do we have the right people available for that procedure? The procedure went 3 hours long. What do you do, and so forth. So there are people monitoring this and looking at this and making sure that everything is available when needed. Supply management. This has to do with anything and everything that you will use in the surgical suite, anything from a case cart to pharmaceuticals to disposing waste, et cetera, et cetera. Somewhere there is a team of people making sure that that happens on time and properly. So this actually took quite a bit of time. These are not AI-generated images. Architects are using a lot of AI images right now. These were created specifically for this. So we looked at the design based on the axonometric drawing that I showed in one of the previous slides. And we're like, okay, so what are we going to put in here? So how can we combine, say, a surgical planning and a surgical imaging planning team with the large displays and private meeting rooms and so on? And by the way, somebody said, wouldn't it be nice if we had direct view of the exterior of a nice garden and so on? And it's interesting because I'm standing here and I don't see the audience very much, but I see daylight, and it's wonderful. It's kind of a nice reference back there. So these guys were asking for the same thing. It's like, yeah, you know, we're in these rooms. It's dark all day, you know, we're looking at screens. Show us daylight, show us trees, and so forth. So this is one of those attempts to interpret those desires. This is not Carlos's idea. This is listening to teams that are saying, I need this, I need that. I need to be able to see what's happening in that room. Don't put a solid wall. So we're showing you how we interpret those spaces. That central space that is so critical, somebody said this could be like the new version of the tumor board. Who would be in there and why, and what would they need? So they might have a digital twin hologram in the middle that disappears when you don't need it, and then right behind it you have screens showing other aspects of, again, I'm not a doctor, but I can design where the screen is going to go and the right lighting for it. But what's interesting is that there's like a collaboration, central collaboration space where people are together. They're all from different disciplines, and they're discussing what it is that's going to happen at that moment in the patient journey. So again, access to natural light. Something I learned recently, which was really, really important. So for the last 3 years, I've been working on a large project for the Mayo Clinic. They're building, first they call it the Hospital of the Future, and then they changed the name, Unbound Bold in Rochester. And the chief of surgery said, when I come out of the OR, I do not want to see a blank wall, a long blank wall. I need to see daylight. I need to see people, and I need to see light. So he dropped like what became one of the most important planning principles for the whole exercise. And that's hard, because I will show you a plan when you have to, these operating rooms there are so many of them that it's very difficult that when you come out of the room and you do this, you see light. In some cases, you're not, unless you have a long strip of spaces. So the importance of daylight and connection with nature cannot be understated. And the other thing is, I want to see people. I want to see teams working together. Very, very, very interesting. He didn't start with, when I do pancreatic surgery procedures, the room is too small. And no, he didn't. He knows that we're going to take care of that. He started with kind of a more emotional side of the conversation. Here's another view of that central command suite. These would be planning units, 3D printing, support, amenities, another big deal. I come out of the OR, 6 hours in the OR. What happens next? So where am I going to talk to the family? Where am I going to go later to take a 15-minute nap? Where can I get food? And so on. So amenities, looking back, how programming has evolved over the last 30 years, staff amenities have become a huge, huge priority right now, for all the right reasons. My wife is a clinician, so she tells me that every day she will say, well, you know, the place where I eat is too small, and it's dark and so forth. This QR code, and I'll send you the presentation, but this QR code put you inside the space. This is a 3D model, and you can go into the space and enter the central command suite. So I want to show you a couple of images of how this idea is materializing in the real world. And I copied the slide on purpose. Innovation, innovation, inspiration. Yesterday, architecture has a direct impact on how you do what you do. And this is a perfect example. I was sitting all day here yesterday, listening to presentations and so forth, and I look at the program and it says 1 hour for lunch. I never get an hour for lunch. I'm lucky if I get 10 minutes, 15 minutes. But what was really interesting, and the reason why I put this there, is because I noticed that in front of you, you have a table, a little fold-out table. I'm like, that's kind of cool. So I pulled the fold-out table. I'm like, okay, I got time. I got the architectures giving me something. So these sketches were done yesterday in between sessions, right? I'm starting to sketch, and I'm showing you this because architecture and what you do is directly connected. No matter what you do, you're building a model or you're writing an algorithm or whatever. So I started sketching this yesterday, and it's kind of small, and you won't, but I want to explain to you what this is. Let me see if I can. You won't see my cursor. But on the right, on the left-hand side, this is a hospital of the future. So you have a drone. Remember, innovation. Innovation. We need to build a hospital with things that have never been done before. Not just to say that it's got things that, but things that are meaningful. In this case, we need robots that do the things that nobody wants to do. So you have a drone landing on a drone pad, and there is a zip line with a payload, right? I'm talking about the image on the left-hand side. And the payload is being deployed down a shaft into the building, down to, say, level 4, where the pharmacy is. And the image on the right, this image right here, shows a little door that opens, and the payload is picked up by the guys in the pharmacy, right? And it happens to be a pharmaceutical product that was not on site. It just arrived from the airport, and it took 1 minute and 54 seconds for that drone to come from the airport to the roof of the hospital. And this was done right there yesterday, because I just happened to have a little table to draw, right? And then I sent it to my colleagues, and they said, the mechanical engineer called, and he says, I love your sketches, but you know what? In Rochester, it's minus 18 during the winter. So you need an airlock, because we can't open a hatch on the roof and get minus 18-degree air blown into the building. Oh, okay. So how can we do the airlock? The session in the afternoon, the 5-minute break, another sketch, and so forth. So the point of this is the following. If you have the right space, you're going to do things that you never thought you would be doing. That's the point of what I am explaining. In this case, is that little table. Another example of that, long flights, jet lag, and architecture, right? So these are airplane sketches, and I wanted to show them to this group because, you know, Heinz and I have been talking about the operating room of the future, and part of the operating room of the future is what happened in the past, right? You need to understand what happened and where. So long flights, jet lag, and architecture have a direct connection, and this is what happens when you have a lot of time. And then it becomes real. So this is a little project we're building for the Mayo Clinic. It's in design right now. Up until 6 months ago, I could not show these images. These are public images right now, but I keep going back to the same thing, which is getting people together to innovate and to do great things. And that little sketch with the drone that I was sketching here yesterday, that drone is landing on top of those 2 buildings. This is another view of the complex. It's quite large, as you can tell, and you know, it's impossible to explain in a couple of minutes, but modularity is front and center. The idea here is, how can you design a facility that can change constantly, right? Where the functions can be moved around, where a floor with operating rooms can be turned into a research floor, and a research floor can be turned into a patient floor, and so forth. So there's this dance, you know, that I've heard a lot about modeling and 3D models and 3D printing and so forth. In our world, it's the same thing. It starts with an idea. It's usually a human idea, not AI. Things like this. What is the tumor board of the future? What do we need there? And then there's a computer model built for it. Maybe there is a department-level command center, a small area for these guys to do their work, and so on. So this is kind of a glimpse. First time I show this. This has not been shown before, but these are examples of what can happen when you invite an architect to a conference that has nothing to do with architecture. You come up with things that then you can turn them into reality, a wonderful thing. And it's specifically in surgery, the goal is to slowly veer off the course of today's chaotic ORs. You showed yesterday, somebody showed the challenge of robotic consoles in the OR, stuck in corners, bad lighting, cables on the floor. You know the story. How can you begin to improve that? Does it make sense to build an OR control room right next to the procedure room, adjacent, and so forth? Another thing that I wanted to show, which is going to have an impact on operating room design, is the following. And this is, this is something that Dr. Giulianotti, Piero Giulianotti, brought to my attention about 1.5 years ago. The individual pieces of equipment that are in the operating room, there is a tremendous effort to begin combining those. Now, how real will this be is yet to be determined. There's a prototype that's being tested right now and so forth. But the idea, again, is to veer away from the chaos that you see on the top left corner here into a better organized, more, he called it, this is a medieval environment. So why don't we start with the equipment and try to integrate all these pieces into a modular design platform. Why? Well, we might be doing this in faraway places. Again, the connection with the central command suite. If you do this in a faraway place, how are you going to control it? So the image on the left, which most of you have probably seen, this was published 2 years ago as part of the Spaceflight News International Space Station. What happens if we have to do a procedure on a patient far away? So central command suite, maybe you need somebody from Johns Hopkins or some other place to guide the procedure. We also did, and this is also thanks to Heinz and the CARS organization, one of our exercises, what might the dream OR of the future look like? So extensive modeling to change the look and feel of the OR into a more compact, simplified, integrated environment. Maybe a central layout, and who knows? This could be done far away too. So I know you're trying to take a photo, so I'm going to back up so you can take the photo. This you can do when you have a small audience, which is great. It's perfect. Conclusions and recommendations. Incorporating a central collaboration and command suite in a future hospital that leverages AI, personalized model-guided medicine is essential. This is not an option. This is a necessity. This is no longer something that, well, maybe I do it, maybe I don't do it. For all the reasons that are listed there under the heading number 1. And it's being implemented. And I want to conclude with something that Heinz said at one of his wonderful lectures. This whole exercise might help us discover the truth and trust to build model-based wisdom and improve what we're doing. Again, these are the QR codes that will put you inside the presentation, inside the central command suite. So I'm happy to discuss it further. And thank you again for inviting me. This is a real pleasure, and I'm happy to take some questions. We're right on time. So, yeah. So thank you very much. Appreciate it. Any questions?
Yes, thank you very much, Carlos. We have a question over there, please. Yeah. Please take the mic, no, so that we all can hear it.
Joris Jaspers, I work as an engineer in the University Medical Center in Utrecht. We face the same problems, overcrowded ORs with all kinds of equipment. And I really like these futuristic pictures, but we also saw these pictures 20 years ago and it still is a mess in the OR. So perhaps the solution is more in the logistic part. Why do we store all these equipment? Because if we put them in storage rooms, we are lost them and we have a lot of time searching them for the planned surgery. So, and the technology to improve that is already there. We use now track and trace systems to really know for the scrub nurses who prepares the room, where is the equipment I need for next procedure, what are the preferences of this surgeon coming in, and then within 10-15 minutes they can update. It's not high tech, it's not future proof, but it's working. So I really like the far ahead future, but we can act now with more available technologies.
Well, thank you for your comment, and I take that more as a comment than as a question, but it's very difficult to change things, and especially when you're doing it well. Right? When you think you're doing it well, I mean, the patient recovers, you did a great job, and so on. So this is gradual, but in our profession, we listen to people talking about what they would like to see improve. Some things are real, immediate, some others are going to take a long time. But because these buildings are built to last, whatever, 50 years or more, here in Europe, a lot more than in the US, our job is to future-proof it, right? And you might have a chaotic environment day one, but if you build the right infrastructure, the right chassis, then over time you can evolve. It's like a stage in a theater, right? You don't have to destroy the infrastructure, you can change it. So that's one of the purposes. And you're absolutely right. That's one of the biggest challenges, because if I show this to the surgeons that I'm working with right now, they're going to go, oh, no, I can't use this because this or that or whatever. And then I'm going to say, well, what about the last 3 months that you've been telling me you want to change this, this, and that? So it's an ongoing, beautiful dilemma.
There's another question over there. Or comment?
I'll start with a comment by saying, you know, obviously we're very happy with your abilities to design things. I'm Fadi Charbel, I'm the head of neurosurgery at UIC. So we've met before, and I was singing the praises of your work with the SITL lab, which won the award. So that's my comment. My question is a simple one. So you're sitting there and you're drawing. What are you drawing on? What are you using? Is this a pen and paper, or do you have a? Really?
Yes, it's. You know what's really? It's this, and this. And what's interesting?
Not an electronic something.
No. It's this, and then it's an iPhone photograph of the sketch sent to a team of 50 people, and they're going, this guy is still drawing by hand. I'm sending this to 20-year-olds, right, who are computer wizards, and they do these beautiful models and so on. But there's something about architecture and design. You have an idea, you see something, and the way it flows to this, that you can't do with a computer, because I can't tell, I can't tell if that computer rendering was done by John or by Mary. But when I see a sketch from one of my colleagues, I know immediately who did it, because they prefer a watercolor or whatever. But the answer to your question is, it's just paper and pencil.
It somehow makes me feel good. Thank you.
You're welcome.
Any other question from the audience? I have one very quick one, perhaps it's a very long one actually. You mentioned very often the need to accommodate groups of people coming together in your operating room, teams and so on. But as we are moving away gradually from analog communication between people towards digital communication, the digital communication people become part of a bubble almost at the end, you know? So they don't need, it appears to me, the sort of analog communication. What impact will this have on the architectural design of the hospital and the operating room? Have you got any thoughts on this?
So, yeah, this is the interplay between physical and digital. That's not going to change. It goes back and forth, back and forth. So I was observing a case at a hospital in Naples recently, open heart surgery. The team met for the pre-case debrief. They were in the OR, and there were people setting up the OR at the same time. Why? Why? Because they didn't have a space right across the corridor, adequate space to do it, right? Mm-hmm. So I don't know that I have a good answer to your question, but all I can say is that it's like AI. Will AI replace architects? No. It's going to be used by us, but there will always be this sort of back and forth. And the same thing goes for analog and digital and in person. You're going to need, as you move through that journey, I'm going to need to be right next to you at moments for some things, and then you might go away for days, and we don't need that personal interaction. It will be digital. So,
okay, thank you.
Yeah.
I think it gives rise to many, many questions. how the operating room of the future and the hospital of the future could look like. Mm-hmm. We have more opportunities, I hope, here at the ISMIT meetings next years to come, but also at CARS, of course. We have to close the session now because the next one is just in line, a few minutes, only 1 minute away. Thank you very much, Carlos. No? Thank you.
Oh, yes, okay. So we are complete. So let's start the next session. I'm happy that few of you made it at least. So the session is entitled Advances in Robot-Assisted Surgery. We have 4 speakers. Obviously, all 4 speakers are here. So I ask every speaker to stick to the time, and we start with the first presentation given by my co-chair, Raquel Maria Mega. And I think she will read the title on her own. It's a long title.
It's a pleasure to be here. We're joining surgeons and technicians for the benefit of the patient. And I will show our experience in Lisbon about robotic liver surgery and transplantation, and trying to show you some. Okay. So in robotic, where are we now, and where are we standing? Well, first liver robotic surgery was made. Okay, so now we are here. First liver robotic surgery was done almost 20 years ago, but only 10 years ago it starts to grow. It starts to grow first in the United States and then in Europe, and till now there are many centers that have a wide experience. There are several publications on that. They are growing fast, which shows that this is starting to grow now. But if we have this publication of 2022 that shows that in some centers in Europe, most of surgeries are still doing open, which probably is because of the complex surgery that liver and biliary surgery have. So what we think in our center is that robotic surgery of the liver is, of course, liver surgery done from a different approach. So indications should not change, and it should be done for HPB surgeons because of the specificity of this surgery. And of course, no indications changing, no overall strategy of the disease changes, and we shouldn't sacrifice important steps of open surgery. Our experience, well, we serve the whole south of Portugal and the islands. There are about 40 million people, and 90% of our patients are referred from the other hospitals. Our experience in surgery, this is HPB, which is pancreatic, liver, and biliary surgery, excluding gallbladder, is about 600 a year. And our robotic experiences started in 2019. We have a donation from an institution of XI Da Vinci equipment, and we started this days. In 2023, we have a second equipment, a platform X for Da Vinci. And we are starting to grow. So this is 2019, 2020, we started growing. Of course, we have COVID, but we still can manage some surgeries, and now we are growing. As robotic grows, laparoscopies tend to go lower, but minimal invasive surgery in liver keeps growing. So we're starting slow with cholecystectomy, and then we go bigger with resections that are very complex. I'll show you here, for instance, a mesohepatectomy. Mesohepatectomy, for those of you that are non-surgeons, is a difficult surgery because you have 2 surfaces of resection. And as we see here, in the end of the surgery, 2 sides of the liver, which opens like a book. And then we go bigger with resection of half of the left liver, and then biliary reconstruction. This is really where the robot improves things, because the magnification helps a lot in this anastomosis of biliary. These are ducts that have about 5 millimeters, so the magnification that we have in the robot can really help. And then even harder, we started doing section of thrombus in vena cava. This is a tumoral thrombus from HCC for hepatic carcinoma. Trying to put this a little faster, but I can do it. Okay. So, and then going even further, we go for right hepatectomy. You see we are using bipolar energy, lifting the right liver from the diaphragm, which is here. I don't see, you don't see my, putting a reference on the right hepatic vein. And then, okay, this is not going well. I'm sorry. Trying to. Okay. And so after that, we'll go further and we started doing perilar cholangiocarcinoma. So perilar cholangiocarcinoma are tumors that come on the confluence of the bile ducts. This surgery is a surgery that is complex, even open, and we started doing these resections. It implies a liver resection, a biliary reconstruction, and sometimes also vascular reconstruction. And we do it in our center and then publish this paper with teams from the United States and from Europe for the first multi-center transatlantic collaborative study. So what we do, we have several types of cholangiocarcinoma, and we do this resection with vascular reconstruction. Understand that the time of the surgery is a bit longer, but the oncologic results are getting better than we must resect more ganglia. The loss of blood is less, and we going to have good results. So here I have some examples of this resection of portal vein, and then using a stapler. And then reconstruction of this vein. This could be done in laparoscopy, but it will be very difficult because of the straight movement of the devices. And in robotic, of course, it's done really beautiful. And here we have another case. It's a liver with the dilation of the left ducts. This is a Klatskin type 3B, I'm sorry. This is a resection, and this is another part of showing how complex this can be. These are 3 hepatic ducts, which will be reconstructed and allocated to the ileum. And once again, magnification can really help us. So after all this, we started to think that maybe we will be able to do the transplant, the whole liver transplant also for robotics. This is our experience. We started it in '92. We do around 110 transplants per year, some years a bit more, some years a bit less. And we thought that because we have this experience in complex robotic surgery, we have experience in vascular reconstruction, and we have extensive experience in liver transplantation, we'll be able to do the robotic liver transplantation. So the first one was done in the United States, and then in February of this year, we done the first one in Europe and the second one in the world. Of course, we have some instruments that we have to acquire. We train a lot about this vascular, with vascular anastomosis. We use from cadaveric donors samples. And from our list, we selected 7 patients, and we have a donor that it was a 51 years old female. It was a cadaveric donor, of course. And so we do our first liver robotic transplant. So this is our hospital, very different from the models that we have seen in the previous conference. So our patient is a male, 50 years old. He has hepatic disease from ethanol ingestion. He is at discompensation with hydroxyl irritation in May. And he's sarcopenic. He has refractory status as child C, and this is his liver, the CT scan. This patient has a lot of fasciitis, which is good for us on robotic surgery because it creates a lot of space. So this is the surgeon that stays with the patient, and then we have the surgeon in the console. This is our setting for our parts from the robot. So we use a horizontal supraumbilical placement. And now this is treating the hilum where the vascularization enters and the bile duct goes out of the liver. So the portal vein, which will be clamped. You see the artery here. This is a difficult step because it is the dissection from segment 1, which in cirrhotic patients is really big, from the vena cava, which is with danger of bleeding a lot. And so now we are dissecting the right liver from the vena cava from the other side. Again, referring the right hepatic vein, which will close with a stapler. And then the left and middle hepatic vein. I don't know if we have surgeons in the room. Maybe not. So this is the final stepping. Now we are separating the liver, and we have the vena cava, which there will be 4, and then we have to, of course, remove the liver from the patient. This is the cirrhotic liver, and then we'll put the new liver inside. And then we have 4 anastomosis, vena cava with vena cava, portal vein, and artery and bile duct. So this is a bag that can be sealed after. And this now you see you have this space. This is not all blood, it's the fluid that are the liver is perfused with. And now I'll do this anastomosis. So this is vena cava with vena cava from the donor. Try to.
Raquel?
I'm time. Okay. So I'll send this, saying this. The difference, of course, is minimal invasive surgery is this. We have a very small incisions. The recuperation of the patient, of course, is really better. We published this experience in the first paper in Annals of Surgery, and then the step further is starting to do donor hepatectomy with robotic. This is, I think, the most responsibly surgery because we are doing an hepatectomy in the person that is not a patient, it's a donor, and we can diminish the complications. So I'll pass this. And saying that robotic liver surgery for us now is like open liver surgery because we have access and you can do several steps that are complicated. But robotic liver surgery is open surgery in the closed abdomen. Thank you.
Thank you very much. So we are slightly behind the schedule, but I would allow one quick question if there is any. It's hard to see in the room, but I don't think there is one. Well, I have a short one, as it is about advances in medical robotics. So if you would have a wish for the robot, for the new generation of the robot, what would be on the top of your wish list in terms of functionality?
Can I choose two? Well, I think it's energy that we use for this section could be improved, but I think most of all would be integration of exams in the platform and robotic. So CT scan, MRI, if you can join these images in our front, it will be perfect. I think we're going there.
Okay, thanks a lot. So thank the speaker again, please. I think it's live.
Okay, so now presenting Dr. Gernot Konfreif. So for his presentation.
Okay, so technology seems to work. Oh yeah, perfect. Thanks a lot. So I was expecting your answer is force feedback, but it's good that there are some other wishes. Well, hello everyone. As you can see, the title is Medical Robotics, What's Next? I have to admit that after this 1.5 days here at ISMIT, you have already learned a lot of robotics and the future of robotics, so I'm not sure if I can add something to that, but let's try. Before starting, let me quickly tell you what my background is. We are running a competence center close to Vienna in Austria, and the main idea here is to help company partners to bring devices from a low TRL to a high TRL, and then later also to product with all the additional aspects that are needed. So it's much more than technical work, as you can imagine. We do this with a relatively big network of industrial and research partners, and I think we do it not that bad. Let me give you a quick, let's say, historical information before starting with the next steps, because I think there are also younger people here, maybe not that much aware of how everything began. So I was, as you see here, I'm focusing to the three main groups of applications, which still is neurosurgery, laparoscopic surgery, orthopedics. At least those were the starting points. And if we go back to the early 2000s, so there was a very difficult situation in medical robotics. There were not that much systems, as you can see here in that list, and especially one, the RoboDoc, also was facing some, let's say, problems in the first step, and then some also kind of problems in the press later on. And as RoboDoc and Neuromate was owned by the same company, at the end of RoboDoc also was bringing Neuromate a bit into troubles. So as a medical robotic person, it was a hard time, because I was also active in that field at that time. I always had the feeling, well, is it the right topic? Is it a future topic? And as you all know, time was changing, and in the last 10 years, I would say there were plenty of systems entering the market. That slide is too small to show all of them, so I'm only focusing on some. But I think that's also what you have seen here in the meeting. There is a lot of activity, a lot of work going on. So of course that is bringing me to the question: is it already the end of the development? Do we have everything that we need? Is there still room for improvement? And I would think there are some things that we at least can talk about or think about. Not only autonomy, because we have heard basically in every robotic presentation there was also the term autonomy, more with or without inclusion of artificial intelligence. But I think it's definitely an important and necessary and nice topic, but I think there are also some other things that we can think about. Starting with integration, I think you also have mentioned integration in your case of preoperative imaging to intraoperative procedures, but also integrating of the robot in the OR environment. There are still very bulky systems. It's sometimes hard to integrate to existing workflows, to existing setups. So that's something we definitely could do better, I would say. Then cost is always a factor. Those machines, even if I understand the background, because certification is a very long and painful procedure, but they're still, well, not the cheapest part in the OR, let's say it that way. That also leads me to the next point. Is there already a standardized way or accepted way to evaluate if those systems are cost effective at the end, not only in the small area, let's say, of the OR, but also if you then consider post-operative aspects. And of course, we still need to think about interaction principles. Most of the systems still are master-slave, teleoperated robotic systems, and I'm always asking myself, what about the good old ideas of haptic interface, of co-manipulation, and this kind of stuff? There's not much activity in that field compared to what was in, let's say, 10 years ago. I give you some examples. They're very subjective, I have to say. It's my point of view. You don't have to agree, but maybe you can think about it, or we can start a discussion about it. Let me start with the size. So, you know, there is this nice statement, small is beautiful. The question is this also applicable for the OR environment? My answer would be yes. I show this with a small example in neurosurgery. You know, you all know the ROSA robot system, which is a relatively big one. As you can see here in the image, there is also possibility of doing the same stuff, which is a much smaller robot, as you can see in the other picture. Those two robots, I have to say, can do the same stuff. So it's not that one or the other robot has superior functionality. And the question I simply want to put into the room is do we always need to have such big machines in the OR? Only to add some numbers, because the picture might be misleading. So you see here the dimension. You're talking about one system is in the small, in the 200, 300 millimeter range, and the other, the ROSA, and also the NeuroMate is much bigger. It's about a meter or meter and a half, the size of the robot. That, of course, comes with some, influences for the working space. As you see here, the small robot, of course, has a small working space. Vice versa, the big ones have a big one. But for neurosurgery, the question is, do we need a square meter or a cubic meter of working space? Because the operation area is relatively small, so a small robot might do the same stuff quite well. The other question, or the second question I simply want to add as a discussion point is the old question, is it better to have a one-for-all robotic system that then is modified modified to different applications, or is it better to have a tailored design for each application scenario? Also here, two images. You all know the KUKA robot. That robot comes with a kind of a pre-certification, I think that's what they call it. So that means if you integrate that system into a medical system, then you might have some advantages in the certification procedure, because there are some things that already has been done by KUKA. So basically you get all the technical file for your technical file, which might make things much easier. But on the other hand, of course, you might have some constraints with such a big robot in certain scenarios. I'm putting here as an example a needle placement with cone beam CT guidance. Also here, well, unfortunately the same small robot that you have seen in the last previous slide, because I'm a bit biased here because it's something we have developed during the last 20 years. But from the experience in that project, I know that rotating the C-arm, if you have such a big robot in the interventional position, that might be a bit painful procedure. So again, here a small robot simply might have some advantages, or let's say not a small robot, but a tailored robot design, kinematic design might have some advantages. Of course, there are other applications where you need a big working space, and then of course you also need kind of a bigger system.
Let me come back to autonomy, because that obviously seems to be the holy grail nowadays, at least if I recapitalize all the presentations we had in the last 2 days here. The question, of course, for me still is, well, is it needed from clinical viewpoint? Or is it enough to add some automatic robotic procedure? So I have the feeling that these two terms are quite often mixed. I think that's something we really have to be a bit more accurate in our argumentation. Automatic procedure simply means you have a predefined, a well-defined task, and you let the robot do this automatically. So yesterday, for example, we have seen some examples for suturing procedures. That, for me, would not be an autonomic procedure as such. It could also be done with an automatic task execution. And that's relatively simple also in terms of regulatory environment. On the other hand, if we really talk about full autonomy, of course, it's much more. It's not only the task execution, which is done automatically, it's also the task programming, the task definition, the selection of different possibilities in order to realize a task. All those functions then should be done in an autonomous way, and of course the complexity of the problem will then be much higher. So what I want to say is, should we go for automatic procedures? Yes. Should we go for complete autonomy? I don't know. I really would be happy to have a deeper discussion with clinical people here, what kind of autonomy, automatic procedure they want to have, they need to have, for which procedures. Then, of course, also always discussing any kind of ethical concerns, as already mentioned also by Amir Scholt yesterday. And we never should forget, if we add autonomy, or if we make the system more complex altogether, this of course does not make things then easier if it comes to cost-benefit relation. Well, there are some activities in autonomous robots. I'm only picking 3 because we are involved here. So there was a project under the lead of University of Verona, which was investigating autonomous functionalities in a setup together with a Da Vinci robot. We are at the moment coordinating a EU project where we try to investigate autonomy and artificial intelligence in eye surgery. And we just kicked off last week another project where we do a robotic, partly autonomous robotic procedure for laser treatment in the head neck region. But if we talk about challenges of increased autonomy, time is running away. There was a nice meeting 1.5 years ago, and a lot of clinical people also, and the question was, what is the main hurdle here? And it turns out that regulatory was the #1, together with trust of artificial intelligence, autonomous systems. So I skipped that. Simply want to say there is a regulatory environment, and in my understanding, that regulatory environment is already, let's say, able to cover also autonomous robotic procedures. We do not really need more standards. Maybe there are some standards necessary, and there is some work around it if it comes to the combination of the technical development and the ethical implications. You see here in the IEEE robotic and automation systems, there are some of those standards in discussion. Let's see what they bring us. Still, as mentioned, there are some regulatory, mainly regulatory hurdles, as you can see here. Testing will be more and more complicated with autonomous systems. On the other hand, with autonomy, you lose the last barrier, so to say, for a safe system, because at the moment, when we do risk analysis, we always say, okay, the robot is there, but at the end, there is a surgeon, and the surgeon then confirms actions or decides actions. You would not have those last barrier if it is a fully autonomous system. So that's really a big step also in regulatory viewpoint, and we have to be very careful here. And finally, that's the last statement. There was a nice, interesting discussion with some lawyers about half a year ago, and they brought up the topic that if the robot system is starting to be, let's say, fully autonomous, then we are not talking about the medical device anymore, because then the robot is practicing medicine. So the robot is becoming a doctor, your colleague, so to say, and from from regulatory viewpoint, then we are in a completely different area. So if that really will be then the common understanding of autonomy, that the robot becomes doctor robot, then I think that is something which will be very exciting on the one hand, but very challenging on the other hand. That's it from my side. Thank you very much for your attention.
Now, if there is any questions from the audience? So,
If not, I have to change. Yeah, you have one. Okay.
Yes.
I thought I'm switching back to my duty as a chair.
Would you prefer, in the future, would you prefer to be operated by the surgeon or by autonomous robot?
I would like to have the surgeon on the bedside, supported by robot, of course, but he or she should be the one who is doing the decisions. But it's my personal viewpoint.
I'm happy with that. Okay, thank you.
Oh yeah, there's another one.
I mean, I agree with you. You said that if a machine does a surgery, the legalities are different. I don't agree, because you will ultimately be responsible for the patient, and as you said, you want to be the decision maker, right? So I think that'll be the model of the future. Even when you get autonomous diagnostic images, there will always have to be a person there to say, yeah, you can do this.
That's true, but then we are not talking about full autonomy. I mean, you know, it's like not being a bit pregnant. It's not possible. So if you go for autonomy, you are autonomy.
I totally agree, but I don't know that we'll get full autonomy. I think we should be part of the decision process.
Definitely agree to that. Okay, thank you very much. And switching. Next presentation, which is given, I need to check.
Marta Molina.
Marta.
Yeah, there we go.
And as I don't have the title here, I ask you please to introduce your paper on your own if it comes to the screen. Well, in the meantime, I can. So the paper, Marta's paper is about robotic surgery in urology. How far can we get? Well, we will see.
Hello, so my name is Marta Molina Bravo. I'm from Hospital of Spain, of León, here in Spain, in the north. I'm representing Dr. Miguel Ángel Alonso Prieto, which unfortunately couldn't be here today. But we want to thank the ISMIT to invite us and to have León in a representation of this international congress. These are the conflict of interest. I want to talk about the evolution of urologic surgeries from the beginning to the robotic surgery and how it improved urologic procedures, being urology one of the most benefited specialties by this developing minimal invasive technology. We can see manifestation of urologic procedures since the ancient Egypt in the Everest papyri, like with circumcision. Also in the Middle Ages with lithotomies, treating the sufferers from stone disease. And we can start talking about laparoscopic with Kurt Sem in the 60s, who was a German gynecologist and a pioneer of minimally invasive surgery. He was considered the father of the modern laparoscopic. But it was not until 1998 that the first laparoscopic prostatectomy were performed by Bertrand Guilleneau and Richard Gaston. At first, the distribution of the cases of the patients treated by robotic surgery was mostly urologic, but then it became for more, the other specialties became more and more experimented in it. The first time the word robot came out in the world was in 1921 with this Karel Capek, named Robotum. But robotic surgery started with Akhil Madani, which was a student in the ISMIT University, and he developed his telescope in surgical instruments. And that brought the attention to the NASA and the military. But the Da Vinci robot was first launched on the market in 1999 by the company Intuitive. And then new models were released in 2006, 2009, and the last one was introduced in 2014. This robotic surgery allows us to make techniques, minimal invasive techniques that were almost impossible in the open surgery or very difficult in laparoscopic. Like this one, this radius sparing prostatectomy, which we can see peritoneal incision, then the vesical seminoles isolation, the juxtacondylar section, the posterior of the face of the prostate isolation, the stitches to preserve the neurovascular bundle, the bladder neck section, and also the urethra section, all these in a very, very reduced space. This robotic prostatectomy allows us to do to have better early continence, better operative potency, and reduce of the operation time because omitting steps like mobilization of the bladder or the fatting of the prostate. In a cost-effective analysis made by the UK National Health Service, that the results were with counting over 10 years experience that robotic prostatectomy was 1,500 euros more costly than laparoscopic prostatectomy, but was more effective with a main gain of in quality adjust life years of 0.08. The incremental cost effectiveness ratio was 20,000 euros with an 80% probability that the robotic prostatectomy was cost effective in between a threshold of 33,000 euros quality. These higher costs of robotic prostatectomy seems to be offset with a modest health gain due to a lower risk of early harms and lower positive margins. This seems like robotic prostatectomy have less urinary incontinence and less erectile dysfunction. So this lowers the cost of solving these problems, these undesirable effects post-surgery. These cost-effective rates are just for high-volume centers. So, open cystectomy keeps being the treatment for muscle-invasive bladder cancer. But we could see with a laparoscopic technique that that reduced the hospitalization days, the blood loss, and the postoperative pain. but laparoscopic intracorporeal urinary diversion was extremely hard, extremely difficult. So it didn't have any benefit compared to the open technique. But with robotic surgery, we can perform this with lower operation time and more ergonomic manipulation. We could see here, with robotic surgery, we basically reproduce what we do in the open surgery. Here we can see bladder augmentation cystoplasty, and we choose a small valve when we measure. We normally identify the most mobile lobe of ileum that reaches urethra without tension. And then we can suture to the open bladder in here. And for the urinary diversion, we use the stapler to do the reconstruction of the neobladder. Another urologic pathology that was benefited by robotic arrival were the renal tumors. Simpler transperitoneal and retroperitoneal approaches for partial nephrectomy. We can see this video. It's fast forward, but the process takes less than 3 minutes. We get to the renal pedicle and identify all the structures. We can also use indocyanine green to better visualize the vessels. But this leads to a faster dissection and access to the pedicle. We can also do a super selective clamping, which leads to less ischemia, and even zero ischemia partial nephrectomy to protect renal parenchyma from ischemic injuries. We can also approach, we have other extraperitoneal approaches, like this robotic inguinal lymph node dissection for perineal cancer, or other tumors that affect the inguinal lymph nodes, such as melanoma of the lower limbs. Here in the video, we see that we pulse the lymph nodes, and then we put 4 parts, 3 robotic and 1 auxiliary laparoscopic. We do a deep dissection to approaching the fascia lata and the femoral vessels. Also the inguinal lymph node, saphenous vein and its arch. There. In this case, we clamp the saphenous vein because there were large size adenopathies. This surgery with robotic assistance is much simpler and ergonomic than laparoscopic, and with a much lower complication rates than open surgery, reducing 60%. We are moving towards a single part robotics assisted, which is already happening. We have a really good video of single part robotic access, the low anterior approach for retroperitoneal partial nephrectomy for Dr. Betan Kadani. And we can have a very small Egyptian incision and do a nephrorectomy in a supine position. So also, the 3D printing has significant advantages, mostly because we could do a pre-surgical training in complex cases. We have also the augmentation reality, which is a technology that allows us to see the real world through a device, and we can add graphic images, so it enables us to overlap images in an actual real surgery. So it is pretty compelling. To conclude, robotic surgery is allowing us to go farther in less time. In urology, specifically, it is already showing better functional outcomes despite the challenge of obtaining evidence. The future is hard to predict, but we believe that robotics, along with its development and the implementation of improvements such as haptic feedback, which still needs enhancement, will make it so that the future of surgery can only be accompanied by robot assistance. Thank you very much.
Thank you. Is there one question from the audience? Don't have to be so shy. No question. Okay, then I ask you the same question that I have asked Raquel. What would be, I mean, I saw haptic feedback is obviously on your list, but beside of haptic feedback, what else would you like to have as a new functionality for your robotic system?
I'm guessing what she said, overlapping images, it would be great. Sometimes we cannot find tumors of renal tumors that are a little high, or they don't seem high in the scan, but then we don't find them. We just ultrasound right now, but it would be very useful to have the image there.
Okay, thanks a lot.
Thank you.
Okay, then thanks again.
We present Dr. Alicia Casals, which will talk about robot laparoscopy, present and future.
Ay.
F5 also would work.
F5.
Bigger?
It's fine. It's fine. Okay. Thank you. Well, I will give a view. Many things have been said partially on this. I try to put things together to see the present and future. And for that, I want first to analyze a little bit things that everybody knows, but let's put them together. In open surgery, we have some advantages and disadvantages, of course. Sometimes we think that, we consider the pass from open surgery to robot laparoscopy, but let's stop in the middle in laparoscopy. In this case, we of course have less invasiveness and fast recovery, etc. But as everybody knows, we have much more limitations due to the working conditions and the limited degrees of freedom of the instruments. When we come to robotic surgery, what we gain is mainly the accessibility of the instruments. Most of the systems have 3D vision, etc., and we can get more complex surgeries. But we have limitations, and I want to remark mainly these last ones, that the robot has a big footprint in the operating room, everything is centered around the robot, and we need more setup and operation times in general in these applications. And cost, of course, is another. So one of the goals is advance towards more autonomy and human-centered systems. Maybe we have to discuss a little bit. Gernot comments the concepts of also of autonomy. We will go through them. Okay. Much has been said of evolutions of robotics. Many of them has appeared and are progressing. But let's see maybe the way through autonomy. Laparoscopy, of course, is teleoperated systems. And so as teleoperation, we can see here that what we provide is orders that the robot replicates, and we can get some feedback. But of course, has no much sense if we don't, if it is just a replication. For that, the advantages of robotics is, in general, and existing ones are changing geometry, ergonomics, sensor feedback when possible, tracking, virtual reality, all these performances. And we have to look at the future, and we are talking of autonomy, we're talking about digital twins and metaverse in order to be more in the context, so help the surgeon to be a better teleoperator. And basically have an adequate and rich interface. We have seen previously the future operating rooms, and that's. Well, this schema has been appeared several times during this conference. We can put some of the, and this is the implication of humans in the intervention while the automation increases. And we have examples of robots in all of them with the comments that Karen mentioned about automatic and autonomous. But, okay, for example, we can consider Da Vinci as its teleoperator as in the first case, no autonomy because it's just copying. But of course, as we add performances and some capabilities of assistance, we can put in this category. We have other robots, not in laparoscopy, but in spine surgery, that the robot is just a guidance for the instrument for its better localization. Or in nodes and in endoscopy, endoluminal systems, steering inside the natural tracts in the body. We have some applications in which the robots do the task autonomy or automatic when it is programmed, as in orthopedics, as in eye surgery, in brain surgery, that some actions are done based on a previous program situation. So in very limited and very constrained environments. And finally, we can put this example of radiotherapy robots that really do all the tasks, even compensating position of the users. But okay, we have to say autonomy also with caution because it's something that is quite programmed in a very constrained or very predefined environment. And well, we will see how we advance toward this full autonomy. Just to discuss a little bit on the autonomy, I will put some small examples in projects that have already appeared in previous presentations. One is autonomy in surgical robotics, that is the SARAS project, mentioned before, mentioned yesterday too, in which we have been working in the process of automatizing and making automatizing for an auxiliary robot, so robots for doing auxiliary tasks. So at the level we are for simple, concrete, and quite definite tasks. And just to show as an example, we have been working in decomposing all the procedure, phases, actions, surgems that are basically the atomic tasks. So every intervention, for example, here in RAP, we define it particularly all the tasks, all the actions done for this task, and each of them with all the possibilities following finite state machines, so defining everything, all the possibilities. So at the end, it does the task autonomous, but previously we have had to define everything in detail. So we are talking about artificial intelligence, we are advancing in this direction, but we are still far from idealizing that everything can be done autonomous by the robot. So this is an example of the steps towards automation of a specific task. And here we have an example where the auxiliary robot has to deal with the movements that the main surgeon is doing, and so avoiding and continuously updating the position. And so these are assistants in this intervention of providing or avoiding this auxiliary surgeon here. In another project, the Atlas project, that is autonomous intraluminal surgery, is not exactly laparoscopy, but has many things in common. We had to assist in the insertion of the instrument, of the endoscope, and here appear different tasks in order to assist in this assisted teleoperation, because still is assisted teleoperation. And the problems can be in more or less weight in one application or the other, but in general what we need is perception to detect the polyps, navigate and the way, and the free space, navigation, modeling. We had to develop a model of the colon in order to train the system, flexible steering, in these cases also additional. The additional aspect is the instrument itself, new sensorization. That are appearing and being used more and more. New kind of sensors are optical coherence tomography or FBG, adapted to this miniaturization or to be able to be on the instruments, etc., and facilitate the interfaces. As Marta mentioned before, we have also to deal with instruments, so for example, for these multiple instruments in one, or multiple instruments in one body. We have to deal with the robot itself. And an important thing when it is referring to the control and assisting the surgeon in the intervention, when we are dealing with different instruments coming up from the one body, the advance of the body affect the instrument, so there are couplet architectures between the body and the different instruments, and this poses additional control aspects, etc. We saw also yesterday different kind of architectures of this kind of robots and instruments. And the last project I want to mention is one fetal surgery. Instead of the laparoscope, it's a fetoscope, but the principle is the same. So here we have a scenario of the lab. Here, some additional difficulties with as the high mobility of the sen, the very deformable tissues, the small instruments, even smaller than in general laparoscopy, and access constraints, as we have also to enter the abdomen and the uterus, etc. So for this, we developed several assistance systems, not autonomy, but quite useful. So we have to see how to manage between one thing and the other, between autonomous or assistant to the surgeon that was holding the instrument, locating points of interest, navigation to desired points, etc. So we performed several assistance to allow the surgeon that is working in very stressing conditions to work more efficiently and, more important, safely, and also in a shorter period of time. And for that, for example, we need to build a mosaicing from fetoscopic images as we advance. If the surgeon only sees a very small part, if we build a big area, so he knows, or she, where it is and how to go, and it also helps not only the surgeon to locate the instrument within the scenario, but also give information for assistance to navigation. So I have also generated autonomous trajectories when the surgeon say, I want to go from one point to another. So this was another in which there's no autonomy, but many facilities to the student. So to conclude, we have to see if this is an schema of the aspects or the factors involved in the control, that is from the surgeon, the gestures of the surgeon, you control the systems from the system, the robotics, the surgical side, we give out these conditions. What is coming new and advancing in the future is more capabilities of learning and applying some artificial intelligence commands, step-by-step specific autonomy, but also, and very important, to provide clear information to the surgeon in order he really knows what it does and give correct orders, not risky orders. And for that, aspects like digital swing, creating this immersive environment is quite critical. Seeing inside the liver, for example, seeing inside what is not visible at simple sight, because we have the information from previous images, things like that, that really facilitates the actions and this eliminates stress from the surgeon. So if we have just a view of this future, what we can expect from the future, I will say that is extensive robotization. Now robotization is quite limited compared to the number of interventions, and many things come from this. For example, we also, as I mentioned yesterday, depend on new technologies, new disruptive technologies that appear, and new devices like micro and nano devices are able to change a lot of this context. So we expect the advance in autonomy, providing real virtual reality and more learning environment, generate universal knowledge, because this also will allow to create new ways to proceed, human-centered, that is quite important, and safe. And not only thinking on the surgeon, or not only thinking on the robot, sorry, but also on the surgeon and on the team that is assisting the surgeon. So for a more powerful surgeon, as I said, we need this immersive environment, more information and new tools to assist them. And for the team also, tools, fluent interaction with the surgeon, connection with remote experts for punctual assistance, and new tools. And that's, I think, is my vision of how laparoscopic and, in general, the operating room can move in the future. Thank you.
Thank you. I think very interesting conference. Do we have any questions from the audience? Sir?
Louder if it's, yes, it is on. Thank you for this overview and also for the other speakers. But what worries me a little, what I see now over the last 15, 20 years are incremental improvements in robotics, which hardly ever reach the real clinical world. And it reminds me of the statement of Henry Ford. When we ask horse riders what they prefer in their next generation, they want a faster horse because they can't think about cars. And that's the same when we ask surgeons working with robots. They come with all kinds of these solutions which are very hard to implement. So I think, I'm an engineer, we have to think out of the box. And yesterday I gave some insights of more image-guided interventions like radiotherapy. And you did as well. In your slide for autonomy, I think I thought a cyberknife, I'm not sure if that was the case or it's an alternative, but hardly ever is addressed real, but I think the future is there. But could you address more on this really autonomous things? Because I don't believe that what is presented here for this incremental, just a very small percentage will read the OR. We have to look in a different way. What's your...
Yeah, I think this the progress is I don't know exactly if is what you mean, but of course, getting solutions, sometimes solutions appear because of technology and because of ability. For example, gamification has provided a lot of possibilities for future interfaces in surgery, because they have developed GPUs and things that otherwise we wouldn't have as tools. So in general, external things help us roboticists to advance. And from what I see, our experience is that we are advancing. The application of artificial intelligence, as I said, systems learn, we have data. Getting data is hard. In robotics, there are so many complexity, so putting everything, and we in general, I think the robotics community is somehow frustrating because maybe artificial intelligence is advancing a lot in other areas, but less in ours. And so we have to, for that is what I say, that I think we go step by step. We are automatizing part by part, or in general looking at how the synergia, because maybe in many applications, maybe the goal is not automatizing it, but trying to find the best synergy between the surgeon and the robotic system or the auxiliary components in the operating room.
Well, thank you very much for the talk. Great talk. I'm particularly interested in the image that you have on your last slide, the image in the center, and your comments or thoughts on the operating room of the future as it relates to ceiling-mounted devices. I've heard a lot of people talk about robots not hanging from the ceilings or light, and most of the equipment being mobile, but I noticed that you have an image that has that. Can you comment on your, what are your thoughts for that?
I think we have to reach a compromise, no, between, because one of the problems is sometimes that the operating room is completely full, and so we have to manage how, yes, sometimes I think the surgeon with many things above can be really a little boring, but well, we have to see. I think is a step-by-step testing and seeing how good, how acceptance, how much steps that we can advance with some of these new devices. So if the benefit is, well, okay, maybe we have some burden, but if the information is not complete, then maybe it's not good enough. And so we have to balance at every moment and seeing. For me, it's a little difficult to predict sometimes. I see examples of views of the future and think it's exaggerated, and the robot, I start saying, we think that the operating room has been centered on the patient and the human and the surgeon, not on the robot. And sometimes we enthusiastic with the technology maybe can go in the wrong direction, putting much technology not in the adequate way.
So for the sake of time, I would ask you if there are more questions, then please catch up Alicia or other speakers outside, because we are already in the lunch break. I want to close the session. Thank you very much for your attendance, and ask you, Juan, do you want to have an announcement for the, or are you, okay. I thought you were coming and telling us that lunch is already over. Okay. Okay, perfect. So thanks again, all of you, the speakers, audience, and see you then in the lunch break. Enjoy food.
Answer is yes. There were, in Star Wars, human surgeons, 0. Human nurses, 0. The dream of our species is to replace us, and there's nothing we can do about it. First, a definition of what artificial intelligence is. Basically, is the ability of machines to simulate human cognitive processes, such as reasoning, learning, planning, creating, and also technical skills. And this goes back to the origin of machines that think. In fact, Alan Turing was trying to replace Christopher Morcom when his friend died in 1930. And it became even more so in 1950 when Alan Turing published this seminal paper entitled Computing Machinery and Intelligence, where he asked himself, can machines think? And he replied, okay, that depends on how you define machines and think. But it was not until 1955, 1 year after the death of Alan Turing, he committed suicide, when we started using the word, the expression, or the term artificial intelligence. And I want to draw your attention to the definition of artificial intelligence, because this was a workshop organized by John McCarthy. And he said, an attempt will be made to find how to make machines use language, form abstractions and concepts, solve kinds of problems now reserved for humans, and more importantly, and improve themselves. So basically, we have designed this technology, artificial intelligence, to replace us. It didn't work for a while. There were many different disciplines. Each of them was in a silo, and they were not connected. And that's why we suffered a couple of AI winters. In 1973, the first AI winter, then the second in 1988. The technology was this. I remember the first time I wrote code, it was this computer. However, in the 21st century, things changed. Why? Because of the technical advances, deep learning, neural networks were designed and developed. Then we accumulated massive amounts of data, and then a lot of computing power with many different implications, energy consumption, water consumption, but it is here. It's not going to change us. The problem now is that we humans are so occupied that only machines are learning. And this is something we need to think about. It became really famous because of this architecture. This is a transformer architecture. This paper was published in 2017, only 7 years ago, but it helped transform how we look at AI, specifically generative AI. And now we have new models. There are like O1 preview, which are even better than anything we knew before with GPT-4o. It increases accuracy and precision to a large extent. What about healthcare? Everything can be done with Gen AI. You can do research and innovation, education, clinical practice management, you name it. Everything can be done. In fact, we have come up with at least 3 different chatbots, GPT-4-powered chatbots that are publicly available for free. One's is bariatric and metabolic surgery. Professor Balibrea is around here. Another one is hernia bot and coloproctology. You can ask questions. It will give you good answers, pretty good answers. In fact, Gen AI is better than 99.98% of New England Journal of Medicine readers when it comes to complex diagnosis. Much better than us. Let me give you an example. This is GPT-4o. The only thing that I told it was dame el diagnóstico, give me the diagnosis. I uploaded an image, and this is what happened. Give me the diagnosis, the image, and it's absolutely right. This is a real case from a couple of days ago. A dear person asked me, what do I have in my eyelid? I took a picture, I described the symptoms. What is the diagnosis? It nailed it. There is no need for the agent between knowledge and the end user of knowledge. That's our risk. We are at risk because we are no longer needed. This may be right or wrong, but we are not needed anymore. In fact, neural networks can read our minds. This is a clear example. They gave pictures to people. They took functional MRIs while they were looking at pictures, and the neural networks reconstructed the image. So our ideas can be seen by neural networks. Another question, or just a kind of a statement that I usually get, but they are not empathic. Are we sure about that? This is a 2023 JAMA Internal Medicine article that showed that patients think that answers generated by ChatGPT are better and more empathic than those generated by human doctors. In fact, they have similar traits in terms of personality compared to ours in the 5 different domains of personality test. It's clear. They were trained with our data. They behave like us. But that's not the major change we have to face in the near future. I mean surgeons. I'm a surgeon. My doctoral thesis was 1992 on laparoscopic surgery, but now there are things that can do what we do easily and very precisely. Let me give you a couple of examples, and I will finish with that. Can we get sound? ¿Podemos tener sonido?
I see a red apple on a plate in the center of the table, a drying rack with cups and a plate, and you standing nearby with your hand on the table.
Great. Can I have something to eat?
Sure thing.
Great. Can you explain why you did what you just did while you pick up this trash?
On it. So I gave you the apple because it's the only edible item I could provide you with from the table.
Great. So, based on the scene right now, where do you think the dishes in front of you go next?
The dishes on the table, like that plate and cup, are likely to go into the drying rack next.
Great. Can you put them there?
Of course.
Now let me So we need to get ready. How? First, act quickly. Second, learn the technological basis. Third, design a strategy. Why and for what? Let's define the purpose. 4, identify use cases that generate better value in healthcare. 5th, invest in innovation and cultural change is going to be otherwise pretty hard to accept changes. Invest in education, reskilling and upskilling. And last but not least, face the legal and ethical challenges that this technology will bring in. So remember, resistance is futile. We will be assimilated. Thank you very much. Next, let me introduce, questions now, or?
Yeah. We have any questions?
Okay.
That's not the case. I just want to make a comment. So when you have a young doctor, depending on personality, maybe also very emphatic, and then the young doctors or she start suffering to get so close to the patient and all his problems. So the older doctors usually they get a bit of a professional distance, we call it. And we are advised by psychologists to keep a bit of a professional distance. And the balance between being emphatic and professionally distanced is really hard, so that only very few doctors manage this. So I wonder how AI will develop over time. Maybe they start suffering too, and then they keep a distance to this. So I don't know what the solution is.
Yeah, it's so difficult to foresee the future because these neural networks evolve so quickly with so many inputs, so many prompts, interactions. The problem is that unless they develop consciousness, they are good at understanding what the others feel. So they understand pretty well what others feel, but they don't feel it for now. We don't know about the future.
I remember, well, you have the Captain Picard, there was Data, his brother had this emotional chip, and the problems when Data got the emotional chip and all the rest of it. And then he was fighting for him to become a real approved species so that they are not allowed to take him apart. And I have this kind of analogy, and we may have to accept that AI is a new species, and we have to be carefully integrating with the new species.
That's an excellent, brilliant idea. I kind of support that approach. We are just one of the many different steps towards a different species. Yeah. And we have created that new species.
We have created it nonetheless.
Yes, and if you look at AI, the movie by Steven Spielberg's, do you remember that? It's similar. The problem is when these machines develop consciousness, when we code or they learn to code and improve themselves. So the challenges are so unfathomable and affordable. This is really interesting.
Exciting, yeah. Okay, we have to move on.
Okay, let's move on. Let me introduce my co-chair, Andreas Melzer from Germany. He's going to speak about focused ultrasound therapy.
Yeah, so I'm getting a bit down to earth to applications. And so how can I get to my presentation here? So, okay. Yeah, and focused ultrasound is a novel technology, but certainly the wrong number still should work here. Is a novel technology that is very close to AI application. It's more regulatory hurdle. And so we have non-invasive or ultrasound guided by MRI, and we have, just as a background for you, thermal and non-thermal effects. So in opposition or in opposite to diagnostic ultrasound, the focused ultrasound that where also the name clearly identifies is not creating a large sector or linear array image, it focuses the ultrasound energy to a point, and thereby is a significantly higher energy that can be delivered to tissue up to the point where it destroys tissue. So this was early by neurosurgeons adopted. They tried to treat brain without knowing anything inside, without MRI, or not even CT scans. So it didn't work very well in most cases, but then it developed. You see all these applications, they're ever increasing, and 100,000 patients at least treated, and the 20,000 MRI guided, a few in prostate cancer. So the ultrasound guided has a significant difference to the MRI guided. So you see here an ultrasound diagnostic image, then there is a planning with these lined small cigars, and then the focused ultrasound is applied. But the diagnostic probe picks it up, so you have no control exactly during the treatment. So there's lack of monitoring, lack of temperature mapping. It's slowly coming, but it's not yet clinically applicable. And we have all these great MRI imaging features which cannot be applied. So that's why MRI-guided focused ultrasound has some huge technical and clinical benefits. We have, however, something which is quite popular in many ultrasound machines available. It's called sonoelastography, whereby a much lower frequency is put on top of the ultrasound imaging frequency. And we do this clinically without a modern system by tapping, for example, on the liver, and thereby all of a sudden a lesion shows up due to the different elasticities of liver tissue and the lesion. So we may have this then available in ultrasound guided, but it's after focused ultrasound. So we see then the effect, but we cannot really control. In MRI guided focused ultrasound, we have the opportunity that the hotspots that's been created can be monitored by MRI quite well, and InsightTech from Israeli company has pioneered this substantially, and you see here the imaging of the temperature change. However, it's not directly the temperature, it's a proton shift image. So it's an indirect measure, but it's quite reliable. So and then the lesions you see on the other side are the treatment results. And again, there's also contrast agent that needed. Philips went a slightly different way to this, though in essence it's the same, but they made the beam forming part of the system, whereby by controlling each element, the temperature can be applied to a larger area with no so much peaks. And this became a tool, experimental tool for hyperthermia, for treating cancer before the radiation, as well as for drug delivery, but it's not yet clinically approved. InsightTech made on something very interesting development with a mobile unit, 900 elements to be positioned on the patient, and they had successfully treated bone metastases. The benefit, there is no cumulative dose, so you can treat a lot of bone mets, but quite often you need radiation on top for the overall radiation treatment of the patient. So other developments were more on the high-frequency ultrasound. You see here some transrectal probes for prostate. Didn't work so well. It was a more trial and error thing with side effects comparable to surgery. But it had a renaissance due to the MRI-guided technique. So now it's an image fusion has been made available to at least have an indirect control of the position of these transducers. And this is what paved the way to this improvement, to the InsightTech introduction of the MRI-guided transrectal treatment probe to the prostatic cancer. Unfortunately, it's not so awfully successful. It's very complicated. I joined sessions. However, it has already a bit of an AI component. It suggests to you where you have to put your lesions. Very interesting, and it's learning. So even though they never called it, it has an AI element of a self-learning. So profound, they took all the Philips technology also over, made something which we do not call focused ultrasound. It's defocusing, however, it goes from the urethra to the outside, covers almost the whole space of the prostate, and is comparable to surgery, easier to use, and as far as I know, quite successful. We went to the significant problem of moving organs, which was a real challenge, because when the organ moves, how can you keep your focus? And with this technology, using a robot arm, but mostly due to MRI improvements, sorry, it's not running well, we finally had very good results. You see the liver tracking in MRI by fast MRI images. You can pick areas with high intensity, and then the ultrasound through an API can be controlled through this beamforming process. So the ultrasound focus either sharp for burning or soft for temperature rise follows the MRI image. Very sophisticated from MRI and ultrasound standpoint. And what was also embedded in this project was called modeling simulation, but this is a strong element which requires AI components, so that through all the data we have available, the machine tells you this is a case for focused ultrasound, and this is not the case for focused ultrasound. You can still decide, then you get a simulation of what will happen during the treatment in both temperature and ultrasound pressure. So why these two modi, sharp and soft? Sharp is for tumor ablation, histotripsy, very short pulses. The soft is for mediated drug delivery, for blood-brain barrier opening, neuromodulation is coming, and also under clinical trial to increase radiation sensitivity, because tumor cells don't like ultrasound very much. They become more sensitive to the radiation effect. Blood supply increases, oxygen concentration increases. So the drug delivery is also a very exciting component. We had a very good EU grant funding, became even a success story, and we put liposomes and cyclodextrin polymer carriers, embedded doxorubicin, a very aggressive, so effective chemotherapy agent, published this, and the idea was you have these capsules running through the bloodstream where they pass the ultrasound focus targeted towards the tumor. The drug delivery elements crack open and enter the cell. And that's not the only effect. Very early in our group in Dundee, Paul Prentice discovered the effect of sonoporation here, usually complex experiment with optical trapping of an ultrasound contrast agent bubble and a large living cell, and how to enter the cell membrane. And that's what these bubbles do. That's why it's called sonoporation. With a living cell, electron microscopy, atomic force microscopy, we could show this, and if the holes are not too large, cells survive, but at that very moment they take up many things which would be not taken up due to the cell membrane barrier. So the supportive radiation therapy is the same low energy element, but it's more on the effect that, I would skip this for the sake of time, that we have a more sensitive cell because a ultrasound stimulates heat shock proteins. It also compromises the DNA repair because the cell has still to cope with the ultrasound effects, and also the ultrasound effects due to NOx influence increases blood supply, and this is very good for radiation, that the oxygen level is high. So we wanted to combine this with a large radiation therapy center to combine even in a proton therapy unit and also even in a MRI LINAC focused ultrasound with the radiation therapy. So having this, for example, the Philips tool, which is very useful for this, soft heating, larger areas, and then applying it to cancer patients. We are very close to first clinical trial. Excuse me. Again, in a large project, also became a success story. We had a concept of 2 robot arms with diagnostic ultrasound and therapeutic ultrasound navigation, all the rest of it, to do this in an OR setting Finally, we realized this with the KUKA arms, and the KUKA arms are the only robot arms that are medically approved. And we set up all the communication between the two robot arms, and the French company that has this probe I showed in one of the very first slides. Ultrasound, guided focused ultrasound is something the robot arm can position. In our case, it's head and neck cancer, and then apply treatment. So we put this all together in something at my institution we are quite leading. It's called this service-oriented device connection, so that all the devices in the OR are connected, and this helps to get here this iPad control. The iPad also shows that the ultrasound, what the ultrasound image does, and all these collisions are avoided because the robots talk to each other. And I will stop the video, but this concept, you see all this connection. We won the Hamlin Challenge last year, and this is the way forward, that you integrate your devices well with the environment you're working with. If it's an OR, it should be integrated in the OR. So we did needle biopsy, needle ablation, and focused ultrasound. So with our large grant we are currently running, we look into neuromodulation. A specific system was developed by Fraunhofer, MRI compatible with a 256 element transducer. And I showed this in the poster session. We were successfully doing transcranial sonication, and we are now going into a first volunteer trial with this system because it had passed all the required testing for clinical use for trying first attempts on neuromodulating at low intensity. Monitoring focused ultrasound effects, my last subject, is something that's hard to achieve. Even though MRI shows temperature increase, then quickly an edema develops. You don't know whether the tumor is destroyed, whether you had an effective drug uptake. And what allows this is PET. And a friend of mine in Italy did PET CT on a cancer patient. You see the metastasis, and then focused ultrasound was applied. And after the treatment, also correlated to a PSA level, the metastasis was gone. So fortunately in Leipzig, we have a PET MRI in the nuclear medicine department, and they are very keen to do this treatment monitoring. We had set this all up, the focused ultrasound, the robotic system, to do this MRI, PET MRI guided interventions as well as treatment monitoring. And there's some very interesting developments in the prostate, and some urologists already say the optimum is PET MRI because of these new tracers. They are the prostata-specific membrane antigen that really is linked to a prostatic cancer, and you can see here these lighting up elements, and if you had a focused ultrasound, you could do in a one-stop shop the treatment. So in summary, we have all these effects known from various different ablation technologies. Electroporation was one that made a non-thermal effect. Then we have reversible effect, irreversible, and we have a true thermal burning effect, which we would like to avoid. We want to have an irreversible cell attenuation. So it's covered completely by the focused ultrasound technology. That's why it's so interesting for a clinical setting, and it's non-invasive. You have not to put any needle in, any catheter, nothing, but you have to have a lot of machining and equipment. And AI would allow us to have a much better analysis of the lesion size we have to do, particularly if the data set is large enough. That's why it's, I think, one of the most interesting applications for this new technique. Yeah, I have to thank the team. I usually have the fun to talk, and they have to do the work. So thank you very much for your attention.
Questions? Comments? I would like to, is focused ultrasound the best technology to integrate connection plus artificial intelligence plus robotics? Is the easier way to go?
Well, I see both. There is a certain element of robotics already there. In the table, you have a 3-arm robot to position it properly. And so it's a bit like the radiation therapy units with robots. So you can put it according to planning. And then inside the radiation unit, you're absolutely not allowed as a clinician, so that makes a lot of sense. But in itself, the focused ultrasound carries a lot of potential due to the beamforming being very flexible. It's more our clinical approval process, you know, the evidence, and this is not yet there. We don't have enough large studies for the evidence. And pharma companies absolutely don't want to see that there is something reducing the dose of the drug or something like this.
We need to change the business model if we want to
Absolutely.
develop a new technology like this. Okay, thank you very much.
Okay, so we have the next talk. Maybe you do this because you have the list here, and I don't know where this is.
Yes.
Maybe you.
I will do it.
Yeah, you know. Yeah, sorry, it's not listed according to the sessions.
So Jorge Bernal will present now.
Hi everyone, I am Jorge Bernal. I am an associated professor at Universitat Autónoma de Barcelona and a researcher at the Computer Vision Center associated to UAB. And I'm going to present, my work and some insights on how intelligent systems can assist clinicians in gastrointestinal endoscopy topic. So first of all, I think I mentioned in a talk before, but we have over 1.9 million new cases reported of colorectal cancer in 2020, and colorectal cancer is one of the most easy to prevent because we have a very well-known precursor lesion, which is the polyp, but still there are some issues related to how this colorectal cancer is detected. In fact, my research line focuses intelligent system for colonoscopy is devoted to two main applications, which is early detection of colorectal cancer, which is the precursor lesion, which is the polyp, and in vivo histology prediction. Our constraint when doing this is that we have to fulfill actual clinical needs and to be used method during in vivo exploration or offline during in vivo exploration, and for sure under real-time constraints. Our key partner here is the Hospital Clínic of Barcelona. Just a brief, why do we need this system? Because if we have this is a normal colon and this is a polyp, it is easy to detect, no problem about that, but if no one detects it and it takes 5-10 years, it can develop into cancer. When it develops into cancer, the treatment, you can remove the lesion, but it may have spread to other organs, so we have a problem here. Colonoscopy is the gold standard tool for detecting and resecting these lesions, these polyps, but we have the issue that 22% of these polyps are missed during colonoscopy. And in Spain, you don't have a colonoscopy every year. Maybe it takes 3-4 years, and maybe it's not enough time to save the patient because the lesion can have been developed into cancer. So just to simplify this, which is a patient journey, you go to the hospital, you make a test, and then they do a colonoscopy, and you go home, you feel nice, but after 3-5 years, you start to feel bad, you go to the hospital, and then bad news. So the role of these AI systems is not to substitute clinicians at all, is to assist them in this first exploration so they can have a second opinion and for sure try to improve the detection and diagnosis of the lesion so the patient can be started to be treated earlier and the survival rate of the patient can increase. So, and now I'm working also on gastric cancer, which is the 5th most prevalent worldwide, with over 1 million new cases reported in 2020. I'm giving 2020 data because it's the last official data worldwide. And in this case, the standard tool is the esophagogastroduodenoscopy, but up to 10% of the lesions are missed during this gastroduodenoscopy. And the lack of cleanliness and pure mucosal visibility harms the diagnosis capabilities. So in this case, our task is to do an automatic assessment of the degree of cleanliness in these EGD images. So in case the stomach is not clean enough, we can ask the clinician to clean it further or to repeat intervention in another day where the stomach is cleaner. So this is the team I'm working in. This is me. This is my fellow Javier Sánchez Daniel Tudela and two undergraduate students, Neil de la Fuente and Mireia Mayo. We are working in CBC UAB, but as I told you before, we also work closely with Hospital Clinic. In this case, we have Gloria Fernandez and Henry Cordova, which are our clinical support team. I'm going to present the general basis of our work. In colonoscopy, we envision 3-4 main tasks, which is, first of all, detecting the lesion, if we have or not a polyp in an image. If we have it or we say we have it, where it is. Then we segment the lesion and do in vivo diagnosis by analyzing the content of this segmented lesion. But, well, one of the key problems here, and I think I mentioned before earlier this morning, is that the problem is the data. We can develop very powerful algorithms, AI-assisted algorithms, but without data we are nothing. We are in CBC, we have developed 6 different public annotated datasets that anyone can download, anyone can access for research purposes for sure. And the last one is Polyp-SEM-ASH that has over 1,000 images. But in this case, we are aiming at 3 different types of lesions, which are adenomas, serrated adenomas, and hyperplastic. I'm pointing this out because, as you may see in this image, 80% of the images are more or less adenomas. And the real clinical challenge is to be able to accurately diagnose these underrepresented lesions, which are serrated adenomas and hyperplastic. Serrated adenomas can develop into cancer, but they are not always cancer. And hyperplastic polyps are those that are benign, so they will not develop into cancer. But if you remove them to the patient, it will take time, it will cost money, and it is unnecessary. So it is good for us to be able to accurately say to the clinician that this is a good polyp, this is a bad polyp. So, just a brief reminder, detection is presence of accents, and localization is if we have the exact location of the polyp in the image. We have our current studies, we are using fine-tuning or pre-trained models on coloscopic video frames. We are using the latest models of YOLO, which is a very popular object detection network, in case YOLO V9E, but our better results are with YOLO V9C. We are using our dataset that is publicly available, and it's part of the international challenge. Our current results show that the quality of detection depends on the evaluated video. There are some videos that we perform pretty well, some videos that we perform pretty bad. But these videos that we perform pretty bad is because they have few polyps, there are a lot of fecal content, things like that. We have a very short reaction time, so the number of frames between when the polyp first appears and the first detection is 1-2 frames. We have a state-of-the-art performance in polyp detection, and we are able to detect all the polyps in the different videos, maybe not all the frames, but all the polyps. Just a video that we have also incorporated a tracking module, so because clinician doesn't want to have this flickering effect when the detection appears and disappears. So we have incorporated a tracking module, so the detection is more consistent. And important to say that we are doing this in less than 30 milliseconds, so we are real-time capable. The next application is, well, segmentation to provide an outline of the polyp and then to be able to determine if the polyp is malign or benign. In this case, we are using swing transformer. We are using transformer architectures like they have been shown earlier before, and with an additional convolution block. And our method is able to achieve a state-of-the-art quality in binary segmentation, which is polyp or non-polyp in the image, but we struggle a little when we go for semantic segmentation, that is to say if the polyp is adenoma, serrated sessile, or hyperplastic. That is because our data set is clearly unbalanced, and we have problems with this. Even though we have using weighted losses and things like that, we are not able to achieve good segmentation results yet. For gastrointestinal endoscopy, just for you to know, there are 2 different public scales to determine the degree of cleanliness of the stomach. We have the polyp prep and the Barcelona scale. The difference between them is that the Barcelona scale divides the stomach in different segments, so you can have an accurate degree of cleanliness of the different 5 parts of the in this case of the scale. And we have three different levels, which are 2, which is absence of any rest, almost clean, from 0, where you have non-aspirable solid or semi-solid substances that doesn't allow you to visualize most of the parts of the mucosa. We are using, in this case, EfficientNet v2 to classify the degree of cleanliness, and well, with this, we have a compound scaling method. We are able to optimize the depth of the model, the width and the resolution, because again, we want to be real time, we want to be fast, apart from accurate. Our results, well, first of all, the data set in this case is more balanced than the other one, so we have almost 30% mean of data in the other 3 classes, but the problem is that we have only 125 images, which is pretty small if you want to build a network from scratch, so we are using fine-tuning, in this case, paradigms. Our results show that we are very good doing the almost clean and very dirty classes, but we are bad in the class in between. We decided that why not merging 2 classes, in this case, class 01 against 2, which is the more or less clean against the dirty one, and we got 96% of accuracy, but anyway, we have to be more accurate in this class in between, but again, we need more data. Our system is already real-time capable. We are less than 20 milliseconds to process an image, so in this case, we are ready to be deployed in the exploration room for this task. The conclusion and challenges of this talk is that, well, AI, as my fellows have said, is here to stay. Resistance is futile, as you have said, but we need humans. You need humans, first of all, to acquire data, to annotate data, and to validate what we are doing, and for sure, to guide us on what we should do next. Computer science is great, machine learning is great, but we have to do things with a purpose. We have to solve actual clinical needs. If the clinician does not need for us to segment a polyp in colors, we don't have to do it. So we need humans, we need clinicians to be part of our team. We don't have to be isolated, computers on one side and technicians on the other side. We have to work together. Our results show, first of all, that there is a great impact of our publicly available data sets, because people need data to work on this, but our performance is limited by the quantity and variability of the data, so we cannot identify what we have never seen. So our new research line we are working is to generate synthetic and realistic data, for sure validated by clinicians. And another conclusion is that isolated efforts are not enough to reach clinical usability. We need to be together, technician and clinician. We need to build networks, and that's why we have created the first national network on AI for colonoscopy, AI for PolypNet, that I coordinate. So, in case you're interested, if you are a part of a Spanish research group, either technician or clinicians, we are open to more members in our network. It's been a pleasure to talk to you. For sure, this wouldn't have been possible with the support from Ministerio of Ciencia y Innovación. And if you have any question or you have any comment, I will be happy to answer them.
Questions? All right, please go ahead.
I can speak up. How much data would you need, actually? Because you say, okay, 120 images is not enough.
Depends on the application. For cleanliness of the stomach, if I want to build a network from scratch, this is not that I say that I want to do it, but if I want to do it, I am talking about tens of thousands of images. If I want to be able to discriminate good between the classes. With 125 images, I can get to up to some level, but not more. So the problem is the class in between. With respect to colonoscopy, I have thousands of images, but the problem is that, let's say, 80% of the images belong to the same class. And the machine learning, deep learning models tend to have a bias towards the majority class. I can do things to try to eliminate this bias, but this bias is inevitable. And above all, clinicians are now, they want now for us to discriminate even between more classes. So not only 3 types of polyp, like good, middle, bad, but bad, they want for us to discriminate between bad, the baddest, the worst ever. The problem is that some of these cases are very important from a clinical point of view, but they are not so common. So to have lots of images from these cases is very rare. Maybe in a hospital you get 3-4 images per month. To 3-4 images per month, let's say 50 images per year, to build a database from this is nearly impossible. So our take now is, well, the technology is almost there, but let's join effort between hospital and research centers in Spain and Europe and the world to create a data set that can be good for everyone. Because if not, when you see papers, there are lots of papers on colonoscopy. Every month, 3 or 4 papers on colonoscopy, but all in private data sets with 300 images. But we are not attacking the problem. We are solving a small problem, but not the whole problem. So our take is technology is there, but we need clinicians, we need human people to create data and to let us focus on the actual clinical needs. But as you said, 125 images is pretty small. Pretty small.
And maybe a second question then, you say you want to keep the human in the loop, but annotating is probably one of the most boring jobs. Yeah. And if you want to do 10,000 things?
I have annotated more than 30,000 specular highlights, not polyp, specular highlights in colonoscopy images, and it took me 3 months. So annotating is pretty bad. But my take is, I don't want them to annotate directly, but maybe I can provide the output of a segmentation method, and they can validate if it is good or bad. Not doing the full annotation, but to correct the possible mistakes that they may have, or just to validate good or bad, because I know that annotating takes time and it costs money.
But for that, could you not use AI as well?
Sorry?
Could you not use AI for that in the end as well?
No, that's why I'm saying I want to use AI to guide, but I want them to validate, because AI is good, but it's not perfect. AI can make mistakes. Because, just a small comment, my students use AI for doing my computer vision courses, but AI, ChatGPT, is not able to do a convolution good. So they rely on the answer of ChatGPT, and they put it in the exam, and I'm like, no. But ChatGPT is not perfect. Sometimes you have to do things on your own.
Very good, Jorge. Humans neither. That's what I'm a colorectal surgeon, so I'm in the business. And one of the main problems we have is not that we didn't do the colonoscopy, or is the missed lesion. Most of them are flat lesions, and colonoscopists don't see them. So the problem, my question is, how are you going to make sure that you get all the polyps? Because most of those lesions that are missed are flat lesions, and gastroenterologists, colonoscopists, don't see them. So the problem is you are going to identify those who they usually identify. The problem is the missed lesion, which represents, flat lesions represent around 50% of the missed polyps, and missed polyps represent the majority of cancers not found and not worked out because of prevention methods. So the problem is, how are you going to identify those that they don't identify?
First of all, we need images, we need examples with flat polyps that maybe they are seen in some exploration.
Yeah, because the pedunculated polyps are very easy.
No, for sure.
The problem is the flat lesion. That's why they are missed.
How about MRI colonoscopy or CT? I prefer MRI. You see the wall, and then you see the flat lesion.
In this case, I never touched MRI or CT because of one reason. Because I work with I also work only with white light, not MVI, not because I want my system to be used in every hospital, not only in the major hospital that have Olympus, etc., for whatever. I want to be used in a small hospital too. So I'm working with white light colonoscopy. The problem with CT is that you need two explorations. You first need to scan the patient and then to go to a colonoscopy. So it takes time, it takes more money. And MRI, again, it needs some expertise, and not every hospital has MRI. That's
just we talked about the question of the flat lesion.
The flat lesion.
Your system, absolutely agree, is for everyone, and there should be. But how can you get to the flat lesion? And I just raised this point of the image detection, but we might have other ideas how this can be improved.
Oh, for sure. I mean, I think that some kind of lesions, like some kind of diagnosis, need a combination of additional image modalities. I mean, I think with only white light, some flat lesions are nearly impossible to detect.
The problem is that for prevention, you cannot combine colonoscopy plus MRI.
No,
The problem is the flat lesion.
They show it very nicely. And there are some centers that do the MRI, CT, colonoscopy, and then they find something, the endoscopy is prepared. But imagine you have to always keep, after an exam, an endoscopist ready. So it's, as you said, too costly, too effortsome. But perhaps AI, when you go with your endoscope through the colon, is so clever at some point that it sees the wall is not reacting well, and there is something, and you can be pointed, look there is something.
We have to work on this, and we also have to work in, there are new type of endoscope that have, instead of one camera, they have 3 cameras. We have new endoscopes that we can work on this.
But we would never be able to, but AI is so sensitive to see these subtle changes in white light. Anyway, I think we have to move on. Thank you, it was a great discussion. So, I have the great honor and opportunity to announce the John Wickham Lecture, which is... Yeah. That's too late. Huh?
I have to go because I have another presentation now.
Yeah.
Sorry.
So, yeah, the John Wickham Lecture is something I'm particularly happy that we have introduced it, because John Wickham is the founder of the ISMIT Society, and he, a very unique individual, pioneered really this way of, his term, minimally invasive. And he had a good example. When you have kidney stones, you do surgery, it's very major invasive. You may get with a loop, with a scope, but then the lithotripsy appeared. Unfortunately, we know lithotripsy was not so successful, but it was the source of developing focused ultrasound treatment, because it destroys the kidney to some extent. Nonetheless, this was his vision, and he was always towards the reduction of the invasiveness for the patients. He's also an inventor and helped to develop new systems, new technology, and then he founded the society. Unfortunately, passed away in 2017. It's a nice book, An Open and Shut Case, the story of keyhole or minimally invasive surgery. So I have a great honor now to hand over to the moderator, which is our president here, and particularly honor that Krishna Kandapa, I think I will learn it, a great person, and he will be introduced by Francisco.
Thank you very much. Thank you. It's my pleasure to introduce you Dr. Krishna Kandarpa. He is a cardiovascular interventional radiologist and director of research sciences and strategic directions at National Institute of Biomedical Imaging and Bioengineering, NIH, in United States. At the NIH, he led key programs in artificial intelligence applications in medical imaging. Prior to joining the NIH, he worked at Delcath system in Manhattan, in New York, where his team developed a minimally invasive combination of devices and drug treatments for liver tumors, and received FDA approval in 2024. He was professor and chair of radiology in the University of Massachusetts Medical School and radiologist in chief of University of Massachusetts. At the Wales Medical College of Cornell University, he was a professor of radiology, chief of service in interventional radiology, director at the New York Presbyterian Hospital, and a professor at the College of Physicians and Surgeons of Columbia University. He was also professor at the Harvard Medical School and a co-director of the Interventional Radiology Division at the Brigham Women's Hospital. And he was also a faculty member at the Harvard MIT Health Sciences and Technology program in Boston, Massachusetts. Dr. Kandarpa, it's an honor.
Thank you very much. I'm honored that you invited me, and especially to get a named lecture after Dr. Wickman. I am, as you said, I'm an engineer before going to medical school, and I'm always trying to bridge between physicians and engineers. So naturally, one or the other group thinks I'm a fool because I don't say everything that there is to be said, right? So if you'll excuse me, I will tell you about the National Institute of Biomedical Imaging and Bioengineering to begin with. It was an effort on the part of the radiologists, physicists, imaging physicists, and many in industry to get a specific institute within the NIH dedicated to bioengineering and bioimaging. There was a lot of resistance, as you can imagine, another institute at the NIH, no, we can't do it, and so forth. But ultimately in the year 2000, President Clinton, as he was going out the door, signed NIBIB into law. And I was part of the Academy of Radiology Research at the time, now known as ARBIR. And little did I think that I would be one day working for NIBIB. But here I am. So NIBIB is founded on four, can you see the marker there? You can't see it, can you? It's okay. It has four pillars. It's the imaging technologies, therapeutic technologies, engineering biology, and senses and point of care. And these four areas of focus are tied together by data science, modeling, and computation. Now, the emphasis of NIBIB is it's all technology and innovation focused. It cannot be incremental. In other words, if you apply for a grant to the NIBIB, you can't say, well, I have a new pulse sequence protocol for MRI. We'd rather you had some sort of a new MRI unit. So our purpose is, again, not disease-focused, but modality-focused to enable the understanding, prevention, and detection of disease, to personalize diagnosis and treatment. In that sense, the word precision medicine keeps coming up. To extend the healthy lifespan, anyone can age, but not everyone ages well. It's also to reduce the technical costs and the disparities and barriers to access that many patients, even within the United States, have, and clearly outside also. And the whole idea here is to drive innovation through entrepreneurship and external partnerships. So you all probably know, I'm speaking to experts here, that the trends in medical imaging is to go faster, better, smaller, cheaper, and more accessible. Also, we're constantly trying to lower the radiation dose where the imaging requires radiation, or energy deposition such as an MRI unit, except of course when we really actually want to deposit energy in a controlled way. The other interest of late has been tissue composition, characterization, and motion evaluation. The composition characterization comes not just from for biological function, but also for mechanical properties. And all of this we want to do without compromising image quality or the quantity of information content within what we're acquiring. And we believe this is the approach will drive diagnostic precision and accuracy. The other trend, again, which you've seen amply in this meeting, is we're going away from the simple anatomical imaging to functional and physiological motion evaluation as well with our imaging devices. And we're going simply from image-guided. By the way, when I say interventional radiology, I say image-guided or minimally invasive therapy. They're all the same. Interventional radiology happened to be the name that came very early by Charles Dotter at the end of, at the beginning of the 60s. He even made Life magazine by introducing minimally, or what I guess we can now call ultra minimally invasive therapies. So we're going from simply image guided to information guided. That's multimodal information that can contribute to a more precise diagnosis. I don't know how many radiologists there are in our audience, but usually when the radiologist makes the interpretation, the consulting physician will come in and give more information, and then the radiologist fine-tunes the decision, the diagnosis perhaps. That's the same thing we're asking of the computers, but to do it with much more information, which can be humanly a task for humans. Now, we're doing all of this at the dawn, I call it, artificial intelligence. That's your dawn of artificial intelligence in medicine. It's certainly not the dawn of artificial intelligence per se, which goes back at least 50 years or more. And we're going from the very simple things like segmentation that everybody talks about, a computer-aided diagnosis, to the more sophisticated and unexplainable deep learning convolutional neural networks, and God knows where we'll go from there. So focusing on the talk today, it's mostly about imaging and therapeutics. And we have a very great presence in it. And imaging technologies, as you know, require computation, modeling, data science, and image formation and evaluation. As such, AI is a statistical method and a highly mathematical method. The source, detector, and object, signal and noise characteristics are well understood performance limiting factors of all of these modalities, so one has to correct for that. But I think where radiology has leapfrogged every other specialty in the use of artificial intelligence is because over 20, going almost on 30 years now, the RSNA, ACR, and I think AAPM, yeah, the three big ones, decided they were going to have standardized digital communication for images. And that's called the DICOM standards, which are universal now and are serving very well in entering into the artificial intelligence era. Of course, many of the models that are used today are hybrid mechanistic models. They try to optimize the invisible that many people have talked about. Is there more information just than catches the eye of the radiologist? I mean, segmentation, again, not to put it down, but it's a simple AI task compared to everything else. But because we're going into neural networks, we really don't understand these black boxes. The great emphasis, I'm sure here too, but I certainly in the US and especially for the Defense Department, is the explainability of what these algorithms are telling you, or these models are telling you. And when it comes to seeking ground truth, that question is intensified with AI when it's applied to IR. Or any of the modalities we're talking here. Now, I don't want to stay on this slide other than to show, because actually the vertical scale is off, other than to show that there's an increasing trend in the NIH funding of these of AI applications. Imaging alone has gone up only 35% in the last 5 years. In the last 10 years, the NIH budget has doubled, but you'll see that some of these have gone more than double. For example, AI and ML alone have gone up about 3 times. IR investments have gone up about 4.5 times, and the combination of AI and IR has gone up by 2.5. The numbers are small, but the trends are clearly there. And this is the trend that one should really pay attention. This is the FDA clearance of AI ML algorithms in the last 10 years. And you will see there that radiology is the #1 with over 3/4 of the approvals in the radiology field. There's also cardiovascular and neurology, you'll see, but even there's imaging. So if you add that, then clearly imaging and radiology are way up there. As of last year, no algorithms that have used generative AI or artificial general intelligence or even large language models like ChatGPT have been approved, and it's not likely they're going to be approved very soon because it is a very complicated process. Now, the models that we have right now range in complexity from the shallow ML that most of us understand, I think, to multi-layered deep learning, which I've mentioned. And the kinds of approvals are based on hybrid methods, one to find the lesion, if you will, and another one to classify the lesion. Now, in this slide, the most important thing is the panel at the right bottom. What it shows you is that from now on, where we were at 20 billion in global market, we're going to be increasing at the rate of 50% a year till the year 2029, and God knows more, to a level of $150 billion in worldwide investment in AI, in all of healthcare. That's not just imaging. So it's coming whether we like it or not. And these I don't have to tell you because most of you probably know data science better than I do, but there are opportunities for AI in IR. One is in workflow efficiency, report generation, especially in the day-to-day workflow. The automation of protocols of imaging and dosimetry, selection of devices, catheters, etc., based on the patient. And an example would be, for example, a triple, if you're trying to repair an abdominal aortic aneurysm with a stent graft, well, typically you do your segmentation and send it off to a factory in a company in New Hampshire, and they'll send you back a made-to-fit prosthesis for the individual patient. That's if you have time and they're not leaking. Of course, there's also a role for quantification, localization, and prediction of disease, which we've seen here today, and very true vascular and oncological interventions that are done with needles only. And of course, it's important for us to know about navigation, how to register images, maybe between two different modalities. And where I think AI will have a great role is in assessing response to treatment and even providing maybe predictive trajectories of health in the future. It can also help us avoid biopsies in many situations and in selecting target treatments. Now, the problems are that, as we were just talking with Dr. Bernal and all, there is not enough data to generate anything. Not only is there not enough data, as he insinuated, there's a lot of garbage. I mean, everyone's got papers there. When COVID first hit the world, there were, within 6 months, at least 30 papers that I'm aware of. None of them were considered decent papers. There was an MIT review that said none of them is good because the data that went in was horrible. It came from different places. They didn't even do things right. But we had already been thinking about what AI applications we could do in imaging. So I'll show you in subsequent slides what we did. Now, the other issue, other than not having enough data, is the security and privacy issue. I mean, transferring data, and many hospitals do not want to share data, and it's not because they're trying to protect their patients. They're trying to monetize it and sell it to the big players, which I think is also unfortunate. So as someone said, data labeling and annotation is hugely expensive, and if you're going to pay a radiologist to do that, it gets even more expensive. So automated annotation and labeling technologies, again from AI, are being developed. There are also variations in anatomy, so the systems have to be aware of that, and they are. For example, pancreas is one of the hardest organs to segment. And of course, there are also differences in practice and skill sets of those who are going to be annotating. The other is, of course, and this is true to Heinz's heart, is picking the right model for the problem you're trying to solve. You know, and we have, for example, tons of models for one particular disease. Everyone's trying to do the same thing. We need something more general, but not something so general that it's useless. The other thing is, even in countries, when I say even in countries, like in America, where there's an effort to do standardization, we don't have it, okay? And I'm sure you don't have it in Europe. It certainly doesn't exist in most parts of the world. People report the way they want to, they practice the way they want to, and endpoints can also differ. So we need to, before we go global, at least, you know, the larger groups of developers should get standardization and think about it. So I'll talk about two areas where, of AI where NIBRB is providing substantial support. One is purely for imaging, which will, of course, speak to subsequent interventions. But the other one is also algorithms that help and while a device is being developed for the optimization of a procedure, performance of a procedure. Now, in the innovation, in the second category, of course, there's pre-procedure planning, where you analyze diverse data for treatment selection, improve pre-treatment imaging for target identification, assess critical structures, and of course, visualize a path for navigating to the target without hitting anything in the way. Interprocedurally, it's the same things will apply, but also you want to enhance and integrate multimodal visualization. Someone was talking about fusion imaging, which is what we also do support, and sensor-derived information that can also be used during the procedure. And we look for feedback for such as position, force, and haptic feedback that people have been talking about. Most importantly, the device has to alert you if you're going off the intended navigation path. So if we can plot a path for us, it would be fantastic. Post-procedure, of course, we know you want to see if there are complications, if there's residual disease. We want to prevent recurrences and ensure that the procedure actually is efficacious. Now you can see that by building on these concepts and by having a lot of data, we might actually be able to get decent predictive models if we do everything properly and by the book. So in terms of the, as an example of one of the data repositories we have funded in a big way is what's called the Medical Imaging and Data Resource Center, midric.org. Any one of you can go in there. And we funded it. It's a three-way collaboration between the RSNA, ACR, and the American Association of Physicists in Medicine. That is a strong combination. These are the same people who came up with DICOM. The center is at the University of Chicago, run by Mary Ellen Geiger, who many of you may know. She's like a superstar of AI in imaging. She started her own companies in breast imaging and so forth. And it's all, you can get all the results of Gen 3 through the Gen 3 portal at the University of Chicago. And what are the results you'll get? They are AI-ready, highly clean, highly reliable AI images. Now, it was funded, we were planning it before, we were looking for use cases. When COVID came, unfortunately for all of us, we got money into this system and we gave the contract to these people. And the whole idea was to study acute COVID and to enable diagnosis and other things that you see listed there. And of course, then we went to the long COVID era, and also, so the funding continued, and they have a lot of long COVID studies also. Now, they are an open discovery data commons. They're in 24 different institutions across the United States with 100+ investigators. And what they're basically doing is creating the commons, testing, doing quality assurance, and data interoperability or connectivity. And there's also a second wing where they actually develop machine intelligence algorithms and so forth. And these have to be clinically relevant. Obviously, the first few, the 30 whatever, they're all COVID related. But I will tell you a little later that they've gone beyond COVID. But what happens at MIDRIC is, you see the first arrow from the very right, you have RSNA and ACR feeding in images, because RSNA has access worldwide, and ACR has a connection to almost every hospital in the United States. So in the first 3 years, that is, they have collected 570,000 images already, and these are cases, I should say, not images, because each case, if it's a CT scan, for example, is many more images. So these are cases. They have released 177,000. I bet you by today it's about 200,000. And what they do before releasing is they de-identify, they curate the image, make sure it's actually a chest PA and not a chest lateral. They'll do quality control in terms of, because for example, if you get ICU images of the chest, the patient's lying down, I mean, there's a whole lot of things that they have to accommodate for. And then they annotate these images and they harmonize all of them so you know that they're of a certain quality and go out to your door. Now, of all the images that have been given out, and by the way, this amounts to over 70,000 patients at this time, and of all the images that have gone out, about 80% of them are available to the public. And since it came from tax dollars, anyone, anywhere can go and download those images to do your own AI ML algorithms. And the AI ML ready, as I said, they're fair and searchable, trustworthy, representative, and interoperable. Now, 20% of the data we hide away from everybody except a couple of people at the FDA. They have this 20% are available, that the FDA and we developed this system so that we could test any algorithms given to them on this data, which the rest of the world does not know about. And it can be done in a way that they cannot learn. We just tell them, this is how your algorithm performed, but we won't tell them what to correct or whatever. So that has been a success. I'll go back to it in a little second. But they have a growing library of annotations. They have a growing library of everything, actually. And this is they use challenges for looking at lung edema, for example. That's expert annotation, human beings. And they also have a method of automatic annotation, which they've used for chest X-rays. And if you're interested, there's a QR code. Please use it. And this is one of the major contributions that they've made. And this is a bias awareness tool. As I said, and I mean, much repeated data in, data garbage in, garbage out. So if you have an algorithm you're trying to develop, now specifically in chest X-ray, let's say chest, okay, because they are collecting non-chest, non-X-ray, they're doing MRI and ultrasound, they're all being collected. You will be able to tell if your the data you're using is biased or not, whether data preparation is biased, and or no matter what, your model evaluation, your model deployment, anywhere where there's a bias, it'll give you a score, and it'll tell you how to repair it. And this is free. You just have to go to midric.org and look it up. And it's successful enough that the FDA has adopted parts of it for regulating some algorithms. So Midric has, fortunately for us, been a good success. Let me go one. I thought we changed this slide. Yeah, okay. Yeah, so in the United States, you probably heard of DARPA. It's a Defense Advanced Research Projects Agency. Now, that has been broken into ARPA-D for defense, ARPA-H for health, and ARPA-E for energy. And the ARPA-H people who we work with have started what's known as a biomedical data fabric toolbox, and they've chosen a performance, or they're the nodes within this toolbox, and Midric's been chosen to be the ones who will take in all the images and clean them up for the other performers to use. So this has just started this year. It's very early. It'll go for at least 10 years, we're hoping, and by that time you'll be able to do a lot of medical AI through this facility. And I believe it's available to everybody. It's not US only. So the first use case in this with ARPA-H BDF is cancer, so all kinds of cancer. So NCI is leading it. We're doing all the data science and technology for it. The other thing that's happened in the United States is that President Biden has a strong interest in AI, and so he's made it so there's about $3 billion over the next 6 years for investment in a national infrastructure for AI. Now, this is not all medicine. Parts of it's a medicine, parts of energy, any kind of AI within the United States. But again, here, Midric was picked as the pilot program for NAIR in its health section, if you will. Just stop, before I go on to the IR AI bit, I just wanted to show you this because we have P41 centers, and the one in Duke collects a lot of phantoms of of human being phantoms, and it reproduces these movies, if you will, but also builds a phantom for pre-radiation studies and so forth. And what they have actually done is they've built 2 phantoms of average humans, I guess, and sent them to the moon on their Themis capsule that's come back already. And on that, they have put in sensors at different parts of the body to determine radiation dose exposure to the astronaut. We could never do that on real astronauts, but now we can do it on realistic twins of astronauts. And then, then they'll study it and see what needs to be done in terms of helping astronauts avoid this radiation. That's one use of AI in imaging in twins. But moving to IR, what we're doing here is trying to improve the performance of interventional radiology or minimally invasive therapy, or whatever you want. Some of what I'll be talking to is very close to what has been talked about. And so the idea is to enhance image contrast by any methods you can without actually injecting contrast solutions necessarily, improving resolution and increasing the target tissue information content. And of course, improving the integration of IR systems and their performance. So this, I hope it works. So this is so these are the kinds of technologies we pay for. I mean, they'll apply to us and we'll say, okay, yeah, this sounds good. So this is a forward-looking ultrasound probe, and it looks at the lumen in front, it segments the lumen, and also, although those look like scratchy ultrasound images, obviously, but it'll show the interventionalist the path that there is actually an open lumen that you can access and move through. So that's one use of ultrasound for guiding cardiovascular procedures. And of course, once you're where you want to be, you can swap out for a guide wire and do your procedure. This is very clever. It's actually my boss who is technology. It's an endovascular tissue composition using a miniaturized, ultra-fast optical coherence tomography unit and ultrasound system. Now, it can be done at 72 frames per second. What happens if you use them individually is, I mean, this ultrasound's much slower than OCT, so you can, by using them in combination, you can use both. But the other thing is also that if you use them separately, they only agree 2% of the time. So here you're looking at it simultaneously. So what you're doing here is with the OCT, you're able to see that pink bar which says lipid. Unfortunately, I don't have a pointer. I'll show you. And then next to it, more towards the right, is the ultrasound image, in endovascular ultrasound. So you see not only the intima, which is because OCT doesn't penetrate that well, but you also see what's beneath it, and you see the plaques, the intima media, and adventitia, etc. This is the similar, by the way, let me go back just one. Because it's got OCT and ultrasound, you can actually get the tissue mechanical property information out of that as well. That's the stage where they're at now, and it's also being tested in coronary arteries. Now, as you know, OCT and polarimetry, OCT is very sensitive polarimetry. So in other words, you emit light and then it gets polarized, and it's an additional contrast mechanism when you're using OCT. And it's obviously compatible with the catheters. It's tissue to the tissue microstructure, to plaque composition and stability. Obviously, that's what we're looking for, is stability, because these are the flaps that will suddenly dissect into the coronary artery and give you a heart attack. So this is also allows, because of the nature of imaging, for segmentation, and it also tells you where the internal elastic lamp and all the different layers, as I said, will be, relative to the plaque. This is an MR. I think this is the one where I have to actually run the, oh good. And that doesn't show me, oh, here you go. Excuse me, I'm glad we have time. Oh, okay, let's try, there you go. All right, so what this is showing is it's pre-mapped the left atrium, the pulmonary vessels coming into it, and it shows you the area where the arrhythmic focus is, and that red ring is what they want to ablate. Now, you'll see that it's a left atrium, so they basically going through through the atrial septal defect. I mean, they close after you're born, but you can't make your way through because they're like intercepting septums there. So they go into the left atrium, and they can ablate it and hold it there, and it will tell them when it's done. And with the image you're seeing on your right is the MRI of the heart and the catheter moving within it, and there are 4 coils that are color-coded, so you know exactly where the catheter tip is, and you achieve your ablation by virtue of that. Okay. This is interesting to me as an interventional radiologist or even vascular surgeons. You know, when you have abdominal aortic aneurysms, the standard is, well, look, it's almost 5 centimeters in diameter. We have to do something about it. You know, either stent graft it or we will have to go do surgery. But that's like primitive thinking, because it's not the diameter that'll cause the problem, but rather the structure of the aortic vessel wall. So what here they've done is they've used ultrasound to query the wall, and they're looking for regional strain accumulations. They put a finite element mesh on it, and they can tell you where the strains are based on the strands and assumed properties of the wall, or measured properties of the wall. You can tell what the stresses are as well. So it'll consider tissue stiffness and the stress on the aortic wall, and that's what, the extra stress is what will make the wall rupture, not the diameter. So if you look at the ultrasound images themselves, on the extreme left, you'll see they're both 4.7 centimeter diameter aneurysms, but the one on the extreme left is growing at a rate of 0.1 centimeter a year, and also it has less strain differences within the wall and regional differences and strain accumulation. Whereas the one in the middle, the right side, you'll see that the very colorful wall, and that shows all the strain differences and the stiffness differences within the wall, which are what, with adequate fatigue loading, as it were, with the pulsations, will cause it to rupture. So that's the one you should repair, and not the one on the extreme left. Also, if you do not repair it when it looks like the extreme left, you might have medical options to slow down aneurysm formation. And no one's actually studied that, but that's an opportunity to study it. This is a fast DSA at lower dose radiation. In other words, they use low frame rate DSA acquisition, 7.5, and they speed it up artificially to 17 frames per second. And they do it so that there's no strobe effect of adding images or in between images. Now they use two learning. One is the independent component analysis, and that's the component analysis that looks at the blood flow, looks at the arterial, the capillary, and the venous, and it separates them. And in addition to that, they use convoluted neural networks to get the spatial separation. Now, and then they impose all of these, and you'll see the red coming in on the very left, and then you see the AVM in green, and then all the blue, which is the blood leaving by the veins. Now, this, of course, if you have a large AVM, intracranial AVM, it's no big deal. You can see it, or you can struggle with it. But this will, if you look at small AVMs, and sometimes they can be multiple, this is a very good technology to have, and a good application of AI. Moving on from vascular to oncological, I'm sure some of you are familiar with magnetic resonance elastography. And here's what you use ultrasound to perturb the tissue, the liver tissue. And of course, at photoacoustics, where you're doing the opposite, you're using light, and then you're listening with the ultrasound. Here, you're using ultrasound excite, and you are detecting the signal, the return signal with MR. And it is a very good way, an approved way, of looking for liver stiffness. That's very important because most of these patients cannot sustain a biopsy, so you can completely avoid a biopsy. And this is Richard Lehman out of the Mayo Clinic who came up with this idea. And now what they're doing is it measures like focal. If you have an individual tumor, it'll even tell you the tumor stiffness. And they've tried it in the brain, and they can tell tumors in the brain that are encapsulated and then just can be removed, or ones that are so entangled that they're not amenable to be removed. But this technique also gives you, as you will see in this bottom right here, all the other modalities that an engineer would be happy to have, such as shear stress modulus and so forth, and stiffness. But that not necessarily. It's not something that comes to doctors' minds, but someday this might have implications for diagnosis as well. Then there's the high-definition microvascular imaging. It's a very, I'm sure some of the ultrasound experts you will know, it's a very new technique, cutting edge, that can look at very small vessels. Within, in this particular case, it's a thyroid, and obviously it's a superficial organ. They're acquiring images at 60 frames per second on a model-based Doppler ultrasound technique, and they can look at very small vessels. We're taking sub-millimeter vessels. And the way they find tumors is by looking at tumor vascularity, the tortuosity, the excessive bifurcations, almost like an AVM, but except even worse and messy. So based on that, they have done studies, and in 92 thyroid lesions, they've been able to pick up 89 malignant lesions, which is very interesting. And so now they're moving on to kidneys and liver. So that's if you will, a microvessel application of ultrasound technology. Here, what we're doing is, I think I'm supposed to click here. Okay, I click that, and I click that. Sometimes they come in, it's one at a time. That is supposed to be the top is normal, bottom is where the tumors are found. Here it's called quantitative breast acoustic computed tomography. So again, you use the photoacoustic laser perturbation and ultrasound detection. And what you're looking at here is oxygen saturation and hemoglobin contrast. So based on the oxygen saturation, you can tell whether it's artery or vein, and then you use your AI systems to tell you where the tumor is. And actually, it's pretty clever. By the way, all of this I'm showing you're going to say, well, why aren't people using it? Because they're just fresh out of the fact, and they have to be tested further. They're just technologies that have just been developed, and they will certainly come out again. This is to answer the question about the flat polyp. This might have some application. This is called label-free, no contrast, fluorescence lifetime imaging microscopy. So many molecules of fluorophores have the structure that if you hit them with light, they will emit fluorescence, which will die with time. And that fluorescence emission is based on what type of molecule it is and on its microenvironment as well. So by looking at, if you follow the top, boy, this thing's got a brain of its own. Oh, okay. So what you're looking at, there's basically hitting it with a laser, no contrast, looking at the time decay of the photon emissions, looking at the area under the curve, I guess, and then telling you the difference between normal tissue and cancerous tissue, and they're using it in robotic transoral surgery. There are two examples below. One is mapping the probability of tumor, oral tumors, tongue-based, and tonsils. And on the bottom right is detecting positive margins in oral surgery, which it also does well at. But I believe that if you can put this on an endoscope, you probably can see a flat. I'm guessing, but I don't see why it wouldn't work. You can see a flat lesion and say if it's malignant or not, because after all, that's what you are at. Now, I've shown you a lot of these technologies that are young, but I'm going to show you this, and you're going to say, well, what's so great about this, right? Well, this thing is about 15 years old. It was funded by the NIBIB, and basically because some people are talking about how organs move from imaging to OR. So what you do is you image the patient in the same position as you intend to operate, and then you take an MRI image and you just fuse it. Again, I said there's nothing new about this, but it's now hit the market in a big way, and a lot of people are doing it. It was a novelty 15 years ago. So we have a low radiation lowering initiative, and during that initiative, the people at Mayo Clinic, Cynthia McCullough, and others came up with the idea, and some people at GE came up with the idea of the dual energy of photon counting CT, which took a few years to develop, but now it's approved and it's available in America. We have one at the NIH, obviously it was developed there, but it's going to find its way. And it gives you such fine detail and texture and resolution, and the signal emitted is by the number of photons that are within the pixel you're looking at. So you can actually try to get many energies. The dual energies are that only two energies. If you get many energies, then you can actually color code the image, and you have what is known as a color CT, which I've seen, but you can also inject contrast agents and further improve the information in there, so you can have a really beautiful picture. But here I'm showing you just the fact that the availability of resolution is so good. So if you look, they're all three the same photon counting image. The first one is just the original image with needles put in. Second one was a commercially available artifact removal thing. And the third is they've developed their own artifact removal of the needle using photon counting CT information. And you can see it's fantastic. I could work with that easily. By the way, that's, I think, it's actually a cryoablation technique, and it helps the visualization not only of the needles, but also the ice ball when you're done, and other stuff that's very important for the execution and termination of the procedure. Now this will probably not impress a whole lot of you, but when I was at the Brigham, Andreas may remember, we had a double donut MRI unit we did in there, and I did the first human nephrostomy, and I actually published about it. And it was a horrible experience. I mean, that's how you learn, right? This is not doing what it's supposed to do. But here what you see is for MR-guided robotic interventions, the tracking, 2D tracking for prostate, and what the numbers below show you, the target, how much it's off from the target, 0.71 millimeters. That's pretty good if you can't even see lesions that small anyway. And then look at the angle correction is only about 1.5 degrees at most. And in the 3D version, it's even better. The deeper you go, the better you can approach your target. That may be slightly statistical, but it completely keeps its ability to track to the target. And now they're all AI applications, obviously, but this one, what they've done, this is from the Brigham, I believe. They have segmented all the layers that a needle could possibly encounter in going to a prostate. So naturally, you need many procedures to see how each layer is deflecting the needle, and you need to have a standard needle that doesn't deflect very much. So when you train that model, which they did, and you can get it better and better the more number of cases you put in, they've been able, for example, if you look at the blue line, that's without any guidance whatsoever. That's just trying to hit the target. You're off quite a few millimeters, 3, 4 millimeters, even 5 maybe. But with this AI correction, as it enters each layer, subcapsule layer, you'll see that the squiggles are the system trying to correct the direction, but eventually, by the time it goes down to about 9 millimeters, it's right on target, and then the blue arrow going down shows you the correction in the error. So this is a nice AI application, and this is not radiology, but pathology, but I put it in there because it's useful for everybody, radiologists and surgeons. The standard way of, you do your biopsy, you send off the specimen, it goes to path lab, sits there for a day, and it gets stained and everything, and the pathologist finally looks at it, you get a report 2 days or 3 days later, if you're lucky, maybe sooner. Here, what they've done is they've trained the system with multiple pathologists to look for the cancerous lesions. Don't know what the specific cancer is here, but so it's so well trained that if you put it into the AI system, the same slides, it scans the slide and gives you a diagnosis within seconds and minutes. Now that's very powerful, especially if you think you did not get the target, maybe you got the wrong, and you can also obviously know right away what the problems, and look at the performance of it. It's per slide accuracy is 95%, and per slide per slide and per title and per slide are both in the high 90s. So as I said, we have many what we call P41 centers. They are centers that develop technologies, and we will give them the money, but the one thing they have to do is they have to disseminate that technology to anyone who wants it, who's working in those fields, because again, it's tax dollars that are paying for it, so anything that comes out of it goes back to the taxpayer in some way. So the first one is obviously the National Center for Advanced Technologies and Image-Guided Therapy, where Andreas and I used to work at one time in our careers. The second one is the Center for OCT Research. All the OCT technologies I showed you came out of there. And the third one is the film technology development, which is the endogenous autofluorescence, where you don't need any contrast, and you can get and detect tumors. So in conclusion, Oh, good, okay. We are increasing the amount of money we put into imaging and AI. We have over the last 5 years, and we're going to be doing that in the future. There's been a proliferation of AI tools and new technologies and FDA-approved algorithms for research and commercialization. And radiology, at this point, leads the FDA AI growth, and that's why we work closely with them. And we're really not sure where IR and AI will go, but by listening to everything that's been done in surgery, I'm sure it'll go as far as well. The major challenges that remain are access to large usable data. That is the big problem that everyone's got to solve. And even, there's so much variation in data that you really want a clean data and definable data. And it's okay to say that I've trained my algorithm on such and such data and to provide limitations of the power of your algorithm. There's no shame in that. The shame is in pretending that what you've done is the final answer to everything. So we need to be standardizing our outcome measures because we want to use AI as a predictor of disease trajectory course. And of course, all of this will be for nothing if we don't get regulatory clearance. So we have to work very closely with the regulators. And of course, last big thing is clinical adoption. You can do all of this work and people say it's too much, too difficult, that's not good for anybody. So we really have to keep it so it fits into the clinical workflow. In terms of solutions, our solutions are to create these large repositories of high quality data. We don't take everything, we take what it is and we define what it is and tell you what it is. And then if you use it, we tell you where you may be weak. I mean, any algorithm that comes out of MIDRC tells you its weaknesses and its strengths. And we believe that we also have to expand engineering and medicine or engineering and physics partnerships, not just government, academia, and industry. And we think that AI is really going to help push IR into newer territories. But one of my jobs is external partnerships. So we are really very keen to make partnerships with professional societies and industry as well. Thank you very much. These are my co-workers who have contributed to this. And I didn't know, but I understand your meeting next year is in Washington, but it won't be during cherry blossom time. Thank you very much.
Thank you very much, Dr. Kandarpa, for this fantastic presentation about the combination of artificial intelligence in cardiovascular and interventional radiology. Thank you very much.
Thank you. Thank you very much. No questions? Okay, good.
Yeah.
Okay.
Thank you. We have a previous presentation, the previous session. Is here. One moment.
Francisco. Yeah, it was a small overlapping with the session before, so we're going to give the opportunity to present the brief presentation about the use of artificial intelligence developing a digital twin. So it's going to be very interesting. So let's going to give the opportunity. Thank you.
PDF.
Now we have Maya Iriba speaking about using AI to generate digital twins for minimally invasive surgery.
One second. Windows P. Duplicar. Y aquí, ¿por qué no puedo hacer ver pantalla completa? No me va a dejar.
Si quitamos esto aquí.
Ahí la tiene. Yeah, that looks good.
Y no puedo.
Okay, so I'm talking about using AI to generate digital twins for minimally invasive support surgery. First of all, my name is Amayuri Barzabala. I'm going to introduce a bit my company, then I'm going to talk about the digital twins, and then I'm going to relate this on how we are doing our research for generating the digital twins in minimally invasive surgery support. So I work for a company, for Bicomtech, which is an applied research center specialized in artificial intelligence and visual computing interaction. We are more than 260 researchers. Some of them are already postdoctoral researchers. We participate in international projects, and half of our projects are from industry. Our fields of applications are in manufacturing, in smart mobility, e-health, medical devices, digital security, ICT and media, e-government and digital energy, but the topic of today is e-health and medical devices, so this is our department. We are, I think now we are already 40 researchers. We have some active European projects. And we have different lines of research, but I belong to biomedical devices and simulation research line. So why I'm here? I'm a researcher at Bicomtech since 2019, but I'm also a PhD student at the University Carlos III. And my areas of research are surgical planning and navigation using augmented reality mainly. And now I'm digging into virtual twins to explore the conversion from virtual twins to digital twins for real-time surgery support. So before I continue, I would like to ask you a question. So, do you think that a digital twin can help the surgeon to prevent complications that may arise during surgery? Yes, I do believe that as well. So, what do we understand by a digital twin? Because I've read many papers about digital twins, but sometimes it's like complicated having this difference between virtual twins and digital twins. So I will define the digital twins as a virtual representation of a physical system, including the environment and the processes of this physical system, that is updated in real time by the exchange of information between the two systems. This was the definition of Reeves in 2014. And unlike the virtual twin, the digital twin has bidirectional communication. This is a very important thing, because sometimes when we have a digital representation, digital model, we think that that would be a digital twin, but it is not if it doesn't have the bidirectional communication. So the digital twin, therefore, is a faithful digital simulation of its physical twin. Physical changes in the physical twin are propagated in real time to the digital one updating its state, and changes in the digital twin may be used to decide actions on the physical twin. So, to know something else about digital twins, well, since 1970, the NASA creates mirrored systems to monitor unreachable physical spaces, such as for Apollo 13 mission. The digital twin term was informally introduced by Michael Reeves and its work with John Vickers from NASA in 2003. And they described the virtual product as relatively new and immature, and the data collected about physical products was limited, manually collected, and mostly paper-based. So an initial description was made as a virtual representation of a physical product containing information about a said product with its origins in the field of product life management. for the moment, the new advances in artificial intelligence and big data analytics are key enablers for the digital twin technology. So how can we now introduce the digital twins in healthcare? As a first approach, it has been introduced for predictive maintenance of medical equipment and optimization of hospital workflows. General Electric, for example, they have implemented their digital twin for hospital management optimization. Siemens Healthineers also has his implementation. But there has been like a growing interest in building a human digital twin, like the Living Heart developed by Dassault Systems, the Brain Atlas project, the digital twins of some human airways, and some other examples would be the InHeart from InHeart Medical in Pessac, France, that they are developing a cardiac digital twin based on highly detailed segmentation of MR and CT images. But again, here there is like a thin line between what is a virtual twin and what is a digital twin, because you may define this as a digital twin, but you still lack the bidirectional communication. Another example of a company would be Virtonomy in Germany. They develop digital cohorts of designing implantable medical devices, and they simulate highly variable populations for virtual device testing, and their goal is to reduce the time to market and the animal testing and the number of patients in clinical trials. Recently, there has been a European coordinating support action where the aim is to emphasize the development of digital twins, or of virtual digital humans. So if we move forward to what a digital twin in surgery, or what I would expect from a digital twin in surgery, I would expect having my real surgery and my replica of the surgery with the organ behavior and with everything properly modeled. So in order to have this bidirectional communication, we need sensors that track the movement and track what is happening in the actual surgery, but you also need to have some information back from the virtual scene back to the physical system in terms of having this autonomy to operate in the patient. Which ones are the potential benefits of the surgery? Well, we are moving towards a personalized surgical planning. It will definitely help in the real-time decision support. There is enhanced training and risk reduction. The potential benefits for the patients are clear. There is improved patient safety and the outcomes. In terms of predictive maintenance of surgical instruments and optimization of robotic-assisted surgery, and there can be a continuous monitoring and postoperative care. So, as I said before, the key characteristics would be a virtual replica for surgical assistance, the real and the virtual objects and their communications. Also, an important characteristics are the sensors, because we need to use many sensors in order to track these changes in both systems. Then we need to have a good simulation of everything, not only of the organ, but also in the tool and organ interaction. And finally, we need to have an adaptive virtual model. Which are the challenges in this point? Sorry. Well, this sounds very good if we would have a robot which can be properly monitored or which can be properly equipped with sensors, but humans are not equipped with embedded sensors. That's a key challenge. And any medical data describing their status is only extracted from medical examinations. So having the human modeled, it's not an easy task. In most of the cases, we don't have real-time information of the patients whenever we do a surgery. We just have preoperative, we have preoperative images, and we plan the surgery in the preoperative images. But maybe those images were acquired like a month before the surgery, and then you don't have the real state of the patient. So if we were able to somehow adapt the 3D model or the virtual model to the real state of the patient in real time and replan the surgery, that would be very, very beneficial, and that would be like a huge advance for those digital twins. Also, another limiting issue is the real-time processing capacities that we have. Nowadays, we can run some deep learning models in real time, but maybe they are not so powerful to be run in real time for a surgery. Then we also have the limited availability of high-quality data, and for sure, all the ethical and privacy concerns, and the scalability and generalization concerns. So which would be an ideal generation pipeline for a digital twin? Well, we could have, in order to have our virtual model creation, we need to have those organs digitally represented, and we also need some algorithms for simulating their state. Not only having those 3D meshes, but we also need to understand how they should behave. And all this, nowadays, it's easier with all the artificial intelligence and all the deep learning algorithms that has been coming out recently for the segmentation algorithms and for understanding their behavior. Then, in order to have this data flow exchange, we need to have bidirectional updates, and in this part it's really critical to have like the most embedded sensors as possible, but not being exaggerated that avoid the surgery to be performed properly. And finally, we need to have the physical model monitored. The tracking systems need to be good enough to be able to update the virtual model in real time. So in BComTech, what we've been researching in the last years have been some different projects related to all this digital twin creation, but they are not all of them related between them, but they are like small points on the whole pipeline. This was a European project, and we tried to model for breast cancer. We tried to model the breast, and we almost did it properly, but it was like, it wasn't updated in real time. We just have a virtual representation of the breast in order to simulate the deformations and what was going on. Another project in which we've been really involved, and personally I have been more involved in these ones, are those related to spine surgery. This one was for the part of the planning surgery. Okay, I'm finishing. This one was related to planning the spine surgery, and In here, we already were more into detecting the landmarks in real time and being able to reorient the planning trajectories. And finally, we've developed a virtual platform in order to update what was happening during the surgery. We had a 3D phantom, and we had our virtual scene, and we were tracking with the HoloLens the markers. We were displaying the anatomy, and we were all the time sending to the virtual scene what was going on during the surgery. Now we are working on another research line related to pelvic prosthesis placement. And in here, our aim is to not only guide the positioning of the prosthesis placement, but also being able to compute the osteotomy based on the tool resection, on the tool interaction with the bone. So we need to simulate what is happening in terms of analyzing the tool orientation, so we compute the interaction with the bone. And as a conclusion, I would say that digital twins are highly realistic simulations. Oh, sorry. That digital twins are highly realistic simulation of physical processes, updated in real time, capturing the process complete physical state at all the times. Originally, they were developed for industry, but they are more and more, they are entering the healthcare progressively, and the ultimate goal would be to build a whole digital twin. They offer promising benefits to reduce dependence on animal testing, large samples in clinical trials, and trial and error approaches. Also, in drug discovery, they have been used a lot, and for medical device development as well. In surgery, they can be very beneficial for real-time surgery, but not only for that, but also for planning, as in cardiovascular examples, and they are very desirable. Sorry, I cannot. Thank you for everything.
Thank you for the presentation. For the sake of time, we move on to the last scientific session here in this room, and I would call the chairman to come up.
We are going to move to the next session, Revolutioning Surgical Education, Stimulation Ideas to Ignite Learning and Innovation. Our first speaker, and chairman as well, is Jenny Dunkelman, and the title of the presentation is Breaking Barriers to Global Surgery Through Innovations in Education. Jenny, when you want. Thank you.
Okay, thank you very much. Yeah, I would like to tell you a bit what we try to do, how to break the barriers for global surgery through innovation. Well, did you know that about 5 billion people in the world do not have access to safe surgery? And 2 billion people do not have access to surgery at all. If you look at compare it to, for example, to infections, then we see that infection is kind of under control. If you compare it to HIV, malaria, and tuberculosis, then about 4 million people die per year. During COVID, in total, around 6 million people per year. But surgery-related, it's about 17 million deaths per year. And that's the amount of people that live in the Netherlands. They die every year. So that's a huge amount. And the Lancet and the World Bank and the World Health Organization starts alarming, and they indicated that surgical interventions are the most cost-effective interventions in public health intervention in low-resource settings. So, yeah, doing something about that is important. And what also important is that we have to train a lot of surgeons and obstetricians and anesthetists to doing this job. And I know there are a lot of organizations already active in trying to train surgeons, but it's difficult to scale up. So I was wondering, where are the engineers? And where are the biomedical equipment technicians? Where are the engineers trying to support these surgeons working in the low-resource settings? What is needed? Yeah, to increase the global availability of surgery, we need better equipment that's suitable for this setting. Now, what we do, we work on a number of projects. We worked on the top right, top left, you see steerable, affordable, reusable equipment for laparoscopic procedures. Indeed, there's a retractor system developed where you can do cashless laparoscopic procedures. We are working on an affordable camera and lighting system for it, but also on during the procedures, often they have only one set. Dus in between procedures, you have to clean it. We work on cleaning and sterilization equipment, but also on a box where you can put your equipment in and carry it around from one theater to the other, for example. We also work on training devices. This is an example of a training device, specific developed for training fistula repair, which occur a lot in low-resource settings. And the most difficult challenge for us is to find materials or develop materials that can be sutured because you have to suture the bladder, and it should be watertight afterwards. We also work on some other devices, electric surgical unit, affordable one, but also on a reusable and a handheld and a retractor system for difficult deliveries. And there's now a spin-off company making a product out of it. We developed a vacuum system for difficult healing wounds. And we just finished an open access article about this. We put all the information open access, also the file that you need for the 3D printing of the case, so that everyone can build it themselves. And it costs only 300 euros for the materials. And we provide a nice instruction how to build it. But also a needle cutter, that you have not needles. Now often needles they are disposed on waste dumps that you don't want because they are collected again and used again. And also we are looking in the ways how 3D printing can be helping for the lack of spare parts. And what is very important for us is that we develop it in what we call a context, using a context-specific design method. Because in the end, we want to have solutions that fit in the context. So we developed a whole roadmap to do that. I had the opportunity to visit a number of these number of countries and visit a lot of hospitals, and every hospital has its own medical device graveyard. And here you see some pictures. It is known that in about half a year, about 80% of all the equipment is not working again. So also we need to do something else about it. And that is we need to train local biomedical engineers and locally biomedical equipment technicians that can maintain and repair this equipment. And here some organizations already trying to do that. And with the support of the organization like the Examens Institute and TED, we were able to work on a new way of training biomedical equipment technicians, and we developed MOOCs. And MOOC is a massive online open access course, free course. And we developed one for number for biomedical equipment and one for maintenance and repair. And we launched it 3 years ago, and already 15,000 learners enrolled for this course. And that's a huge number, many more than I can do at our university. So, and you see here also how they are distributed all over the world. Recently we started a second course on health technology management, because also how to do the procurement, for example. Also understand the cost of medical devices. It's not only the cost to buy it, but also to maintain it, and about repairing, and about spare parts, and how to dispose it. And this is an example of a mission hospital. They had a whole new theater, and how it was cleaned. And well, this is not how we would do it. So other type of training is also needed. So, and I think we need, innovative training systems for healthcare personnel, but not only surgeons, but everyone working in the operating theater and around. Now, we started now with setting up a training for user training to use the new devices in a safe and an effective way. But also, there are already some companies working on these kind of, trying to make training that can be used to scale up. And that is, for example, Incision, who develops all kind of movements for specific surgical procedures, but also frames that offer 3D videos, interactive, that you can learn all kind of things. And I think many of these tools, we need to use them to be able to scale up. Well, if you think that training of healthcare personnel is only something for lower income settings, well, then you are wrong. This is in the Netherlands. In the Netherlands, it's estimated that we have a shortage of healthcare personnel around 50,000 at this moment. And the result is that we have around 150,000 patients on the waiting list in surgical care. And it is expected if we do nothing, then around 2035 we have around 200,000 shortage of employees. So and our government recognized that, and they launched now, we have a new program. It's called Dutch, Digital United Training Concept for Healthcare, and it's a 120 million euros program. And it's specific for OR personnel, OR nurses, and anesthesiologists and radiologist nurses and assistants. With the aim to increase the training capacity in healthcare, but also together that it not increase the workload of healthcare professionals, but it reduces the workload of healthcare personnel, also during the training. And it should be future-proof and attractive for everyone doing these courses. And how to do that? Well, the plan is that 50% of all the training that the OR nurses and assistants get is in a simulated workplace. Using simulators for clinical decision-making and team training, using VR and AR system, but also digital learning resources like e-learning, but also games to make it attractive. And in the end, it should result in a standardized, safe training that you can do anytime, everywhere, with proven learning activities. And especially the anywhere, that can be really something that can be attractive, because it can also be useful for this training for low resource settings. And maybe we have to tailor them, but I think that the methods that are developed, will be developed, might be also specifically to scale up also in low resource settings. So in conclusion, to break the barriers for global surgery, we need many more engineers and to develop medical devices for the local context. We need to increase education of biomedical engineers and biomedical equipment for maintenance and repair. And we need new methods to train many healthcare professionals in a broad sense for low middle income countries, but also for in the higher income settings. And for that we need to develop more AR and VR methods to train all these people that we will need in the future. Thank you for the attention.
Any question on the floor? Thank you so much for your talk. I think that is very interesting, and I think that is need to break the barriers and to arrive in the training. I think that what the most important aspect, in my opinion, is to create innovation training systems that the less favored countries can apply it, because when we go to these countries, it's really a challenge and to finish a surgical procedure, because there are not specific material and the training of the surgeon is not proper. So I agree with you that the technology needs to help these surgeons and to increase the ability and the capacity for training and for performing the surgery. So it's a very good initiative. I congratulate you, but I think that is very difficult because the medical devices and the medical material is very expensive. So I think that is a challenge, really.
There's really challenges, but if you as engineer try to come with affordable solutions, and I know we sometimes will want to say a nail in the eyes of the big medical companies, because for many of the devices does not need to be that expensive anymore. They are a long time on the market. There's no patents anymore, but you can copy them somehow and make it affordable. And we need new solutions to make a lot of things also reusable. But there are hardly any engineers working for this specific goal, and while the need is so high, and that's for me why I think so important that we try to motivate more engineers working in this area.
Very interesting. Any comments on the floor? No? Thank you so much.
Okay, then I would like to introduce the second speaker, my co-chair, Alberto Budia, on presenting how ISMIT learning and innovation in surgical education at the tertiary public hospital. And especially talking about the main drawbacks. It's very interesting to hear about that.
Good afternoon, everybody. Thank you so much to the organization for your kind invitation. It's a pleasure for me to come back to Cáceres and to come back to this center. It's really very nice and to find and to meet and with all friends. I'm going to try to answer the question, how ignite learning and innovation in surgical education? Because, as you know, nowadays we are living exciting technology development in many fields of knowledge, including or even in our daily activities. As you can see, sometimes go to the bathroom could be a complex process. Entonces, if you look at the image, you can see many buttons for using a bathroom. Or sometimes you can find robotic technology in many stores like Starbucks in Shanghai. So the technology is yet in our daily activity. And in the surgical environment, the technology has changed a lot the way of performing surgeries, because nowadays we have reduced the invasiveness of our procedure, we have reduced the hospitalization length, and we have reduced as well the recovery period of our patients. But it involves as well a change in the surgical educations of the novel surgeons. But when the technology go quickly, I like it's interesting for me to have a look back, because not many years ago, most surgeries were performed using open procedure. So when I started my residence, I studied the surgery in all books of surgery in which they describe the different steps of the surgical procedure. And if we were lucky, we can get a low quality recorded video of the surgery in this type of devices that is history today. And nowadays, last month, Dr. Breda from Fundación Pujoler performed the first telesurgery with robotic surgery. He was in Burdeos and the patient in Beijing, and it was successful procedure with a telesurgery of robotic. So the technology allows us to practice a surgery with more than 10,000 kilometers of distance. But all advances in technology involves a reform and change in the education and process. And in my opinion, it's not only a change, it's really a chance and, of course, a challenge for us. Because we have many drawbacks. For example, we have the main drawbacks, in my opinion, is the high cost of the technology and, of course, the generational gap that we have today. Because the novel surgeons is a technical or technological generation, and the surgeons that have to teach them is a paper generation. So we have a gap, and for the new generation, the works of work, effort, have different concepts than is evaluated for the senior surgeons. Of course, technology is developing with a high speed, and many times we don't have enough time to adopt it or to know it or to know them. So it's not possible to adopt the new technology in our clinical practice. Is the main drawback in a public hospital is the high cost. And the new technology is expensive, has a high cost, and so it's very difficult to adopt it. And usually in the public hospitals, we go behind the new technology because the high cost of that difficult a lot the adoption of this technology. And finally, it's possible that in public hospital there are a resistance to change. Some surgeon teams have a very good results or very good outcomes with classic procedure, have a low rate of complications, and they are in the comfortable area in their work. So it shows a resistance to change, because they have to pass for hard learning curves with the new technology, and sometimes they are so lazy for that because they have the classic technique or the classic procedure works very well in their hands. So the key question is how ignite the learning and innovation in surgical education. And in my opinion, the success and way for that is to facilitate a structured training program for our surgeons. It's important to identify the training pathways in our departments and focus on the most important for me is the surgeon, of course. So, entonces que for adopting complex technology as robotic technology in our department and in our field, I think that you have to facilitate the acquisition of neuroplasticity with automatisms. Is to say, is to repeat the movements. And it's important as well to facilitate the acquisition of the capacity of separate the complex movements in steps, in easy steps, a sequence of easy steps, because it facilitates a lot the learning or the learning process of complex surgery. And it's important as well that all this process has been developed in or has to be developed in a safe environment. Safe environment for the surgeon and safe environment as well for the patient. So, the first step in the process of learning a complex surgery as robotic surgery is this one. Is, as you can see, is a virtual simulation of simple tasks that allow to the surgeon to practice in a virtual simulation using needles and, for example, adapting exercise to the surgery that he is going to perform. And so we have different tasks that you can adapt to training program depending on your specialty or depending on the surgical procedure that you are going to perform. As well, this simulation system allows you to select different instruments that you can have in your daily clinical practice. You can stitch, practice stitch all of them in a virtual system and adapt the exercise depending on the level of the surgeon and the type of surgery that he is going to perform, as you can see. So it's exercise of precision, exercise and all of them that try to increase the capacity of the surgeon to use this system. And one of the most important things is that these simulation systems allow us to obtain a score that you can see the progression over the time according to the number of procedure that you are going in the system, that you are performing in the system. So you can record the score and see your progression over the time. The next step is to make the same exercise but with the real robotic system as you can see in this system. This is the SP model of Da Vinci robotic, and as you can see, you can practice with the real robotic systems, making the same exercise that you have practiced before in the simulator model. The next step is to practice the robotic surgery in a pelvic trainer in the same way. We are increasing the level of difficulty, and in this case, it simulates the human body. The next step is to perform a virtual surgery. It's a virtual reality of a cholecystectomy, and in this case, you can practice in this virtual system using different instruments to practice the surgery with a standard anatomic model. And so you can obtain as well a score, and you can see the progression in your score when you repeat the movements and repeat the surgery. The next step is to use an animal model. Usual for kidney and surgery, we use the porcine model. And so you can see like you can perform a live surgery with a live animal, and so you can practice for the next step, that is to practice in patients. And for that, the technology allows us the opportunity to connect with an expert And so you are performing a surgical procedure, and you can connect entonces, with an expert entonces, that can see the procedure or the specific steps of the surgery and can advise you or can supervise entonces, the surgery with a direct entonces, connection is entonces, called teleasistencia. But artificial intelligence entonces, gives us entonces, many opportunities. Entonces, has increased the capacity of detection of disease, have improved the predictions models entonces, of entonces, risk in our illness, have improved as well the follow-up entonces, system, and of course can optimize the surgical procedure because entonces, as you can see in this image, entonces, different systems entonces, can record entonces, the surgery, can send the surgery to the iCloud or the iCloud sent to CLAD, and the CLAD is score entonces, your surgery and give you a feedback about the score that you have obtained and the position in the ranking of all the surgeries that they have recorded or they have stored. And therefore, identify the key steps during the procedure, the surgical procedure, that need to be reinforced. So it's entonces, a feedback system that increase the quality of the surgery and identify the key points that need to be reinforced entonces, for the surgeon. And the last step entonces, occur last entonces, month with the tele-surgery that I have said before with Dr. Breda. But sometimes the technology is not so complex that needs a complex entonces, training program. Sometimes entonces, technology allow us to make easier a process. For example, entonces, the puncture of percutaneous surgery, with the challenge is to make a perfect entonces, puncture. These systems allow us entonces, to make a real fusion with the CT image and the real sonography, and allow us to make a perfect puncture in less than 1 minute. Or, for example, the image, entonces, fusion with the MRI and the real ultrasound of the prostate that allows in only 5 or 6 minutes to make a fusion and perform the biopsy. So, for conclusion, I think that if we want to ignite the learning and innovation in surgical, I think that we have to design structured training programs and develop that in safe environments for the surgeon. Thank you so much for your attention.
Thank you very much. This is a bit the other sides of the activity that we are working. Are there any questions from the audience? A small question. You indicated this, and the technology is still, you need a lot of training. I think the idea is to add more technology. Do you think there's a certain moment that you have to step back and say, okay, maybe we have to think over again the whole use of robotic systems, and then do a step back in complexity to improve the training or make the training a little bit more easier? Do you think it's a certain moment that we have to go back in adding and more technology?
I think that the training is necessary for all type of procedure or surgical procedure, because many years ago, when a technology arrives, we don't have these training programs. We started with the technology in the human, and it was called human training. Yeah. So I think that for all new technology, for all new procedure, it should design a training program, and the surgeon, before practicing this technology, should obtain a capacity for that. I think that is the future. I think that is the way that we have to develop in all all
so you have to
surgical
follow
procedure.
everything.
Yeah, to follow. I think
training.
that really
And training
is,
should follow in the same speed.
Yeah, I think so.
Okay, thank you very much. And the next speaker is, everybody knows him, of course, is Goan Sanchez Magallo, the president of the, it's mine again. The email that was sent around was also this class, sorry for that. Goan, please give your presentation on extended reality for minimally invasive surgical training.
Thank you very much, Danny. Hello everyone, good afternoon, good evening. It's a pleasure to be here and a pleasure to be in this session. I think it's a very, very important, interesting session, especially because it's related to the application of technology innovation in the field of medical or surgical training in this case. So it's a very hot topic and a very, very important topic, especially for a center like this that is dedicated for training and innovation and technology applied to training. So we already know all the technical challenges, all the problems that we have with technical complexity that we have with surgery, especially when a surgeon, a medical student has to train like a new skills, technical skill, cognitive skills. There is also like a limited practical exposure in training programs. We already saw some examples about how to introduce like new models, new steps, and new tools in order to learn those skills. And also it's like another question, another topic that is very challenging is how to assess those skills, those knowledge. So that, and of course, that is something that we already mentioned, that Professor Duncan mentioned at the beginning, is like there are limited economic resources and we need to find a way in order to have something more economically viable. So, some options in order to address this problem is to have a multifaceted approach. It's, basically, is to enhance the training technologies, to use new tools, new developments, new ideas, improve access to the training resources and opportunities. Let's see how we can use some examples, how we can apply like the use of extended reality. We know extended reality is basically it sounds like it has like a name, a strange name, extended reality. What's that? Well, we have a virtual reality. On one side, we have like augmented reality, and on the other side, we have something that is in between, that is mixed reality. That's something that we already know right now with the use of HoloLens and also with the new glasses from Apple. That's basically just is to enhance the vision, the real environment that we have with new information, with just to have realistic virtual scenarios, to have enhanced training guidance, and also to provide training and cognitive skills rehearsal using like a new tool, new virtual tools. Let's going to start with the use of virtual reality in medical diagnosis. So this is an example that we obtained from a project that we were working together with some of the colleagues that are like in this congress. So in this case, it was developed mainly by the Polytechnic University of Madrid, and also in collaboration with our center and also with other centers like from this project. The project is called Mireia. So the idea of this project is to bring together like different technologies, like virtual reality, mixed reality, and also 3D printing in order to provide new tools for medical training. In this case, it's just it's a tool, a virtual reality tool, in order to train like a diagnosis of colon lesions and also colon anatomy. This is based on virtual reality environment, so using virtual reality glasses. So that's the main idea of this technology. Let's gonna go to a different use of this technology, of the use of virtual reality technology. This is an example from SINTAF, a Santos Lab hospital, that also they have like they were presenting some examples and some research results during the different sessions that we had in this congress. In this case, the idea was just to combine the use of virtual reality, the use of electromagnetic tracker, and also to the realistic model obtained from a patient using a CT scan, that it was embedded inside a system, combining the use of the electromagnetic tracker and the use of the 3D model based from the patient in order to provide a learning tool, in order to provide a guidance during the learning process. This is another example that was already mentioned before, like a virtual reality environment in order to learn how to use the basic steps of robotic surgery. So we have like different options. In this case, it was like provided by SimNow, that is a brand from Intuitive Surgical, that you know the brand that is for the Da Vinci system. This virtual reality scenario, this virtual reality system has like objective assessment, with a lot of scientific paper and a lot of scientific background, just providing like scientific reports about the use of that system. So it's scientifically approved. This is another example. This is from a project that we developed in our center. This is an example of how to create a 3D virtual reality system in order to learn a new robotic platform. In this case, the Versus. There is a kind of a different platform than the conventional one that is the Da Vinci. The idea is just to have a virtual reality and safe environment in order to train those skills, those basic skills. This is another option. There is to create a virtual reality or to provide a virtual reality environment for training the operating team, the OR team. Not only the main surgeon, but also the assistant nurse, all the team that is involved in the performance of the surgery, and mainly for certain technical or challenging parts, like can be like the patient positioning, robotic docking, and also some surgical port placement in certain specific surgical procedure. This is another application of virtual reality. In this case, it's gamification. What's gamification? It's the use of basically to create like an environment, like a fun environment, just to, well, it's kind of a game, but you can learn you can learn like some skills that can be transferred to the real scenario. So that's transferable skills. So maybe it can be like a technical mainly and cognitive skills. Well, let's move on to the mixed reality. Mainly, we can use mixed reality, for example, for anatomical training. This is an example that we developed here. There is a basic example, and you can have like muscular, vascular, bone, and nervous system, just basically to learn like a basic anatomical knowledge, so that you can have like more details about the different organs and the different parts, anatomical parts. This is another example of the use of mixed reality. In this case, it's also for anatomical learning and also for diagnostic training. In this case, like the medical student and the resident can learn how to diagnose like a colon lesion and also the different parts and the different anatomical part of a colon. This is an example from one colleague from the Oslo University Hospital. They developed a holographic method, an holographic system, how to learn the anatomic understanding of complex congenital heart defect, mainly applied to pediatric surgery, to pediatric patients. This is the next sample that we can get. That is just a combination for all of them, all this kind of technology. So we have the metaverse. The metaverse is something that is like a kind of difficult to understand, because it's a combination of augmented reality, mixed reality, digital twins that also we had a presentation before, artificial intelligence. It's like something like a parallel of our real world. In this case, it's like just to have like a virtual world with the different options and combining the different state-of-the-art technology. So in conclusion, just to be brief, it's like extended reality are becoming an integral part of a model surgical training, offering both educational and practical benefits. It could help surgeons to improve their spatial awareness of anatomical landmarks, learning to certain operating times, and reduce surgical errors in certain cases. Virtual reality is also considered one of the most cost-effective methods for surgical training. That's something that we mentioned, about like how to create like something that can be affordable, especially like knowing that right now it's like the price of devices like virtual reality glasses are not as expensive as in the past. And providing a safe and controlled environment. The safe and controlled environment was something that was mentioned also before. That is something that we require for the medical training and surgical training. And finally, the use of extended reality technology has been shown to boost surgeon confidence when they have to address a complex surgical procedure. Thank you so much.
Any question on the floor? Jen?
Thank you very much, Juan. I think that for your anatomical models, they are really amazing. For trained surgery, and especially if you want to do tissue manipulation, then haptics is indeed a challenging issue. Do you think that at a certain moment also in VR, also the haptics can be solved, or is it still something that we should solve in a different way, or something in between that you have something on physical solutions still needed for the haptic feeling?
Definitely, this is like they demand that technology, that kind of technology a lot. But the problem is like the haptic feedback technology is going around and around and around, and maybe I think it's something that is pending to be solved. Well, it's you work a lot in the haptic feedback, and you and your team. It's like something that it's we need to find a way in order to afford that with something affordable and something that they can use like with the new devices for virtual reality and augmented reality. And definitely, I think that's my opinion. I think that's something very, very important because we always have haptic feedback when you use a laparoscopic instrument, when you use an open approach. Of course, with robotic surgery, it's not like that, but because they need to find a way, a nice way to introduce haptic feedback inside the robotic surgery. Maybe we know some example like the same hands. It has like a haptic feedback. The rest are working on that. So hopefully in the future, I think they will find a realistic way in order to provide haptic feedback. I hope so.
Yeah, thank you very much.
In your opinion, which is the future? In your opinion, which is the future in virtual reality for the surgeons? What are you seeing in the future for us?
Well, that's a difficult question, but I think it's a combination because it's like that's my opinion. Like virtual reality is really good for anatomical training for medical students, but when you go into the OR, that's a completely different environment. Yeah. So you cannot be blind. You need something like mixed reality. I think that's amazing. We need something less cumbersome than the glasses that we have right now, but I think that's going to be the future. Maybe the future will be just regular glasses that it can provide like enhanced visualization during the training of residents, during their surgical residency, or maybe medical students while they are doing their regular job, when they are doing their regular activity, just improving or providing more information just to enhance the knowledge that they are receiving at that moment. So I think could be a possibility.
Okay, thank you. It's a difficult question. I know it.
Thank you.
Okay, then let's continue with the final presentation of the conference, and the honor is to Andrea Lorenz from ISMIT in Austria, from molding to silicone 3D printing, functional anatomical models for surgical training and beyond. Please go ahead.
So thank you very much for the introduction. From the virtual models, we now go to the real physical haptic models. Oh yes, here it is. I'm Andrea Lorenz, and I come from the Austrian Center for Medical Innovation and Technology in Neustadt, Austria. And if you have seen my presentation yesterday, you've already seen where basically we come from, or where our interest in anatomical models comes from. So I was speaking about the anatomical training model for an endoscopic negative pressure system in the GI tract. And this was actually a pretty good example for a development of ISMIT because we supported this partner during the development of medical device, and then the need for a model came up. Sometimes this is for testing, and in this case it was for training and teaching and demonstration. And often it is like it starts with testing and then it goes on with the training. And yes, so I want to give you just one slide on our institution. So we are a non-profit research and development center for medical technology with a huge network. We work with many partners from science and industry, and we are in the translational research field. So we're application-oriented and try to really get the idea also on the market into the clinical use, and that's where we are also certified. We contributed to many systems that actually are already on the market that you might know, but you might not know that we were involved. So my part in ISMIT, I'm responsible for the anatomical models. To come back to the topic, we are developing functional haptic anatomical models for, as I said, all kinds of purposes, starting from medical device development, continuing with training and surgical planning. And we're using all kinds of technologies from silicon molding, 3D printing, and we even developed new a method for multi-material 3D printing. And today I'll give you a few examples of some models we actually developed. So this is an example of a model for pelvic fracture reconstruction. The clinical application was actually a pelvic fracture surgery, in particular for training of the modified stop approach, which is kind of complicated because there are many critical structures basically in the way. And yeah, the model was used for training and also for demonstration of this procedure. And yeah, we were using like the common design and fabrication methods. We performed image segmentation, we printed some molds, did some silicone molding for the soft parts, and in this case we were just buying a phantom for the bone. The next use case here is a kidney model for a PCNL procedure. Actually, I got the name wrong here. It's a percutaneous nephrolithiasis. I think it's a kidney stone removal. But we also developed this for training and testing purposes. And the challenges here was that this was performed under ultrasound images, and so it had to be like flooded, and all the structures had to be visible inside of this. And we were basically using the same procedures as before, just that we also 3D printed the bone parts here. This is a little bit of a different example. This is a thorax phantom. We were actually developing for thorax imaging procedures, and it was used for the evaluation of image-based procedures. And we were focusing on the bony parts here, and we wanted to particularly account for different Hansfeld units in different parts of the bone. And this was all done with very simple 3D printing, or filament 3D printing in multiple parts. We did some property tuning before, and we could get real impressive results, in my opinion, with a very similar image. Yeah, so some preliminary conclusions. We developed some phantoms for different clinical application purposes in medical device development, evaluation and testing, but also for training and teaching. And we always used kind of similar procedures, which was like image segmentation, 3D printing of the hard parts, 3D printing of the molds, and silicone molding of the soft parts. And we always, in addition to the specific challenges, we always had the same common challenges regarding the model development. So it was a lot of effort and time consuming. In particular, in addition to image segmentation, the fabrication of the molds, the design of the molds, We always had difficulties connecting the hard and soft parts. And of course, we were restricted in the mechanical properties. So silicons normally are not as viscous as most of the soft tissues. They're easily tearing, and they're also isotropic, and most tissues are not isotropic. So we thought we could maybe help ourselves and develop a multi-material printer where we could actually combine the printing of the hard parts and printing of soft parts as well. So we assessed the standard filament printer with additional print heads for fluid extrusion, where we could print 2-component or 1-component silicons. And we wanted to use this, as I already said, to additionally print the soft tissue with the silicon printer at the same time as the hard tissue with the filament printer. And also, we tried to enable some property tuning with this printer. For example, we were trying to achieve some, we called it up tuning of the material, which means increasing of mechanical stability of the tissue by implementation of some fibers. We did some testing with fibers in the silicons. Also achieved some quite nice results, but we actually worked further on the other technology, which was the down tuning, which we used to decrease the viscosity by the inclusion of some fluid. So we had most of our printing silicons were actually 1 component. So we had a spare print head, and we filled this with silicone oil and basically filled up the empty spaces with silicone oil. And we got really good results regarding the viscosity. And we even printed a first a very small use case of a down-tuned and downscaled liver. Here I have some more example where we actually combined all these technologies. This is a phantom for the pleura punction of a premature baby for pneumothorax treatment. It was used, or it is still used for training. The challenge here is the very tiny structures. And here we actually combined the technologies by adding some silicone-printed internal parts. The rest was still fabricated as before. We actually also tried printing the rib cage part. You can see it here. But we were not able, because this was like the first trial, we were able to print this, but we didn't manage to make it small enough for this application. So in the future, I'm very sure that we will manage that as well. So you can see here a few more different parts we already printed with our printer, using different combinations of mixing the filament printed bone with some soft tissue around, using some different silicons, as you see here, for different hardnesses or properties, mechanical properties of the material. Here is the fluid-filled liver. This is part of a scaphoid fraction model. This is a near model with a flexible filament inside, which is kind of mimicking the cartilage. Here's a bladder to demonstrate that we can actually also print some hollow structures. And this is an example where we actually printed the molding silicons with 2 components, so that which is much cheaper, and which we can also print with larger nozzles and then maybe also larger models. And we did another example for this image property tuning, now including multiple soft tissues, and we also could achieve excellent results. Basically, we can print a whole range of human tissue with our materials. So, let me summarize. We were developing a lot of functional anatomical models, combining molded silicons with printed bones, and using also printed molds, and we could achieve quite good results from this for multiple clinical application, but we wanted to go a step further and develop the multi-material silicon and filament printer, where we could edit quite some advantages. So we could improve the abilities for material tuning, add some viscosity or anisotropic properties. We could also get a more stable connection because we can directly print in each other, and actually the materials also were connecting pretty well, at least some. We increased the options for the imaging phantoms. We can further increase this by using the fluid filling as well. And theoretically, we would get faster procedures by leaving out the mold design. But there are still some open challenges, of course. So as this is a more complex printing process, of course, it's not always so fast that you just send the segmented images to the printer. You also need to do some optimizations, and I think there is some more work needed also on getting a more standardized process for this so that it works easier for new applications. So it works pretty well, but it's a little bit more like effort than in a standard filament printer. And of course, highly depending on geometry, materials, etc. And of course, to get full advantage of the fiber inclusion, we would also need to integrate the kind of a non-planar slicing because the fibers, unfortunately, are not always planar. And one actually big challenge is also the coloring because these materials are so highly viscous, we cannot just mix it in. It's basically like also with the filament printer, you need different nozzles for different colors. So yes. So I would say that this new method is quite promising, but further research is needed. And we always need to find the best technique, application specific. And it is, of course, not always the silicon printing as you could see in this example, but it can be for some applications, of course, it also is. An improved way of fabrication of these anatomical models. So thank you very much for your attention. And yeah, if you want to know more, some of the models you actually can buy in our shop. Or if you want something similar, you can also email me if you're interested in cooperation. Thank you very much.
Thank you so much for the presentation. Any question from the floor?
I have a small question. I know that making this, especially the soft tissues, is very difficult. You use different materials, inhomogeneous material. Did you research that as well? Or is it most of the materials homogeneous, what you develop for soft tissues?
I mean, the material, the silicons are homogeneous, but if you print fibers inside or if you mix kind of the materials, then yeah.
And did you study how to mix the fibers to get the right properties?
I mean, we started a little, but we did not go very far with this because we realized that actually if we really want to get an advantage, we need the non-planar slicing as well, and this is another different story. So for this project that we had here for the development, we focus more on this other option, which we call down tuning, and printed some fluid inside. But yeah, I mean, in the samples we produced, we could of course change the properties, but we're still using artificial materials with different general behavior than tissues. So we need to think a little bit further, I think. Yeah.
More is to be done.
Yeah,
okay,
more work to be done. Thank you.
Thank you so much. I think that it's very difficult to build these models, but I'm a urologist, and we used very times the kidney models for kidney tumors. It's important for us in complex cases and to know the depth of the tumor in order to plan a conservative surgery or not. And for novel surgery, nephrolithotomy percutaneous surgery is very important in order to know the vascularization of the kidney and the best point to go into the collecting system according to the characteristics of the stone. So I think that it's very useful for us when we have very complex cases. So thank you so much for your research.
Thank you for the feedback. Thank you.
Okay, we finish this roundtable with a bit delay, so we invite the next table to come here. Thank you so much.
Yeah, thank you. And please stay, because I think we will have now the General Assembly over here, and after that, the closing ceremony.
Yeah. As member, you're more than welcome, or you should leave. Okay. So first subject, when we get this Zoom, dann brauchen wir das wahrscheinlich doch aufgeklappt, oder? Nee, das ist genau richtig. Weil da muss ja das Zoom auf dem Monitor sein. So we need the Zoom meeting. So can you connect to the Zoom meeting? Da ich Zoom hasse, weiß ich jetzt nicht, was ich jetzt hier alles mache.
Alles ganz normal.
Haben die den Link zum Zoom-Meeting? So can you connect to the Zoom meeting? Okay. So Jetzt kann ich ja nichts machen. Wir haben keine, oder hast du die Agenda rumgegeben?
Ja, die haben
Do you have the agenda in your hands? Okay, then we can go on. So first subject is approval of the agenda. Are there any further suggestions, modifications? It's not the case, so I consider the agenda approved. Then the approval of the minutes from the last General Assembly. Is there any comment, concern, correction? Okay, then here with the minutes of the last General Assembly, October 20, 2023 in Lukang have been approved. And we still have no image here. Excellent.
very good.
So then we have the society status with
Yeah.
Christina.
I just say a few words concerning the number of members. We have right now 59 standard members, wherefrom 43 paid and 2 paid associate members, no block members. So, so there are still some of the members which are on the list that are not.
So for those who are not members, you should consider to become a member of our exciting society. And we have a bit of a list here, what Leon just mentioned. Professional network is already available and will be improved to social media activity. And you have some benefits here, and there's a barcode for joining it. Okay, with some benefit. Okay, and we have a LinkedIn group. Yeah, so Juan, I think your turn now.
Okay, let's gonna start with the closing ceremony.
Yeah.
Okay.
I think that's what Father.
Thank you, everyone. Thank you for being here. It's my pleasure to start the closing ceremony. I think it's like this is the end of very hard work during these 2 days. It's been a real pleasure to have all of you here, friends, colleagues. It's share knowledge, share experiences, a lot of nice presentations. Maybe. I'm gonna check. Yeah, maybe we can wait. Sure. Oh, they are coming. Let's gonna wait. I'm gonna double check if you want. Yeah. There's still some presentation in the other auditorium.
Okay, then let's wait.
Let's wait for
this.
them. It would be great just to have more people around if you think it's okay.
No, it should be like that. We have our General Assembly and now it's closing and everyone should be here. Yeah? So whoever wants to be here. Okay, a small bio break until they finish the presentations.
Change what they're doing here. But that website is live now. So.
Yours.
Okay, we just switch back and forth.
short presentation.
Okay.
Yeah, okay. Hi, everybody. Before we start our closing ceremony, I just want to put your attention to the ISMIT membership. So, as you know, the conference is in part a collaboration with the ISMIT Association, and I would like to invite you to become a member of this professional network. And what does this membership and this network bring with it? It's a professional network of medical and technical experts, which you can be a part of and have easier access to publish in a high-impact journal, which is the MITAT journal. On the other hand, you have the opportunity to get a reduced fee for congresses and in early access. So if you are interested to join ISMIT conferences the next year, it's going to be in Washington. You'll be able to get now a $50 off for this conference, and on the other hand, get all the other benefits by following this link and becoming a full ISMIT member. If the QR code is not working or you want to take your time thinking about it, just join our table and you can fill out this form. And something I'll give you for free is the ability to connect with us on LinkedIn. And there we give you all the latest news on the society and the coming conferences. Thank you. And now, over to you.
Okay, thank you very much. Okay, during 2 days, we organized different activities. We saw different presentations, discussions, live surgery, parallel activities with the Spanish Society of Biomedical Engineering, Spanish Society of Laparoscopic Surgery and Robotics, or other activities, the Spanish Society of Surgery. I hope you can enjoy these activities. This is the end of this ISMIT 2024. We will work with our colleagues for the next Congress in USA in 2025. No more. Thank you very much for to being here. Thank you very much for being in Cáceres in this center. See you in the next Congress. Thank you very much.
Okay, we are going to move on to the most exciting part, that is to give the awards to the best presentations. To the presentation for the best poster sessions, and all of them have been amazing. So it's been a real pleasure to be with you guys these 2 days. And it's, well, now it's, the idea is just to give the best presentation. We have like, we're going to go from John Investigation Award. We are going to go as well for the Advanced Technology Award and for the OR Ready Award. It's our pleasure to give the presentation for the John Investigator Award to
Juliana Manrique Córdoba.
For the presentation of key point generation from surgical trajectory towards machine learning implementation. Please.
Is here.
Can we have a photo here?
Okay, thank you. Well, the second award is Advanced Technology Award to
Senenchu Lanceros Mendez.
For electroactive materials in the scope of biomedical applications, from biomedical monitoring and actuation to advanced tissue regeneration strategies.
Congratulations.
Congratulations. ¿The foto?
Sí, sí, sí. Qué inesperado y qué más. Gracias, espectacular.
Gracias a ti por el trabajo.
Okay, the last OR award is a OR Ready Award is for
Teddy Binkel.
For the presentation of the radical revocation safety in the intervention operating theater, the active feedback enables timely precautions.
It's funded by our prestigious member, Malvetta.
Congratulations.
Thank you very much. Congratulations. Please. So, very much.
Let's move on to the poster awards. For the third poster prize is to
Eoin Higgins.
For the award shape sensing inflexible and articulated instrument using two-wire multi-sensor magnetic navigation. I don't know, maybe he is here, or maybe one of the members of his team. No?
Anyone from the team?
Yeah.
Okay.
So no prize.
We will send the prize like
Okay.
by post email. Let's move on to the second poster prize. It's to
Tim Horeman.
Advancing minimally invasive surgery, a force-sensitive laparoscopic grasper for delicate tissue handling.
No.
Tim is not here. He had to travel to Gulf, but maybe somebody. Professor Dankelman.
Dankelman. Jenny. Thank you, Jenny.
And the last but not least is the first poster prize to
Patricia Sanchez Gonzalez.
For enhancing neonatal care proficiency, evaluating the effectiveness of Simuneo, a realistic simulator for critical clinical scenarios.
She's not here.
She is not here. She is there from the Polytechnic University of Madrid, so we will send the award to her. Thank you very much. Thank you to all of you. Thank you to all of you for amazing work, amazing jobs, and all the oral and poster presentation. So, the next step, it's
thanking from the society to
Yeah.
help also this hard work.
Thank you very much.
Thank you. So we have the presentation for the next meeting that is gonna be is gonna be in Washington. So let's give you that. Please take a picture.
Past president and new president.
The new president for the next year.
Okay. Yeah. Hold it in the back. Feels like a bib.
Better?
Better fit.
Much better fit, right?
Yeah.
Cool.
Perfecto. Okay.
So,
Okay.
thank you so much. That's your turn.
So,
Kevin.
how can I get this screen now up on the,
Right now,
on the
could we
computer?
see this?
Yeah.
Oh. Yeah, here it is.
Yeah, perfecto. Okay, great, okay. Yeah, thank you very much, Juan. Thank you, Miguel, for really a fantastic presentation here and seeing the town. I still can't pronounce it right, Caceres or Caceres. I'm sure I'm not pronouncing it right, but I look forward to welcoming you next year in Washington, D.C. Let me just see if I can navigate this website here. 222 links. Okay, it's going to be a little tough because, but anyway, we're going to be October 10th to 11th in Washington, D.C., and I work at the Children's National Hospital there, so we are right in the middle of the city. The conference is just outside the city with very easy access to the city. These are my colleagues. Dr. Sandler is our chief of surgery. Kalali is our tech transfer and innovation lead. So the event is now starting, it looks like, in 376 days right here, so a little bit more than a year. And then the theme of the conference here is reimagining the future of surgery. So very similar to what we've done here so far. And then in terms of, let's see if I can get over here. And yeah, so abstract submissions are going to be very similar right here. Some conference information right here about the key dates. The registration will open January 1st here. So we'll keep it open till just before, but of course the earlier the better. And the abstracts will go live on January 1st. And then here is, we're going to have a satellite event on the Sunday. We'll have a tour of our hospital group. So we have a research group physically located in the hospital. There won't be any charge for that tour, but you'll have to register in advance here. And then finally right here, a little bit about the venue. So this is a conference center just outside Washington, D.C., but has a direct subway connection into the city, the North Marriott Conference Center. And the conference center hotel is physically connected, so it'll just be walking across. We have a large space here for the plenary sessions here, and then a large exhibit hall right here where the food and drinks breaks will be held too. I'll be looking for sponsors. If you have any idea, let me know, and we'll have a poster session in this area. And then the program right now that we've started putting together right now is a 2-day program with very similar sessions that we're having right here, as well as the named lectures on the Thursday night. It'll be Friday, Saturday this time, Friday, Saturday meeting. And the opening session will have a reception and then a dinner as well, with Sunday being the hospital tour. And then there's a little bit of information about travel and stay. Booking is very easy. I can't require you to stay at the conference hotel, but I need you to stay at the conference hotel. So we put strongly recommended. The rate is actually quite good for Washington, D.C., $179, except plus tax. Unfortunately, in the U.S., we always charge extras like that. But it's a very nice hotel, very close, and so hopefully you can come and spend a few extra days and see Washington, D.C. as well. And then we do have 3 airports in Washington, D.C., but the international airports are going to be Dulles Airport and Baltimore Washington International with good connections. So that's really kind of a summary of things, and I look forward to seeing everyone there. And I have some flyers as well. If anybody would like, I have a little flyers. I even wore our hospital tie with our bear logo today, so you can see the bear logo as well, which is our mascot. And I think this has really been a great meeting for the collaboration between engineers, clinicians, and scientists. And I hope we can keep it up next year and for many more years to come. So thanks for the organizers for a great meeting. And that's all I have. And does anybody else have anything, or do we just conclude? Okay, that's it, everybody. Yep.